Hello, Harshad.
Hi John, good morning.
How are you doing, Harshad?
I'm fine. When are you starting?
Are you at work? We start in about 10 minutes.
Yeah, yeah, 10 minutes. Okay. Yeah, I'm at work.
Oh, okay.
Yeah, I'll join you in 10 minutes. Yeah,
Okay, see you.
thanks.
Hmm. Hello, Nick. Hello, Uday. Oh, Nick, you're not coming in, huh?
Dear John,
Yes.
I am Nick.
Who's that? Uday?
I'm your friend Nick. How are you, my friend?
Oh, Nick, how you doing? You're not coming in, huh?
Yes, it is a very interesting meeting. Compliments, John.
Yeah, you coming in the panel or no?
If you want to invite me, it will be a great pleasure.
Okay, I'll let you come in if you want.
Oh, nice to see you, dear John. You are like the Greek ancient god Zeus, the king of the gods.
Oh my God. I want to go to Greece and go to all the temples.
Yes, okay.
Yeah, well, I wrote a book on Greek mythology.
Did you have it in electronic version in order to send it to me?
No, I don't. I have to work on it. I have to work on it because it's a lifelong thing. I really want to go over there to see the original sites of a lot of the Greek runes, which are a lot of them are about the myths. You know that.
Yes.
So
Okay.
I would love to go to Apollo, Delphi. I went to a few places in Naxos. There's a couple of places there where they built. I didn't know they actually built those on the Greek islands, the statues.
Yes.
Yeah, and then they would move them after they built them.
Yes. Okay, John. It will be a great pleasure to listen this webinar about Gazi Yaşargil. I met him. It was very inspiring.
You met him in Turkey?
No. I have met in various congresses and also in Turkey many times.
Oh, okay. So you used to go to the conferences.
Yes. Okay.
Kiki, the first speaker.
Okay. Thank you very much, John. I will
Yeah, sure.
see
You're
you.
welcome, Nick. You're welcome.
Okay. Thank you very much, dear friend.
John, as the first speaker joined. No,
Yeah,
Kiki Turel.
yeah, Kiki is here.
I don't know. I'm not seeing his name there. If no, he has joined. Kiki has joined. Yeah.
Hi. Hello.
Kiki, happy birthday, Kiki. Ah, what a
Thank you.
great day.
Thank you.
Yeah.
Thank
Yeah,
you.
yeah, I was
Yeah.
going to call you.
How you doing, Kiki?
Hi, John. How are you? Seeing you after a long time.
Kiki, this is actually a birthday party for Kiki.
Yeah,
Yes,
yeah, yeah.
yeah.
Young at 80. He's young at
It's
80.
not Yasergil's memorial, it's Kiki's birthday.
Yeah, yeah. What a day.
Professor Suresh Nair is a exalted library. Looks very impressive.
No, no, no. It's not my library, Kiki. I told you, I am at my in-law's place. My
Yeah.
mother-in-law passed away. So I am at
Yeah.
Jabalpur. That's why I cannot join. Today evening only is a dinner meeting, no? Or it got over yesterday.
Yes. So please, no. Today evening. So I'm expecting you.
Okay, welcome. Okay, we have big function here.
Yes,
Have
I
a
know.
great day, Kiki. Yeah. You're becoming younger day by day. Yeah.
No.
Yeah, thanks. Your good wishes are helping me.
Good morning, sir.
Good
Hey,
morning.
Harshad, how are you? Hey, Harshad.
I'm fine. Good morning. Many happy returns of the day, sir.
Thank you, dear. Thank you.
I
Thank you
thought
very
it was 2 days ago.
It was on 9th. Today is a party.
Yeah, I'm going to see you there.
Yes, I'm already 3 days
I'm looking
plus.
forward to meet you today.
Absolutely. I too.
Yeah.
Yes.
Only.
Happy birthday, Dr.
There's Marvin.
Kiki, sir.
Thank you. Hi.
Uday. Say
I'm-
hello, Uday.
I'm good. I'm good, sir. Hello, Dr. Suresh, sir. Good morning, Dr.
Hello,
Suresh, sir.
hello. Nice to
Hello,
see
yes.
you. Hi.
Hello, sir. Thank you.
Okay, we're
Happy birthday, sir, Dr. Kiki, sir.
Thank you. Thank you very much. It's nice to communicate with so many people.
Yes. Dr. Suresh is in Jabalpur or Bombay?
I am in Jabalpur. I am in Jabalpur.
Suresh is in
Okay.
Jabalpur. I am in my office.
we're getting feedback because somebody has a YouTube open. Somebody, close.
Good morning, Swami. Yes, Swami. Good morning,
morning.
Swami. Good morning.
Yes.
Good morning, everyone. Nice to see you all.
After this talk gets over,
If his telephone rings, उसको silent कर दो. या एरोप्लेन पे डाल दो. ये बंद हो जाएगा.
Sam, are you there? Sam? Sam, you there?
Yes, I'm here.
I can't see your picture.
Laptop.
Sam, you got your camera?
Let's take Kishan. I am on the
Okay, somebody has their YouTube open. Please, turn it off. Sam, how you doing? Is it mine? Marvin, it could be yours, Marvin. I think you're,
Good morning,
Yes,
Joe.
I'm ready.
good morning. Let me do this.
I think the echo comes from mic of Marvin.
It's Marvin's.
Could you please mute yourself?
Yeah, it's Marvin.
That is-
We got it. We got it.
Yes, now it's okay.
Yeah.
What is that?
Okay.
Good. It goes on.
Please upgrade Professor Dewujari. John.
What did you say, Sam?
This is Florida. जाने का है.
Oh.
Upgrade Professor Dewujari for panelists.
Yeah, Dr. Pujari. You know, they took away their co-host. I don't know why they did that. That was used to be very useful. Okay, Chandra's here.
Hi, John.
He's next. Welcome, Chandra.
Hi, yes.
Yes, Dr.
Hi,
Turel.
great. Hi,
Another
good
opportunity.
morning. Thank you. How are you? Good to see you
Good,
here.
good.
We are only a few feet away, physically.
3 minutes.
Early in the day.
Yes.
Good afternoon, Deo Pujari. Nice to see you.
Hi, Suresh.
Mhm.
Kiki is the first speaker, is that right?
Yes.
Yes,
Yeah,
I have to be relieved because I have to arrange
birthday
for my,
boy.
This is
for my
really
party.
Kiki's
Yes.
birthday party. It's really his birthday.
I have got a birthday party, so I have to run from here.
2
We have
minutes.
enough time. There's enough time.
Yeah, 2 minutes. Okay, Ramesh.
Where, John? John, are you in Florida? Where are
Yes,
you?
Miami. 3 o'clock in the morning.
So what's the
Sure.
weather like? moment,
Neurosurgeon hours.
Yes. You know everything about neurosurgery by now. And many,
I can
and many
operate.
other-
I can operate now.
So we can always ask you for a second opinion when we have
Oh,
problems.
yeah. Oh, man.
The powerhouse of
I couldn't do it. I couldn't do it. I couldn't handle an aneurysm bursting. I would just leave the operating room.
So you say I will not handle complications. I can handle the rest.
Oh,
You leave
okay.
the complications to me.
Is Dr. Same with us?
Yeah. He's there.
Samir
Yeah.
is there, yeah, Samir.
Sammy, yeah? Okay, Sam, we start in 1 minute.
Yeah, I'm here. Thank you. Yes, I'm here.
You ready, Sam?
Okay, please upgrade بفصل رانيش نايف في البانل.
Ramesh there.
He is raising his hand.
Yeah, he's coming in. You ready, Sam?
Sir?
There's Ramesh, welcome.
Hi, John.
Ramesh.
How you
Hi,
doing?
sir. Hi, Kiki.
Hi,
Chandra.
Ramesh. Hi there. How are
Very
you?
good. I'm so sorry, Kiki. I really wanted to come, but when you do the party, I will raise a glass for you and send the video to confirm it.
Okay, we're ready to start. Ready, Sam?
You can come on a Zoom today in the evening, Ramesh.
Sam, you ready? Sam?
We are having an evening Zoom function with some of my friends from abroad.
Oh, okay. Let me know.
I'll send you a link.
Excuse me, gentlemen, we're going to
Yes,
start.
I'm
Okay.
ready, John.
Okay, Sam, are you there? I don't see
Hi, Ramesh. Hi.
Sam, your camera.
Hi, Sarah. എന്തുണ്ട്?
Yes.
ഒന്നുമില്ല അത്.
Sam, you need to
They're
put
starting.
your
They're
camera on.
starting.
Sam, you need to put your camera on. Kiki, don't go on the screen share yet. I haven't introduced you. I haven't introduced you yet.
Sure.
You have to get up to screen share. Okay, we're going to introduce your face rather than your
Yeah.
little picture in the corner. Sam, are you ready? Sam, your camera's not on.
Yes, ready.
Your camera's not on, Sam. Please turn it on.
No, it's on.
I can't see you.
It's on, John.
Okay, well, I'll start. 10, 9, 8,
Okay, just
7,
let's
6,
start.
5, 4, 3, 2. Good morning from Miami Beach. This is Dr. John Bennett, home of Neurosurgical TV. We're honored to host the Memoriam for Gazi Yasergil, and we've got a great turnout. And I'll turn it right over to the brilliant host, Sam El Morsi, from Egypt. He's going to be hosting the whole, almost the whole show. Okay, Sam, it's all yours. Sam, are you there?
So again, Sami and me.
Thank you, John. Thank you all for joining us today to. Yes, I'm here.
Go ahead, Sam.
John, it's okay.
Sam, go ahead. You're on.
Okay, good day to every one of you. Good day to every one of you. Do you hear me?
Yes.
Hello. Good day to every one of you. Thank you for joining us today to honor Professor Yasergil, the most dominant neurosurgeon worldwide and well known for all of us. And microneurosurgery has been changed a lot since he has moved on this way. And now we will start sharing your screen.
Okay, Kiki.
Yeah, all right. Screen sharing.
See the first, just confirm if they can see the.
Okay. Is it confirmed you can see the first visual?
Yes, perfect.
Can, after moving, just confirm if it just moving.
Okay, so I'm now moving. Can you see my first slide?
Yes.
Okay, that's the ripple effect. I'm going to talk about the ripple effect from my journey from my naked eye to the loops to microsurgery in the 70s and beyond. So only the man who knows exactly the art and science of the past and present is competent to aid in its progress in the future. Words spoken by Bill Roth. Bill Roth was a pioneering general surgeon, gastroenterological surgeon in Zurich, in the same place where Yaşargil worked. My journey started in the 70s. Training, subsequent development occurred in India, in Mumbai. When I trained, we were already overwhelmed with general surgical, neurosurgical work, which included trauma, brain tumors, congenital malformations, hydrocephalus, tuberculosis in all its forms. And then we had spine disorders. We saw CV junction anomalies right from those days, even earlier. And of course, spondylotic disease, degenerative lumbar spine. Somehow, peripheral nerve surgery was not given due attention at that time. Nonetheless, we were operating 3 full days as regular operating days. And on the other days, we had emergency duty, tackling acute cases, mostly trauma, which means that we were actually operating 6 days a week, running our wards, running theaters, investigations. And in those pre-CT era, it consisted of direct puncture angiography, myelography, ventriculography, pneumoencephalography, and so on. So surgery was basically by naked eye. As you can see me in this one of those black and white pictures operating. Those days we had no significant textbook. We had some literature, papers, but no textbook, excepting this one by Northfield on neurosurgery. And this was our guide before we appeared for our board exam, which I passed in 1975. But during that board exam, examiner asked me, what is the latest that you read about neurosurgery? Very quickly, I only had a faint idea, but very quickly blurted STA-MCA anastomosis, described by one Dr. Yaşargil, is one of the new developments which can help augment cerebral circulation. My examiner, who was well-read, was very impressed by this answer. But in reality, I wonder how much more of us knew about this subject at that time. At that time, information exchange was very less. Our teachers could only advise us to go to certain centers. And before I qualified, my professor already advised me to travel to Atkinson Morley's, where he had trained. So I went to UK. This is the first time I stepped abroad. And you can see my dear family, all of them, my brothers, my close family, all coming to greet me at the airport in 1975. This was some big event in the family. The first member of the family, of Turel family, venturing out of the country. I wanted to have an idea of what other departments in UK and Europe were doing. So I could hardly afford air travel or stay in a foreign country. Fortunately, I had a free ticket to Rome, and I had to buy a Dural pass for $100 that would allow me unlimited travel for 3 weeks through Europe. So my dad gave me about $200. At that time, dollar was 10 rupees a day, 10 rupees a dollar. So I carried $100 for Ural and $100 to be spent over 3 weeks. And to help me save on my hotel stay, I traveled by Ural train on most nights. So I was sleeping in the train and again working and traveling during the day. This was like an exploratory tour with no particular agenda. Seeing Europe for the first time was absolute bewilderment for my eyes. I was also carrying a small camera a cousin of mine had gifted me at that time. I couldn't have bought it myself. And this camera since then has become a part of my life. So you can see small little things add to our development in our lives. I'm sure this must be happening to all of you too. But to take advantage of these small opportunities and turn them into game changers is something big. Without even giving much thought, it just developed, photography developed into my system. And over the years, I've become a kind of a known photographer when I have been having several photo exhibitions, traveling around the world. Without the camera, I would not be seen. So after Italy, my first stop was Zurich, Switzerland. I had heard about Canton Hospital in Zurich and Professor Yaşargil. I just walked to the neurosurgical department, no prior letters, no appointments, no discussion. I was told Professor Yaşargil was a very short-tempered, hot-headed surgeon, temperamental, whimsical, eccentric, and whatnot. All kinds of words were being whispered about his persona. It didn't matter to me. I had gone to see and learn something, so I just said, let me go. I had no idea whom I was going to meet. I had never seen a picture of his, nor what I was going to see. It was just a random visit, like one essential halt in Europe. I was quietly led to the neurosurgery OR where Professor Yasergil was operating. I was directed to an amphitheater-like place, which is at the top of the classroom, as you can see in this picture. And from there, we were asked to observe what the master was doing without uttering a word. I saw that he was busy operating on his trademark surgery, clipping off an aneurysm by the Tentorial Approach, which he had described and popularized, using very fine microsurgical instruments which he had designed. Though he used only a handful of them, there were trays and trays of instruments of different dimensions, much like a buffet spread. From the enclosure above, we could see nothing. He was operating using a microscope, surrounded by assistants and assisted by his favorite nurse, Diane. He was using a massive, elaborately designed and meticulously balanced controverse microscope, which had a mouthpiece with which he could move it in all directions with both his arms, whilst he was resting. He's resting his arms on an armrest so that his hands were free to dissect. And whilst he was operating, nobody was allowed to talk, not even whisper, hence the glass enclosure. This was my first introduction to a microneurosurgical operation. And to the personal effect and to the personal and technical ingredients that required to make a difference to the complicated and still evolving field of neurosurgery. While dissecting the aneurysm, it ruptured. He just laid down his instruments, raised his hands up in the sky into the theater ceiling and screamed, "Oh God, help me." Meanwhile, the aneurysm went on bleeding. He then calmed down himself, stretched his right hand out. The nurse Diane knew exactly what to give him, and in no time, we stopped seeing blood. Very quickly and deftly, with secor in one hand and a clip applicator in the other, he had slipped the clip into the aneurysm neck and clipped it successfully. From my journey to Europe, I returned back to Mumbai in 3 weeks' time. And having qualified, I secured the position of a junior consultant at a public hospital. My then teacher, Professor Bhagwati, presented me with a pair of 2.5x magnifying loupes that he had stopped using because he had got a new pair from US. This extra magnification clearly boosted my surgery, increasing visibility of the surgical field and accuracy of surgery. Soon thereafter, I bought myself a 4x loupe made by Keeler, England. This further added to the scope and precision of surgery. However, the deeper areas could not be sufficiently lit by the ceiling lamps, so I added a headlamp to overcome this shortcoming. A memorable event soon followed thereafter with these loupes. Simultaneously, neurosurgeons from Germany, Professor Hans Werner Priya and Dr. Gorte visited KEM Hospital in Mumbai, 1979. They conducted a dissection course on a table microscope. This was a completely different vision than loops. It offered significant magnification, illumination, and added 3D stereoscopic vision. This was my first exposure to microscopic surgery. It really opened a new, completely revolutionary avenue to neurosurgical dissection. So we had to practice hand-eye coordination to be able to use the operating microscope, as we saw during that demonstration. I grabbed the opportunity to upgrade my surgical precision. So from loops, I ordered a table microscope made by an Indian surgical company. And then I started my practice on microscopic surgery with the table microscope. Our professor of pharmacology offered me white mice. He would then sedate them with intraperitoneal phenobarbital. I got some basic instruments from a local Indian surgical company, and Ethicon JJ was generous enough to provide me with unlimited 10-0 material. I had the option to train my hands on placenta and tubes as well, but I was happy with mice because it was real tissue. With each mouse, I would do anastomosis of the 1 mm carotid artery, and the same animal I would flip over, expose the sciatic nerve, and then suture it again under the same microscope with the same suture material. I knew it was cruel. I didn't like to inflict this kind of injury to animals. I was always very gentle and kind to animals. Actually, I turned vegetarian when I was only 6.5 years old. Well, initially I practiced on 25 mice. After the first couple of misses, subsequent animals did quite well. There was no hemiplegia, but the sciatic nerve left them weak in the leg. It didn't give me a good feeling, so I stopped doing the sciatic nerve and concentrated only on the carotid, and completed at least 100 successful anastomosis and kept the animal alive and observed him throughout. Soon thereafter, we had our first generation CT scans, and I had the opportunity to remove at that time, the world's largest brain tumor, weighing more than half a kilo, just using loops and magnification and headlamp. At the same time, in the same year, 1981, Professor Beamer, an orthopedic hand plastic surgeon, visited Tata Memorial Hospital, and he showed how digital arteries could be anastomosed, and they were even finer than the carotids that I had practiced on mice. This was very impressive, how restoration of function could be done, how magic can be created by microsurgery. I now was absolutely enthused to pursue microsurgery even more. At that time, microsurgery was not even whispered, but I had one plan, and I devised special plans to train myself. There was no one to train me in my country. Whilst training on the table microscope, I had been nudging my chairman, Professor Bhagwati, to procure an operating microscope since 1979, and finally prevailed to get one for use on our patients, and we got OPMI 6. This was a basic microscope. Our chairman, Professor Bhagwati, ordered it, though he himself was not trained in microsurgery. It was his vision that helped us get this. But we had only one straight, non-inclinable tube, which was a great strain on our neck. There was no side tube for the assistant. However, we had a portal for the camera so that I could load my slide films and take pictures. A real gift. Now was to get the correct kind of films, which was also very important. And I was advised to buy these 160 Kodak professional tungsten films, which was the best for getting high quality micro photographs. I had enough stock, and every time I travel or my friends travel, I prevailed upon them to get this kind of a Ektachrome 160. And when that was not available, I used Kodachrome 64. But everything was on slides. So whatever I earned those days was spent on microphotography and then international travel to show whatever little work I had started doing. Actually, it was very unfair to my young family because all the money was being spent in this business of microsurgery and travel and photography. I still have those pictures carefully preserved in my collection for the last 40 to 50 years. So, since then, since I was new to microsurgery, I would take longer hours to operate. I was in absolute awe of what I saw under a microscope. It was like voyaging into the ocean bed, seeing the beauty of nature, the CSF pathways, the large blood vessels, the small perforators, the delicate cranial nerves. It was a spectacular vision under a microscope. At those days, we had never seen this kind of a vision. And eventually, when we started operating, this is the kind of a picture that we could produce. This was a large, giant pituitary adenoma which had hemorrhaged, and it had turned the patient blind. You can see the optic nerves veins slightly split apart. And then after the entire tumor was removed, you could see the mammillary bodies, the perforators, the basilar artery, and the branches. This was the spectacle, the beauty of microsurgery. How can you not get addicted to it? But as I was enjoying these beautiful visions, it was upsetting my anesthetists who had family duties in the evening. I was not bothered. I was just going on operating from one day to the other. And I wanted good results. I was one of the first persons to do this work, and I had to showcase the entire panacea of microsurgery. Colleagues looked at me with suspicion, doubt, or amazement, even envy. But that made no difference to me. What made difference to me was my results. I was strong and untiring physically and mentally. So for me, doing surgery or long surgery was never a factor. Time was never a factor. I would normally prefer to stand, even operating from one day to the next, even without a break. Two of my longest operations at JJ Hospital that time lasted 27 hours each without even a break. Those days, air conditioning in the OR would stop at 2 o'clock to conserve energy. Hence, I would be sweating for the rest of the day until the next day. There would be a fan and a ward boy would be wiping the sweat from my brow. The microscope tubes were straight, not inclinable. Fortunately, it did not take a toll on my neck. I was very strong. I had a good spine and a good physique. I used to go to the gym, exercise. Genetically, I was endowed with good physique. So I did not suffer from any problems until today. It's very important to have a strong body and, of course, a strong mind, strong arms, good eyes, and a strong brain to succeed in microsurgery. At Bombay Hospital, which I subsequently joined, we did 8 microsurgical operations back to back over 26 hours on one very eventful day. Just as my microscopic microsurgery was advancing in 1982, Majid Sami avalanche happened to India. He came to Delhi and Mumbai. This was a great significant event that changed my life completely. And the rest is history. I saw his super results with MBDs, acoustic tumors, brachial plexus surgery, which he showed liberally in Delhi and Mumbai. I traveled to Delhi to listen to him first, and then he came to Mumbai. I followed him. I was sure I had finally found my mentor. I felt there was a big lacuna in my surgical abilities and wanted to particularly improve on my results of acoustic neuromas. I was at his department in Hanover thinking I would spend a few days, but I ended up spending almost 2 months at that preliminary time. We developed a fantastic collaboration, appreciation, even admiration for each other. We spent several of all the weekends together in his office discussing the nuances of microsurgery and acoustic neuroma particularly. I wrote down 2 chapters to be published in this first volume of Microneurosurgery by Dr. Rand, at that time, 1982. Every time Majid Sami and I met, we talked, it was an experience by itself. Every time it was an explosion of new information. We realized that we could do a lot more than that. So he offered me to come back and spend at least 1 year, if not 2, so that we can explore the entire arena of microsurgery and perhaps write some books on that subject. I rejoined him in 1983 and stayed with him for a couple of years and had the first experience of advanced microsurgery until 1985. I was also a part of his skull-based study group that he had initiated, undertook with his multi-speciality colleagues in Mainz, where he had initially started working in Germany. So my independent journey in advanced microsurgery actually enhanced further after I returned to Mumbai in 1985. Journeying into the microscope, into the brain with a microscope, was a spectacular thing. I conducted the country's first skull-based surgery workshop and live surgery in Pondicherry in 1987, along with an orthologist, Morwani, the first of its kind in India. We formed a microsurgery group with my plastic surgery colleague, Ashok Gupta, and organized workshops to train and popularize microsurgery amongst the young surgeons, not only neuro, but also plastic, orthopedic, and even gynecological surgeons who had to learn microsurgery to be able to do tuboplasties. Skull-based surgery workshop was the next thing on my line. In November 1999, I arranged the 5th AOSBS skull-based meeting, which was an 8-day mega event. We had a 3 days cadaver workshop, 3 days conference, and a 2-day post-conference live surgery. Since then, I have been conducting workshops in microsurgery of skull base and anastomosis. I have been traveling all over the world. I've operated in 15 countries and conducted workshops in as many. I'm just giving you a glimpse of pictures. Tumen, Russia, 23. Verona, you can see Ramesh with me in Italy in 2024, and Klagenfurt in Austria, 2023. Meanwhile, whilst microsurgery was going on, in 1989, neuroendoscopy was introduced in our institution in 1989. Neuroendoscopy was actually originated significantly by Michael Gaab, who pioneered endoscopic brain tumor surgery in collaboration with Karl Storz. He developed a universal neuroendoscopic system, and one of my colleagues, Dr. Virani, trained with him. So back in our department with our ENT colleagues, endoscopy, both intra and extracranial, has significantly advanced over the years, and Professor Dev Pujari has been one of them to take the lead in this area. Amin Kassam explored and exploded the full range of skull-based surgery to posterior fossa. He visited us several times to support us with cadaveric and live surgical workshops, and here we see him with me, Kappa Bianca and Amin Kassam in our theater in one of the microsurgery workshops organized at Bombay Hospital. Simultaneously, another new term evolved, minimally invasive endoscopic neurosurgery. My good friend Axel Paneksky in Mainz contributed significantly to endoscopic and introduced this new term, minimally invasive microsurgery. This was a new idea by operating on using microscope and endoscope and using minimally exposures to be able to reach deep areas of the brain. Together, we conducted a workshop on this minimally invasive surgery at Esculap Academy in Germany. So this journey, whose first big leap commenced with Professor Yaşargil introducing micro techniques to microsurgery, continues. So from naked eye to loops, to microscope, to endoscope, and now to exoscope, which is now becoming very common in many of our operating rooms. Virtual reality, robotics, and AI. The scope truly is unending. In neurosurgery, sky is the limit, undoubtedly. And here you can see me pondering over it, sitting on top of Mount Sinai in Egypt several years ago on one early morning sunrise, thinking about the future of microsurgery. We have been organizing microsurgery workshops on complications in neurosurgery every couple of years. The first one was in 2017 and then 2019. And many of you have been generously participant to this iconic movement, which many of the international societies have been supporting. So we had every 2 years a ICCN. Third ICCN was held virtually, which was attended by 12,000 neurosurgeons online. And then fourth one was in 23, and last year in 25, we had the fifth ICCN. We had an interim meeting in China last year. We have published 2 books on complications in neurosurgery, Volume 1 and Volume 2. And I thank you very much for listening to me. I have some very beautiful pictures of Yaşargil, which I would like to show, but I'm already overstepping my time, and just thought I would let you know my journey and how I was inspired into microsurgery and beyond, the ripple effect through which I would say major contribution, the preliminary first baby steps by Yaşargil, and then onward by Majid Sami and so many others. Thank you very much for listening to me. Thank you.
Thank you, Professor Kiki, for this very nice presentation, which we have started this Memoriam by. Is there any question?
May I make some comment?
Okay, go ahead.
Thank you, Kiki. I think this was a very inspiring talk and truly a lecture fitting to a legend, which you are. And those words of wisdom also so valuable, like having a strong body and strong mind, especially for young people when they start their journey. And the other thing which reminded me when you were talking about your hobbies in the beginning, like getting a camera and then that becoming a major part of your rest of your life, which we all know, reminded me of Steve Jobs, what he said, like connecting the dots. You cannot connect the dot looking forward. You can only connect them looking backwards. So somehow you have to trust that these dots will connect somehow in future. So it was quite a valuable thing. You know, people do several things, but in the end, everything will connect together. Thank you, Kiki. And it was a great talk. Thanks.
Thank you. Thank you.
Thank you, Dr. Kiki, for this excellent presentation, and have a birthday.
Thank you.
Thank you.
Thank
And
you.
now,
Thank you for giving me this opportunity.
thank you. Now we will shift to next speaker, Professor Dural. Please start sharing your screen.
Can you see my presentation?
Yes.
Not the full screen, a full presentation mode. Okay, you're gonna put it on.
I want to see
Put it on presentation mode, please. Yeah, perfect, perfect.
So 10 years later, from what Kiki described, I joined the department to learn neurosurgery. I came from a medical school where there was no special department of neurosurgery. And as he said, he had gone off to Germany most of the time when I was training at JJ Hospital, learning microsurgery, but a microscope had come. And all of us were trying it out whenever it was free. There was one experimental microscope kept for us. And all this happened because of this one man who seemed to have brought up such a change in the whole world of neurosurgery that everybody wanted to learn and everybody wanted to do what he was trying to do. My interaction with him was fairly late, but my first interaction was I finished my neurosurgical training in Mumbai. I became a member of Congress of Neurological Surgeons that year, and I went actually to train with Professor Sen Gupta, who's another mentor in aneurysm surgery, which was extremely popular at that time. And this was one of the first books I received from the Congress of Neurological Surgeons. We used to receive books during those days. Now everything has become digital, but this is something which I have treasured now for almost 40 years. And if you look at the contents of this book, the whole microsurgical gamut has been covered in this. And one of the first things which I saw was Yaşargil's paper on thalamotomy and pallidotomy. And I realized that this gentleman who was working with Cranbull was actually doing stereotactic surgery during his early days. And it is no different in many departments. You do not get what you want to do, but he pursued. Not only he persisted with that, he went for microsurgery training to US with Donahi, very famously, and then developed a surgery for revascularization of the brain. But even his elegant drawings in stereotactic surgery and lesioning are very, very nicely kept. And Cranbull's actually grandson told me that they have a whole plethora of these drawings and various case reports from that time. I think the biggest contribution of Professor Yaşargil is the development of pterional craniotomy. We always used to call it frontotemporal craniotomy. And when the sphenoidal bit was added to it and it became a pterional craniotomy, it unlocked the whole skull base. It not only opened the vascular compartment, but it really unlocked the whole skull base. Earlier, when I was training in UK, I mean, most of these anterior aneurysms, anterior communicating or anterior cerebral aneurysms were being done by just a frontal craniotomy. While you can see that with the pterional perspective, not only you can see beautifully, you can save the perforators beautifully. And it also opened up, and that is, I think, one of the biggest contributions again of Professor Yaşargil and his anatomy colleague, that we got to see beautiful pictures and learn about the anatomical observations of subarachnoid cisterns during the brain surgery. This was not described without microneurosurgery, and therefore I think we were facing issues which we should not have faced if we knew this anatomy so very well. And therefore I consider this one of the most important publications in microsurgery. By this time, actually, the microsurgery had started becoming gold standard. And I decided to do a course with Professor Yasergil at some stage, where I could understand the nuances of aneurysm surgery. I mean, this kind of an aneurysm, I think you can straightforward do with a frontal craniotomy. You get a perspective nicely. and you can see A1, A2, you can see the downward projecting aneurysm. But when it comes to this is the postoperative scan, but when it comes to a complicated cases like this, I had an aneurysm which was within a fenestrated anterior communicating artery. And unless I had the pterional perspective, it would not have been possible to do it. And do it, I mean, we have made an effective job of this if you see this postoperative scan, angio. And this is the postoperative DSA on the same patient, which shows that the aneurysm has been completely taken care of, keeping the ACA intact. Posteriorly directed aneurysms could burst if you did only the gyrus rectus and frontal lobe retraction. So the pterional perspective gave us that again idea where you could separate frontal and temporal lobes. You could put your temporary clips on A1, A2, and even the other A2 if required, like in this particular patient. And then we learned with his various clips how to use a ring clip to save the A2 and still clip the aneurysm completely. So the perspective changed. And you can see this a successful clipping and the patient has done reasonably well. This is a double aneurysm, one of the rare cases, but we could manage to clip both and keep both the anterior cerebral arteries intact. Another large superior posterior aneurysm. Again, you can see that it could be clipped. I would not take too much time on angio, but you can get a beautiful perspective, aspiration, and most importantly, neck reformation by doing bipolar coagulation to reduce the size of the neck. You have to know properly, you need to have a good bipolar, but you also need to understand how it can be useful. Of course, nowadays with ICG, it has become easier, but earlier we used to do per-operative angiography and make sure that the aneurysm has been taken care of. Another thing which interested me, because I took some interest in epilepsy surgery as well in the initial period, was the selective amygdalohypocampectomy. Now the neurologists are not so enthusiastic about it because I think many people who are doing epilepsy surgery are probably not looking after so much microvascular neurosurgery. And that integration was extremely important. And especially in a dominant hemisphere, it can be extremely useful, like we found in this particular patient. Patient had a ganglioglioma, and it could be completely done without interfering with the temporal lobe at all. Another important thing, way back in 2005, Dr. Yaşargil did a course in St. Louis along with Ali Krisht and Olivendra, and they actually showed the fiber dissection for the first time. 20 years later, now it has become the norm, but that was the first time I saw how fiber dissection can be done. And the biggest advantage of that was one could get some confidence in doing insular gliomas, on which he wrote 4 successive papers as to what is the anatomy, what is the opening of Sylvian fissure, what do you see? And till that time, I think this was a low
Are you okay?
I think he lost signal. We will wait till he
Okay.
back.
Okay. He fell off. Be patient, everybody. So hang on, I believe he's rebooting. But he's always come back before. So here, let me monitor. We're waiting for Chandra, right? Just so I keep my eye open. Sam,
Yes.
we're waiting for Chandra, right?
Yes,
Yes.
yes.
I'm just keeping an eye out for him in the waiting room. He hasn't arrived back yet.
Okay, he back.
There was a little disconnect.
Okay,
Would you allow me to go on for another 3 minutes?
okay. Okay, see.
Here we go.
So icing on the cake, as I told you, was in 2008. He agreed to visit our department for our annual function. Can you see and hear me?
Yes, perfect.
Yes, yes.
When he received this medal in Professor Ginde's name, who's a pioneer neurosurgeon in Mumbai, and he was interested in everything. This is lighting the lamp, a typical tradition in India for bringing, light into darkness. That is how the educational events are looked at. And not only was he interested in meeting the big people, like this is my mentor, Dr. Sengupta, but he was very, very interested in looking after all the young colleagues as well. Well, they are not so young anymore. But you can see some very young people here with whom he was very interested in having photographs. Some of them have become, of course, stalwarts in their own field. Dr. Mishra, Dr. Atul Goel are here, and I'm sure Kiki is somewhere there as well. I think one of the important things which we observed was his complete dedication to teaching. And I think one of the persons who probably is responsible, I am told, is his wife, of course, Diane, who not only helped him in surgery, but also helped him in organizing himself and kept his interest in teaching till the very end. And was a very simple man. This is our operation theater, small lunch area where he was happy to eat his fruit lunch without interrupting the lectures. But in the evening, when we had a function with all the younger people, he was ready to sit on the floor in the garden as well. I think with the deep kind of a fiber dissection and some of the approaches which he told, we could remove the thalamic tumors quite well, like in this child. And his passion for teaching was, I think, was unparalleled. I have not seen a person who could continuously teach for 10 hours a day for 2 successive days. And the master, I feel, is also because of his curious nature. Though everybody was trying to take photograph with him, he was equally interested in taking photographs of certain things which he thought were, different, which were peculiar for India. And he was asking and he was taking photographs everywhere. So I think this was a small sort of personal interaction during courses and during his visit to our department. But he has influenced, like everybody else, he has influenced our career quite remarkably. Thank you very much.
Thank you, Professor Dubujari, for this excellent presentation. Is there any question? Thank you.
Thanks, Chandra.
Thank you. And now we will shift to next speaker, Professor Mishnayr. Please start sharing your screen.
Thank you. Let me know once you see my screen. Are you able to see my screen now?
Not yet.
Not yet.
Not yet.
Yeah.
You
We
can?
see it, but we don't see the presentation.
Yeah, we're seeing
Yeah, I haven't shared. I need to get back to the. Let me just.
Yeah, go right to the PowerPoint.
Just to minimize this.
Yeah, I'm trying to minimize, but all these taskbars are out of view.
You don't want to go to Zoom. You want to go to the PowerPoint.
Yeah. I'm just going to try and optimize, annotate. Okay, point. Give me a second to, I'm just going to stop sharing and then minimize the recording.
You'll get it.
Yeah, I'll get it. I'm sure I'll get it. Let me just close this one. Okay. And then. Okay. Let me try again.
It's best to click the share button first. Click the share button first. Yeah. And then look for your file.
Yeah. I'll try again now.
Okay.
Share.
Okay. Now, find the file.
Can you see it now?
Yes, we can. Now put
Okay.
Perfect.
Thanks very much. Sorry for that initial trouble. And those two talks were true remembrance to the legend, Professor Gazi Yaşargil. And especially, it was very nice to see Professor Yaşargil's involvement in Indian neurosurgery by Professor Chandra. So that was quite good to see all those sort of flashbacks. I just wanted to talk about this particular set of meningioma, which Professor Yasergil also classified initially and then described quite a lot of it. I will talk about the tentorial meningiomas, especially the meningiomas which are slightly more trickier than the standard meningiomas. You know, we operate on lots of meningiomas around the convexity and the skull base, but often we not talk about some of the complex meningiomas arising from the falco-tentorial region or the medial, the inner tentorial ring, or the torcular. So, so my intention is to just to go through them, and it's important to understand the anatomy of the dural partitions of the cranial cavity. When we do skull-based workshops or other workshops, we don't tend to explore this area around the tendorium, and so I think in many of the grasped by the younger colleagues. Often we understand that the tendorium is like a partition, thick dural layer partition between the posterior fossa and the supratentorial compartment. It's not like a flat line. There's a pyramidal shape to it. It goes up, and from the other side, from the edge of the petrous bone, it comes up. And the middle, it meets the falx cerebri through which the straight sinus travels. And right at the center point, where you have the major confluence of vein, where the internal system then travels through the straight sinus back into the torcular here. So that anatomy and the understanding of it is quite crucial to manage some of these cases. And Professor Yasergil, even though there have been many classifications, Professor Yasergil classified into several groups, and then Professor Bascioni, who I think is talking a bit later on, and grouped them into 5 groups. So which makes much more easier to classify in terms of describing it. And so the groups are, first group is around here, the inner tentorial ring on the anterior part. And then you have the second group, which is on the falco-tentorial region, which is at the confluence of the great veins, and also around the tentorial leaf in the intermediate group. And the fourth group is around the torcular, and the fifth group is around the outer ring, around the sigmoid and the transversinus, also possibly along the petrotentorial corner. So many of these meningiomas we treat around the petrous bone. They also are attached to the tentorial leaf. So often it makes it difficult to really classify them into the posterior petrous group or the tentorial group. So basically that depends on the point of origin. And so this is the grouping system, and this is from Professor Bascioni's paper about the number of meningiomas. As you can see, these meningiomas in these groups we see quite often. Tumors around the inner tentorial ring, and we often treat them through various approaches, and also tumors around this region are quite high in number. We can see that the highest number is from this group. But these two tumors are not that many, but still a bit high. Of all these tumors, the tumors around the trochlear are fortunately much less, especially sometimes we see fairly extensive tumors occupying the both occipital lobes and both half of the posterior fossa. They are more difficult tumors. So fortunately, they are not that common. And we mentioned about Professor Yaşargil's contribution to the cisterns, which is so important in tentorial meningiomas as well. As you know, the brainstem is surrounded by various cisterns, including the interpennicular cisterns and the crural cisterns and the ambient cistern and the corticogemal cistern. So when a tumor arises from a structure, it tends to displace this cisterns for our advantage, for the surgeon's advantage. For the main important thing which we need to understand when tackling the tentorial meningioma is that it's slightly different to the petroclival meningiomas or phenopetroclival meningiomas. The phenopetroclival meningioma, as Almaty described, it tends to push on the cistern, but only will have usually one layer of arachnoid against the brainstem, which can be often infiltrated, and that makes it slightly more riskier. Compared to that, a tumor coming from the tentorial edge often will have a number of cisterns which are sort of compacted by the tumor growth. So it's important that when we see these tumors, it's important to look at where it started from and then how it would have displaced this cistern. And also, along with that cistern, as you know, each cistern will carry its own artery and the nerve. So it gives you an idea about how these structures are displaced to one side. And these sort of tumors anterior towards the petrotentorial corner, towards the anterior end, attached to the tentorial leaf and the anterior part of the petrous bone, they can be operated to standard approaches. So I will not dwell on these sort of approaches. Standard approaches like posterior retrosigmoid approach or an anterior petrosigmoid approach, and each approach which you choose will have to decide the best way to get to the tumor without causing any neural damage or vascular damage. Here in this case, you can see a retrosigmoid approach, which is what I usually use for most of these tumors, especially they are infratentorial. You can expose the tentorium around this where the tumor arises, and also sometimes the petrotentorial corner where the tumors are really attached into the superior petrospinous. This is the area which you can expose through a standard retrosigmoid approach. And the nerve which you have to be careful is the fifth nerve and also the fourth nerve along the tentorial edge. And in these sort of cases, the main thing is to make sure that we take this arachnoid just separately. So these arachnoid layers which you see here are generally peeled off without losing their vision. At the end, one will have a clean pile surface so that you don't damage any of these nerves or the arteries. And also the nerves are displaced based on the origin of the tumor. This tumor, which arises from the tentorium as well as on the petrous bone, would have displaced the facial nerve, which you see with the DTR here, downwards. And the other surgical nuances which we all should know about, when you have a large tumor in the posterior fossa, rather than doing a opening of the dura directly, always get the CSF out so that you can release the CSF safely, and then you can open up the dura more safely. At the end, you preserve all the microcirculation of the cerebellum and the nerve, so to have the maximum advantage. And tumors in the location of the sigmoid sinus can infiltrate, even though on the scan it looks like it is attached to the wall of the sigmoid sinus. Often only the outer layer may be involved, and you can clearly preserve this sinus in the long term. So these are the crucial points one needs to look at when you're looking at these tumors. The involvement of sigmoid sinus, involvement of the transverse sinus. In this case, this was a radiographer in her 40s operated in 2023. And you can see it is going above and below the petrous ridge. It's clearly arising from a number of areas, which makes it difficult to call it purely tentorial, but it is also the kind of common cases we see. Here, the sigmoid sinus appears to be somewhat affected by it, but you can see that eventually it is preserved. And this is the post-op. There is a small remnant above it, so which we have an option to wait and watch or to operate. So this is another case. Another case where the tumor is in this infratentorial compartment. Again, these tumors are all operated to standard retrosigmoid approaches. But in this case, the tumor is in this case, you can see the tumor is inverting into the sigmoid sinus, one may have to leave a small remnant, which that remnant will preserve the whatever patency that sigmoid sinus had before. Often you may find that tumor may have gone into the sigmoid sinus on the scans and maybe have occluded it, but in reality, that may not be true. So that always you have to keep in mind that the sinus may be partially patent. So my intention is to be conservative rather than trying to resect the sinus. So this is another long-term patient of mine, initially operated in 2008 with a tentorial leaf, anterior tentorial leaf meningioma. But often when we operate in this is a standard subtemporal approach where you have to be careful about the PCA and the fourth nerve. You don't need to go into the posterior fossa unless the tumor had spilled over the edge to the lower. Here is the post-op scan. There is a dural sort of en-plat kind of tumor extending along the tentorial leaf, which sometimes can be difficult to completely resect without damaging the fourth nerve. But these small remnant one have to watch for a long time. This is maybe 2018, several years later, that remnant started getting bigger, kept on watching it, and finally got bigger to need another operation. So 2008, from another maybe 10 years, so it grew back. That needed another operation. Again, the tumor attached to that lateral cavernous sinus wall was left. And initially, we were discussing about gamma knife, which they didn't want. And even he had other medical morbidity, which we didn't, so we didn't treat it. These tumors are more difficult to operate. There are two reasons for it. One is the involvement of the tocula and the sigmoid and the sagittal sinus and both transverse sinus. So, and also the straight sinus. All the sinus involved, if they are occluded completely, those circulation would have been collateralized to somewhere else. So one has to be really careful when dealing with these tumors, mainly because the occipital lobe, especially the calcarine cortex, may be affected, and any damage to it will lead to a bilateral cortical blindness, which will be a catastrophe. Fortunately, the surgical approach will need a slightly more extensive approach, exposing both the occipital lobe or suboccipital region bilaterally, and that's more morbid operation. I'll just focus on two cases to finish this talk. This is a case I operated 3 weeks ago. This is a 40-year-old lady, came with a few weeks of unsteadiness and headache. You can see this tumor it's a falcotentorial meningioma. The tumor has gone through the forks along the straight sinus, filling up the whole straight sinus, and pushed the anterior venous structures forward. And the straight sinus is completely occluded. So one thing we need to understand is where the deeper system is draining. So for that, we need to look at the venous anatomy quite carefully. Here, you can see that the tumor has gone into the infratentorial fossa quite a bit, and also gone up. So the approach-wise, there are options. I could go from the below or go from the interhemispheric para-occipital approach, but the long axis is here, so I decided to go from here. Also because of the fact that it might be too difficult to get to the upper end of the attachment from below. And this lady, she had occlusion of the ventricular system, and she would have needed temporary external ventricular drain during the operation, which is what I did. The other thing which is important is the amount of tumor extension into the occipital lobe. So these are quite critical, especially when you see bilateral occipital. The calcarine cortex is so fragile that one cannot afford any maneuver, any dissection around the cortex. One has to be extremely careful. So that will help you to see the serious space around it. So this is a calcarine cortex. This is the MRI scan being overlapped with the DSA. The deep system is completely occluded. The straight sinus is occluded. So those deep system is draining somewhere. So the angiogram shows that there is a vein going into the sagittal sinus, and also there is a vein going downwards into the petrous posterior fossa around the TP angle region. So this is the internal system which is being drained somewhere else. So the whole of the straight sinus is occluded. Obviously, these tumors get supply from the meningeal branches of the meningiohypophyseal trunk. Again, there is another collateral circulation going upwards, going downwards. Most of the occipital lobe will not have any significant drainage bridging veins, which is quite convenient. So strategy is important in such cases. How do you remove it? My surgical strategy for any of this meningioma is to detach all of meningioma as much as possible. Here, the back end, you don't have much tumor, so you can cut across it. at the front end, you've got to be very careful when you remove this front end. So you preserve the venous structure in the front, even at the cost of leaving a little bit of tumor. So here, that is the front end. So this is the strategy. And then you go across the opposite side. You come from the right side and go across the opposite side and cut the tendorium on the other side. So that will free up the whole tumor. And that things makes more easier. The strategy is, this is a interhemispheric transcendental approach, where one exposes the tendorium and the straight sinus and then cut across it and go onto the other side as well, go along the outside of the tumor to cut across it on the same side as well. So with this, you need a good position to have your cavity, bring down your occipital lobe, and the head is put downwards. So this is my team sort of braiding her hair very skillfully. So she was very particular about the hair. Incision is fairly large because you want the occipital lobe to be placed downwards with the gravity, and the incision crosses over the contralateral side. Especially this location, this sort of twisting of the head and the position is disorienting for a normal surgery. So you've got to be careful about the landmarks. Even before you pin, you have to understand where the midline is, where the sital sinus is, and then you mark the sital sinus. In this case, I've gone across the contralateral side so that I have good exposure to the sital sinus and the transverse sinus here. And the bridging veins are not really bridging. They are traveling, but getting attached to the midline. The one thing which I wanted to point out is the fact that one got to be really careful with this retraction. So there's no retraction used, but the pressure on the occipital lobe got to be very careful. Then the cut along this forks begins. Then I will go across it, and I'll cut through the whole of the forks, and then go across it and debulk it. And then finally, we'll go to the front end of it, debulk it, and cut through it. And you can see the front end. So here I will cut through the front end, so detach it from the front. So I know the deep venous system is coming here. All these veins are here. So I'll cut through it. So I detach the front end of it. And then I debulk as much as possible, so to make it smaller. Here, the front end is being debulked so that I could get the tumor off the arachnoid layer here. So then carefully, this is a crucial part of the operation. I don't want to go through the whole operation, but there are certain aspects. One is the occipital lobe, how you retract it and be aware of the occipital calcarine cortex all the time during the operation. Second bit is the venous confluence here. You know that there is a draining vein going to the petrous bone, the posterior petrous area. And there's another vein in the superior sinus. So those are the points one needs to keep all the time. And then there's a big tendorial defect once you remove the tumor from the cerebellum. So those are then once it's done, so I'll just skip all this. So this is all so final bit of the tumor from the vein, you can then safely remove it by cutting the small bit which you have left. So this was, then the tendorium defect is, I repaired it with a Duragen so that I can have some sort of a normal anatomy to repair the defect. So there was no damage to even the first day she complained of a blurring of the hemianopic field that improved subsequently. Another case, fairly similar sort of tumor, Tentorial Meningiomas. Here the veins are displaced upwards. So in this case, patient had an attempted operation already. So that made slightly difficult things to kill. What they couldn't really remove it, and then there was a gap here. And the tumor, you can see the venous system is displaced as well. So this will be an idea. The approach was right for the previous team, but somehow the exposure wasn't very good. So you can see the previous exposure. There's a craniotomy. This was enough to do the operation, but I think somehow the strategy was slightly different. This is a semi-sitting position which I used for this case. Same scar and then same exposure, but slightly more wider. So you can truncate the tumor, amputate the tumor, and then go to both sides. So that is the key point in sort of tumor. So you get to the normal around the tumor, then you disconnect it. And then you can see it, and whatever stump you leave behind, you can come back to it later. So this is the strategy which I think is so important in such cases. And there was a small remnant on top of the vein, which will be monitored and we can then decide. Because it will be difficult to see this part through the back end of it. But the more you try to remove it, the risk will be much higher. So finally, I would like to say, for most of the meningioma, this is true. Every effort should be taken to understand where it's coming from. So tells you where the structures are displaced and where the cisterns are displaced. And the principle of meningioma remains the same. Be careful about the sinus invasion, especially falcotentorial and torcular meningiomas. And sometimes you may have to make a judgment call about how much you have to remove, especially on the veins or on the brainstem. And the main thing is to have a strategy even before you operate, and that is more important. Thanks very much.
Thank you, Dr. Ramesh, for this excellent presentation. Is there any question?
Can I just make one comment, Same?
Yes, sir, for sure.
Ramesh, very beautiful demonstration of, coming from above as well as from below. The thing, as you very correctly mentioned, is to take care of the calcarine sulcus, calcarine gyrus. And I think the best way is the positioning. I think positioning is the trick. You hardly have to use the retractor. If you do sort of ipsilateral, where the tumor is the largest, if you keep that side down, though it appears very odd to begin with, it works out beautifully. And I think that is one key lesson I have learned for this occipital transtentorial approach.
Yeah, absolutely right, Chandra. And occipital lobe, even with any pressure and condition, there will be some temporary transient. But if you have kept it intact, I'm sure those patients will recover in course of time.
Yeah.
Thanks very much.
And luckily, all the veins, as you correctly said, they are not major veins draining into in the last 6-7 centimeters at least.
Yes. Yeah.
Towards the torque.
Thank you.
So,
thanks.
Dr. Amit, can I ask one question to Dr. Ramesh?
Okay.
Yes, sure. Hi, Kuntal.
Hello, Dr. Ramesh. How are you? Nice to see you after a long time. Yeah.
Yeah, I know.
So wonderful presentation and very nice videos. So I just have one question. Sometimes even the positioning also doesn't lead to that much of brain laxity. So do you use lumbar drainage in your practice for some of these cases?
Yeah, so Kuntal, thanks for reminding me, because I should have at least pointed out that the external ventricular drain for that big case that she came with hydrocephalus, she had papilledema. I didn't do a preoperative external ventricular drain when she came in. I waited because she was clinically well, waited for an operative. Because these cases, when you open up the occipital lobe, they are quite full. So I generally tend to do an external ventricular drain from the occipital lobe rather than a frontal EVD. I don't tend to use a lumbar drain for such cases. I think you can do it, but there is always a concern that even though you don't drain the lumbar drain for these sort of big tumors, the act of putting the lumbar drain in, they are at that point where you have the 2He needle in, you can let off a lot of CSF by the time you get your trocar back in. So I think it's probably easier to put an external ventricular drain in my case. And especially if you're using navigation, even without navigation, when these cases have big ventricles, it'll be easier to use the same position and same location to put an external ventricular drain. But in this case, I had an external ventricular drain, which I removed 48 hours later.
Thank you. Thank you.
Thank you, Dr. Ramesh, once again for this very nice presentation.
Thanks, Ame, for this invitation.
Discussion. Thank you. And now we'll shift to next speaker, Dr. Kuntal Das. Please start sharing your screen.
Thank you. Thank you so much. So I'm going to share my screen. Let me know if you can see it. Can you?
Yes. Yes.
So yes,
Perfect.
thank you. Perfect. Yeah. So thank you very much, Dr. Sameh and Dr. John for organizing this meeting. And a very good morning to everyone in the panel as well as our participants. So we all know that we are here today to celebrate the life of the great man, the Professor M. Gazi Yaşargil. And as it is said that all men would eventually die, but there will be very few who actually live. So Professor Yaşargil is one of those few people who have truly lived his life. And whatever we are doing as neurosurgeons, either we have come in direct contact with him or sometimes not, but we are all actually following the path that he has shown. So thank you, Professor, for everything that you have done. And you'll always be there amongst us, and you will always continue to inspire generations which will follow. So thank you so much. And with this, I begin my presentation. So there are no disclosures with this presentation of mine. Some of the materials that I've used are from our published work, and all the patient videos that you'll see here have been used after patient consent. So I'm going to talk to you about aneurysm surgery, something which Yaşargil was very fond of. And I'm going to talk to you about subtle nuances of anteroclinoid process removal in paraclinoid aneurysms. So the paraclinoid segment of the internal carotid artery is this segment, the C5 and the C6 segment. And aneurysms in these locations constitute around 5 to 15% of all aneurysms that we see. And we can see this bony aligned structures over here. You can see quite a lot of important structures which arise and are located in this location. And dealing with an aneurysm in this crowded space could be really challenging. And these challenges are mainly because of this intra-extracranial transitional zonal architecture. Secondly, several bony and ligamentous projections and attachments which kind of make the structures taut and do not allow sufficient mobility. And of course, we have got very, very important structures like the optic nerve, the anterior cavernous sinus and its nerves, as well as the ophthalmic artery. So we can see there are a lot of anatomical impediments into this area, and we need to have a great microsurgical skills in order to tame this dominant adversary. So before I go in, I'd like to take you through a short video of how we do the extradural anteroclinoidectomy. But before that, let me just take you through, for the sake of our younger audience, the anatomy of the anteroclinoid process. Here you see this is the anteroclinoid process, which is nothing but the medial extension of the sphenoid ridge, specifically the lesser wing. Here we see we have the optic canal on the medial side, and we have the supraorbital fissure laterally. So basically it has got three attachments, as you see. The attachment one is actually the continuation of the lesser wing. The attachment number two is what we call as the roof of the optic canal, which attaches this anteroclinoid process to the plenum sphenoidale. And we have this optic strut. This optic strut is generally not visible. And as you see here, this is located between the optic canal and the supraorbital fissure. So in order to take this anteroclinoid completely, we need to detach all these three roots. Then we're in a position to take it out completely. So I'll take you through a short video. This was actually a tumor case, but the steps here would give you a perspective as to what are the techniques of taking the clinoid out completely through an extradural route. So we have a right-sided frontotemporal craniotomy done here. Now, what I want to emphasize is doing a posterior orbitotomy is very, very important. You see the posterior orbitotomy being done here. Now, the advantage with this posterior orbitotomy is it allows you to put in your dissector and see where the optic nerve is located from within. This is much easier than finding it out from lateral side. Then we have the meningioorbital band. Now, sharp division of this meningioorbital band after its coagulation is very, very important because you'll see that the anteroclinoid process is actually hidden in the dural fold. So this duplication opening is very critical, and it requires sharp dissection. And here we see that the anteroclinoid process has been completely exposed. We have the optic canal out here. Now, we use nowadays a no-drill technique of optic canal deroofing, where we use a ronger, because drilling can sometimes lead to heat injury. We can see the optic nerve extradurally located. We see here the optic strut. The anteroclinoid process is progressively reduced in size, and it is very important to drill this optic strut, which is between the optic nerve and the supraorbital fissure, and the drilling has to be end-on. Now, once this structure is drilled sufficiently, the clinoid process becomes quite mobile, as you see, and gradually it is teased out, and this is the optic strut over here, and it is removed, and we see the beautifully exposed area here. So this is how an extradural clinoidectomy is normally done. Now, any discussion on aneurysm surgery will inevitably have this question: why a surgery? Why not endovascular? Now, this question is pertinent. And if you look at this particular paper, which looked at the results of microsurgery versus endovascular treatment, in particular for the paraclinoid aneurysms, you'll see that as far as cure, that is complete obliteration in the long run of this aneurysm is concerned, surgery definitely has advantages over endovascular treatment. But as far as the safety profile and complications are concerned, definitely the literature shows that endovascular treatment is probably safer than surgery. Therefore, the need of the hour for microneurosurgeons, what Professor Yasergil would expect from us, is to improve the results of microneurosurgery so that we can keep on giving this benefit to our patients, the high rate of cure as well as a safe outcome following a surgery. Now, we all know why anteroclinoid removal is important here, and I'm not going to go into that. So what I'm going to stress upon is the technical nuances, like whether it should be intradural or extradural, because this could be important, because vision loss has been described to be a very common with extradural clinoidectomy, anticlinoidectomy. Then whether or not we should go for a complete or a tailored clinoid removal. And thirdly, is only anticlinoid removal enough, or do we need to do something else? So over the next few slides, I'm going to show to you some cases of mine just to impress upon this technical details. So let's see which are the situations which are tailor-made for intradural tailored ACP removal. I'll start with this case on the left side. You have a 70-year-old female with a right-sided temporal lobe hematoma and an aneurysm which is projecting into it. She was WFNS grade 4. As you see, the aneurysm is actually a PCOM aneurysm, but sometimes even a PCOM aneurysm can be very close to the skull base, called the low-lying PCOM aneurysms, and they need to be dealt with like a paraclinoid aneurysm. So here an intradural approach was chosen. The brain was quite full. You see the ICA optic nerve, carotid optic space. And you can see the ICA is so short over here. That is why the aneurysm was close to the skull base. So in order to mobilize the carotid here and to expose the aneurysm, we need to do some at least partial clinoid drilling. Here you can see that the clinoid is being drilled. This is the outline of the anticlinoid process. This is the aneurysm here. So although we are able to see the aneurysm, but we need to have a good proximal control. We need to be able to put a temporary clip here. So for that, we need to make some space. So intradural partial clinoidal drilling here allows us to put a temporary clip. You can see the ICA is very much atherosclerotic, and you can see the fetal PCOM here. So this partial clinoid drilling allowed us to make the ICA mobile, put a temporary clip, and to be able to put a permanent clip across the neck by visualizing the fetal PCOM. Subsequently, the hematoma was removed. And these are the post-operative scans where we see that the aneurysm has been completely dealt with. So this is one situation, and this is the patient in the follow-up. Now let's look at another situation, a 65-year-old female with, again, SH. And here we see that there is a medially directed paraclinoid aneurysm, possibly suprahypophageal. So in this patient, we took a neck control. This was one of our earlier cases. Now our strategy has slightly changed now, which I'll show. So a T-renal craniotomy, one of the greatest contributions of Professor Yasergil, was performed. Here we again see the crowding of the structures. The falciform ligament is released. And we proceed with the intradural tailored clinoid removal again by cutting the dura and reflecting it over the optic nerve and the carotid. The drilling is conducted. It has to be done with a lot of irrigation because there could be heat transmission to the optic nerve. Now, this allows us some kind of mobility of the carotid artery. We put a temporary in the neck. The aneurysm is dissected well. And we are able to put a right-angled fenestrated clip, taking the ICA into the fenestration. And the kind of mobility this tailored removal of the clinoid allowed us, we could occlude the aneurysm completely, as you see here. And the laminate amylase was open to let out some CSF. And we can see hemostasis. This is the patient at 7 years follow-up. But even though this case could be done completely, but I would still say that the kind of exposure it provided was probably not adequate. And we are no longer doing intradural clinoidectomy for paraclinoids in our recent years. So what these two cases tell us is intradural clinoid removal, partial removal, is probably best justified when the need is felt only after durotomy, like, for example, some PCOM aneurysms. Otherwise, we like to do it nowadays in combination with extradural clinoidectomy in some cases, which I'll show later. Now, nowadays, our preference is to go for an extradural complete anticlinoidectomy with a complete release of the carotid 360 degree. Just to tell you how we do it, we have this 33-year-old female who presented with headache for 1 month. It was an unruptured aneurysm, a decrease in vision in the left side. We see a medially directed giant aneurysm, possibly a dorsal wall aneurysm here. We do a T-renal craniotomy, then do a posterior orbitotomy again. The frontotemporal dural band is opened. It exposes the clinoid completely. We can see the optic nerve. We remove the roof of the optic canal by a no drill technique. Here, the optic strut and the ACP was pneumatized. So this could be a blessing in disguise in that it makes your clinoidectomy easy, but at the same time, you can have postoperative CSF leaks in such situation. So the anticlinoid is removed completely. This is the optic strut. Now it is very important to remove the optic strut. Otherwise, you cannot control the C5. So this is the C5 segment, that is the clinoidal segment. We try a trial temporary clipping. We open the dura close to the skull base. Now it is very important to release the optic nerve completely, as you see here, then open the distal dural ring. The optic nerve is completely released so that the tension is not transmitted. Now we have the clinoidal segment of the ICA. Posteriorly, we have the dorsum celli over here. So it is very important to dissect 360 degree, otherwise your clip will not go. The PCOM was rudimentary here and it was divided. It was divided to allow dissection as well as to improve the clipology. So we put a temporary clip, and I see this shows that there is some backflow. So we needed to put 2 clips on the ACA as well as M1. And with the aneurysm completely trapped, we applied a series of clips. As you see, an aneurysm like this would require several clips. Here, it is important to preserve the choroidal artery here. So using a series of clips, this aneurysm was completely obliterated. The enterochoroidal was preserved, and a small nubbing of the aneurysm was accepted at this point. ICG shows patency of the ICA, and it is very important to close with fat the opening that was created. Postop angiogram shows near complete obliteration of the aneurysm, and the patient is doing well with improvement in the vision. A small nubbing here can be seen, which was deliberately left to preserve the enterochoroidal. This is the patient in the postoperative period. She is doing well. The ocular movements have all come back. So a pneumatized optic strut, as I said, could make clinoidectomy easy, but the repair has to be very meticulous. We prefer a nodal technique of the optic canal so that the vision is not adversely affected. And as I said, only clinoidectomy is not enough. You need to release the DDR as well as you have to do a 360-degree IC dissection. Now, when a combined work is necessary, I'll show you this case, a 59-year-old lady with a right-sided medially directed aneurysm. What I want to tell you is, look at this projection of the clinoid into the sphenoid bone. So this kind of situation is known as middle clinoid process and keratoconclinoid foramen. So in a case like this, complete external clinoidectomy may be hazardous. So we go with optic canal deroofing extradurally, as you see. The optic strut is drilled. But unlike the previous case, we are not able to remove the clinoid completely. So we leave the clinoid at this point. The C5 segment is dissected. We have the proximal dural ring. So we ensure that we have a proximal control here. Trial temporary clip is done. Now we open the dura, release CSF. The dural opening is again close to the skull base. Now, after opening the dura with the IC under vision, we go back to this area. Now we are able to release the clinoid completely. So this kind of combined intra-extradural work may be necessary in such cases. We join the extra and the intradural compartments of the ICA. We have the full control on the C5 and the C6. Now, what I want to emphasize is it is very important to remove the optic strut completely here. Otherwise, your temporary clip will not go, and the clipping may become difficult. We are able to dissect the aneurysm now, and able to put the clip across it. Once the clip is placed, it is important to ensure, like any other case, that the clip has completely occluded the neck. We ensure that the clips have passed across. An ICG is done to ensure that the aneurysm is completely grown, and the aneurysm is then decompressed. It is very important, otherwise the patient will have persistent visual deficit in the postoperative period. And the postoperative scans show complete aneurysm obliteration, and the patient is doing well. So if a keratoconclinoid foramen is recognized preoperatively, we should always go for extraintradural combined job. Coming to the last case of mine, another case again. Here you see that the aneurysm is located in the dorsal wall, and it is very close to the clinoid. And some surgeons are wary that a complete extradural job here could jeopardize the aneurysm and there could be rupture. So in this patient, again, we went for a hybrid job. We did a posterior orbitotomy. And in the extradural phase, we just did optic canal deroofing. This was one of our earlier cases. We no longer use drill at this stage of surgery. So the optic strut and the clinoid is left for the intradural surgery. Dura is opened and the cilium fissure is opened and the CSF is let out. We have the optic nerve. And once this dissection is done, we expose the areas of interest, the A1, the ICA, the MC here, and this is the aneurysm you see. And this is the distal dural ring and the falciform ligament. So the rest of the clinoid is now removed intradurally. The dura over the clinoid is cut and the dura is reflected. The optic canal was already derubed extradurally. So all you need to do is now remove the optic strut, which is being done here. The optic strut is removed, is drilled. Now the clinoid becomes free and we are able to take the clinoid out completely. So this exposes the C5 segment, the aneurysm, and the C6 segment is already there. We can see the amount of mobility that we have gained as a result of this clinoid removal. Now we are able to do a 360-degree dissection. This is a C5 segment. We are able to go behind the aneurysm as well. We have the angiogram showing the complete exposure of the structures of interest, and eventually a clip is applied across the neck. And these are the postoperative scans. So in some cases like dorsal wall aneurysm, one can again choose for a combined intra-extradural job. So to sum up our recent experience, we'd like to say that extradural clinoidectomy in paraclinoid aneurysm is safe, and we generally attempt it in all cases, except for certain cases, for example, low-lying ICP-COM, or sometimes in the presence of a keratocondyloid foramen, we may have to combine it with an intradural exposure as well. In our practice, neck control is only taken only when we plan to do a suction decompression or a bypass. Otherwise, it is not used. It is very important to minimize drilling over the optic canal because it can endanger the vision. And extended optic strut removal as well as circumferential release of the IC is very, very important apart from antroclinoidectomy. So at the end, I pay my homage and respect to a professor who embodies what a complete neurosurgeon should be, an excellent surgeon with excellent dexterity, a kind-hearted doctor, an innovator, educator, and researcher, all packed in one. And out of all his qualities, what stands out as the most remarkable attribute is his ability to teach generations of neurosurgeons like us. And as this saying says, that a teacher actually affects eternity, and he can never tell where his influence will stop. So thank you, Professor. Thank you for everything. And I thank all my co-panelists, Dr. Sameh, for this opportunity. And this has been a real privilege for me. Thank you so much.
Thank you, Dr. Das, for this very nice presentation. Is there any question?
May I speak? May I make a comment?
Okay.
Sure, please.
Thanks. Thanks, Gunther. That was a beautiful talk, and the operative cases were so beautifully done. I agree with everything you said, and also thanks for the opening the orbit before you do the clinoidectomy. Yeah, I also alternate between the extradural and the intradural approach, and then the advantage of intradural clinoidectomy is that it's a tailored approach, especially for low-lying PCOM. You don't have to. You need to only expose whatever you need to. And there's something else I just want, and also thanks for bringing out the issue about the middle clinoid and the carotid clinoid foramen, and also emphasizing it, because sometimes when people do not look for it, and then once you feel that they've taken the clinoid and they start some mobility, they tend to pull it with some instrument. If there is an attachment, that acts like a sickle and then can potentially damage the carotid. So important to look for it in a CT scan beforehand. And by the way, the last case, was it a ruptured case or an unruptured case? It looked like a ruptured aneurysm.
Thank you for your comments. The last one was a ruptured case, but it presented slightly late to us. So that is why you could see a lot of clot stuck to the aneurysm and a lot of thick subarachnoid blood. So the point I want to make is, as microneurosurgeons, we need to emphasize on improving our skills and making sure that the complications are minimized and trying to find out why the complications are happening. So as I've showed in the literature review, surgery is still the best form of treatment as far as these aneurysms are concerned. Any day, anywhere, any literature you find out. The only problem is probably the complications are high. So we need to ask ourselves, can we reduce the complications? Can we enhance our skills more in order to reduce the complication? I think this is where the direction, where we should be heading, taking cues from what Professor Yaşargil has shown us through his work throughout his lifetime. And I think this mode of treatment will still remain relevant, and it should not be, just left as such. We should not forget clipping. I think this will be a great disservice to the humankind if this happens. So this is what my appeal is to the neurosurgical community. Let us not stop clipping. Let us still keep on clipping, and let us improve ourselves. Let us make the line bigger, Let us show our results. Let us publish. Let us do much better work. That is what I want to say. Thank you.
Very fitting, and it's a fitting tribute to Professor Yasergil as well. Thanks, Punta.
Thank you so much. Thank you.
Thank you. Is there any other question? Thank you, Dr. Desso, this very good presentation. And I have an announcement that we are planning for 100 webinar for 100 day in collaboration with Neurosurgical TV, and we will back to you with more details in coming days. And now we will shift to next speaker, Dr. Rubish Kumar. Please start sharing your screen.
Thank you, Professor Same, for this wonderful initiative and the opportunity to speak for the legend. Is my slide visible?
Yes.
You want to put it on presentation mode, please? Yeah, perfect.
Yes, fine. Okay. So thanks again. So I will touch upon a topic which is close to Professor's heart. The STA-MCA bypass and how it was done and how it was invented and how there was some downfall and how we are adapting it now again. So as we all know, Professor Theo Pujari showed this slide when Professor came in 2008 to India. So we all had the golden opportunity to interact with him very closely. And Professor was on his knees and he was very tirelessly, he taught us for 3 days continuously, 10 hours per day. And so I was as a very young neurosurgeon there standing behind him and looking upon him as our mentor and legend. So as we know, Professor Yaşargil, the STA-MCA bypass, vascular neurosurgery was very, very close to his heart. And when Professor started doing in experiments in dogs, that was in the small vessels, he presented his work in a radiology conference, an international radiology. And there he met Professor William Sweet and Theodor Rasmussen, and who were inspired by his work, experimental work on dogs. And they advanced him to meet Professor Donagis to learn more of microvascular work. So from then in 1965. So this is a photograph where Professor Yaşargil moved to Professor Donagi at the University of Vermont, and he started doing experimental work on microvascular work and microvascular anastomosis. And then eventually after he moved to Zurich, again, he did the first ever STA-MCA bypass in the year 1967 in a patient with a Marfan syndrome who had a complete occlusion of the MCA. And this patient did very well. And so that was the beginning of an era of microvascular anastomosis for the many neurosurgeons. And subsequently, he went ahead and he published his work, the first 9 cases where he did STA-MCA bypass, all for atherosclerotic disease, of which 7 were for occlusion of the IC and MCA, and 2 as an adjuvant for surgical treatment of complex aneurysms. And that was very well accepted, and he taught the world how to do and how the indications. He also did the first STA-MCA bypass for a Memoriam disease in 1972, and a patient had a very remarkable improvement for a 4-year-old child. So that began and the entire work of STA-MCA anastomosis. And then the further journey of STA-MCA bypass, it was now adapted by many neurosurgeons at that era, where it was also extrapolated to acute stroke and emergency revascularization was done. And Professor Turel and Jafar studied 67 cases with an emergency STA-MCA bypass, of which 27 patients improved and 26 patients unchanged. The 11 patients died. And then they concluded that a patient with crescendo transient ischemic attacks, mild to moderate deficits, less than 6 hours of onset of stroke, and no obvious infarct, they're ideal candidates for this emergency STA-MCA bypass. Subsequently, this bypass was extrapolated to cerebral vasospasm, which is one of the dreaded complications after any aneurysmal SAH, And Professor Badger and Sampson reported on 11 cases of doing STA-MCA bypass for symptomatic vasospasm to reduce the morbidity, and 6 patients improved after the 11. But however, these techniques, indications slowly faded away as the endovascular techniques emerged. And so it was not much done. However, the work on Moyamoya disease continued to have. But then we all knew that there was a downfall of this technique because of this trial on STA-MCA bypass by the North American study, which was conducted between 1977 to 84, which failed to demonstrate the benefit of STA-MCA bypass over the best medical management. Though this study was a lot of flaws and there were a lot of criticisms, and subsequently a St. Louis carotid occlusion study was done, and with using the hemodynamic factor, oxygen extraction factor, but that also did not show much benefit. But then subsequently the COS study, which is a recent one, the 2011, which also failed to demonstrate the benefit. But what really happened? Why was their study was not showing proper results? But there are a lot of flaws in the study, though it was well conducted. But then the results were very much argued and debated, and though there was a clear improvement of the oxygen extraction factor in patients with the STA-MCA bypass, the study did not extrapolate well because of the following factors. The major flaws was the study was that the rate of recurrent stroke in the surgical group was 9% compared to 22%. So this is a very significant thing, because almost half the reduction of strokes are happening in the study. But what really put the study down was that the early postoperative strokes was quite high in this arm of surgical group. So that probably brought down the results. So it was not really a really good study, and there were a lot of flaws. That was why it was criticized quite well. And it also excluded patients with symptom recurrence despite medical management. Whom are the real patients who will benefit from this STA-MCA bypass? And this study never took the cognitive function into consideration. They took only the motor deficits as. So that is why this study, though it was done, it was not very much attested. Subsequently, Japanese group came out with this study, Japanese ECIC bypass trial, and they demonstrated very good benefit of STA-MCA bypass in patients with significant hemodynamic factor. And the risk of recurrent stroke are 5% compared to 14% with medical group. And subsequently, they all went to do the part 2 study, JET2, where the first study, JET1, was for significant hemodynamic compromise. For JET2, it was for mild hemodynamic compromise. There was not much benefit. But for moderate and severe hemodynamic, the STA-MCA bypass really benefited. We never considered the dementia part in the patients with occlusive disease, and in the chronic occlusion patients, not only this, we are thinking about the motor problem, even the cognition is also important. By STA-MCA bypass, we do improve the cognitive functions, at least prevent the retardation of that. Where are there no controversies in the Moyamoya disease? We know that the STA-MCA bypass really doesn't need to be discussed about, because it has a very established treatment. We also have now a lot of endovascular technique coming up. Those aneurysms which are giant and complex, as an add-on, we do bypasses for a good reconstruction. And for skull-based tumors resection, we can also do bypass to prevent a vascular deficit after parent vessel occlusion. So these are no controversies technique in these two indications. However, what is more interesting and what is more controversial, I'm going to speak now. So this is a 60-year-old female who had this recurrent TAAs on medical management, and she was put on best medical management. She was quite well. Few months later, she presented to the ER with this dense weakness, and we can see that the whole hemisphere infarcted. So now, whether at this point of time when she presented itself, whether we could have augmented the flow, because we can see that the right ICA is completely occluded, and we can see that there are a lot of watershed infarcts. So this means that this is a significant hemodynamic challenge. So this patient, at this point of time, if we could have done a bypass, probably we could have prevented this patient to develop this major stroke. Again, and one more example of a 45-year-old male, you can see that there is a thinning of the MCA. The ICA is absent on one side. What is the patient presenting is with a cortical watershed infarcts? Again, there are some amount of deep watershed infarcts. This patient subsequently, even though on best medical management, ended up with a large stroke like this. So again, the question comes, whether this patient, if we could have done an STA-MCA bypass, whether we could have prevented a major stroke happening in this patient. So now, with these two cases in the background. I'll just discuss the stroke burden in our country. In India, you can see the stroke is one of the very common diseases which we see encounter on a very common basis. And we have not only mortality, the significant, the most common cause of morbidity, even though this is a common disease, next to only myocardial infarction. So we can see that the internal carotid artery is completely occluded, and that is quite, these patients can be asymptomatic for some time till they develop a major stroke. And we can see that this is the study done in India again on the internal carotid artery, and we can see that only 70% of population has a normal carotid artery. And the carotid occlusion, complete occlusion is seen in 15%, and with moderate and mild stenosis in almost 8 and 6% respectively. So these patients with complete occlusion and moderate occlusion, they go on to develop these hemodynamic strokes. And in mild to moderate, we have medical management. For a complete carotid occlusion, there's not much to offer because medical management is not really going to help, because these are not thromboembolic strokes. These are hemodynamic strokes, and that is where the crux of the problem. Whether we need to do bypass in these patients or we just need to continue medical management is the question. But most of the time, what cardiologists do is that they try to reduce the BP to protect the heart, but that hits the brain. So when the BP comes down, that normal perfusion pressure comes down in these patients with complete occlusion, they develop hemodynamic strokes repeatedly. So what are the hemodynamic stroke? How it is different from thromboembolic strokes? Thromboembolic typically occurs in the vascular territory, whereas hemodynamic stroke occurs in between the vascular territories. That concept we should understand. So that's why you can see that. So these are the watershed infarcts. So this is between the STA-MCA territory. This is between MCA-PCA territory, and these are the deep watershed infarcts between ACA, MCA, and PCA. In a patient with a hemodynamic stroke, we see these white chronic infarcts not in the vascular territory, but in these watershed zones. So whenever we see a watershed zone infarct, we need to be very, very careful in studying the further imaging to know what is happening to the vessels. So we can see that. So these are the deep watershed infarcts, and whenever we see these type of mosaic pattern, we need to be alert ourselves and then study the vascular imaging to know what is really happening in the patient.
I am Georgian from Ecuador. Sorry,
Sorry, please, George, mute yourself.
Yeah.
Okay,
so
I am listening the
John.
To
John, please mute John.
The better neurosurgeons of the world.
Okay, which person is this?
George Jarin.
George Jarin from Ecuador, Quito, Ecuador.
Please mute yourself.
Any minutes.
Yeah. So what we can see that, so we see these type of mosaic pattern. We see this type of a mosaic pattern of infarcts, and we can see that very clearly seen, and we can see that these patients have complete occlusion. So you see that they're not having significant, they're just having watershed infarcts. So these are the patients whom we have to work up significantly. And here we can see that this patient has a complete ICA, and this patient we can see that the MCA is occluded, and these patients present with these watershed infarcts. What is more important is that these patients, when we do a perfusion scan, we see that the whole hemisphere looks hypoperfused. So this is what the importance of doing perfusion scans in these patients to know really what is happening. So which are the group of patients who are prone for these hemodynamic strokes? One is this extracranial carotid stenosis, and these patients benefit from either endarterectomy or carotid stenting. There is no controversy in that. Again, a complete IC occlusion can also present with the hemodynamic stroke, and here is the maximum controversy. Whether to do bypass or whether to continue medical management is a major question. In a patient with Moyamoya disease, again, they present with hemodynamic stroke. Again, no controversy. We can go ahead with doing bypass or EDAMS. They do benefit well. Intracranial atherosclerotic disease, again, a gray zone, a complete M1 occlusion or a very tight M1 stenosis. When these patients develop recurrent stroke, what we need to do. So on one end, we have very clear indications, a carotid endarterectomy or STA-MCA bypass for Moyamoya, and two other spectrum where there is a complete IC occlusion or a complete M1 occlusion. We do not have data supporting whether we need to do the best. So here, we need to tailor the patient's needs, individualize the treatment based on the patient's needs. So what is really happening? So little bit to understand why some patients develop symptoms, why some patients do not. Whenever there's a chronic occlusion of a large vessel, we see that these patients develop collaterals. But these collaterals are not symmetrical in all. In some patients, their collaterals are sufficient, so they go on to develop normal life without much symptoms. In some patients where the collaterals are deficient, these are the patients who develop symptoms. They go into the stages of hemodynamic failure. And these are the patients whom we should identify, work up a bit more and know whether the collaterals are sufficient or insufficient. So the circle of Willis is incomplete in majority of patients. It's complete only 25%. So that is why there is no trial or no study can clearly tell us whether an STA-MCA bypass is going to help a patient with the common completion or not. Every patient has to be individualized and tailor monitored. So we have stages of hemodynamic failure. In stage 1, the autoregulation is intact, CBF is maintained. In stage 2, autoregulation is exhausted, the CBF is reduced, but then metabolic compensation occurs by extracting the oxygen more. But in stage 3, it's complete exhaustion, CBF is reduced, oxygen extraction reduced, and these are the patients who develop symptoms and stroke. As I shown, the first 2 patients were complete occlusion causing stroke. Now, how do we work up these patients and how do we know which are the patients whom we should do bypass and which patients we do not? So we have the acetazolamide challenge test. What is acetazolamide is that it produces intense vasodilatation. So in a normal patient, when you give acetazolamide, there's a 30 to 60% increase in the cerebral blood flow because of vasodilation. But in a patient who already has a chronic occlusion, already the vessels are in dilated phase. So the Diamox, when you give, they cannot dilate more. So what happens is instead, the normal vessels dilate, the already dilated vessel, there is a shunting of blood flow. We call that is a paradoxical response. This is the graphical representation. So you have a stenosis here, and we can see that when we give acetazolamide, beyond the dilated segment, the vessels shunted after Diamox. So there is a paradoxical reduction of blood flow in a patient whom already there is a chronic occlusion. So those patients are really going to get affected by this. And so these are the patients who really benefit from STA-MCA bypass. So how do you interpret Diamox challenge? In type 1 patient, they have normal cerebral blood flow, which increases after Diamox. In type 2 patients, there is a baseline cerebral blood flow, which is reduced, but increases after Diamox. In those group 3 patients where there is a reduction of cerebral blood flow, and when you give Diamox, there's a paradoxical reduction in the blood flow. So this group of patients are the ones who really need brain bypass in the patients with chronic occlusion. I will take you through examples. You can see this is a 42-year-old female who presented to me way back, who had a large cavernous, neck aneurysm, which is extending the cavernous sinus. I just did a simple Hunterian ligation. She went on well for the next 10 years. After 10 years, she presented with my headache and recurrent DAAs. And when we did a DSA, we can see that the left IC is already occluded. There was a reduction in the compensations, and we can see that there is a capillary delay. And this patient, we did a SPECT with the Diamox challenge. And we found that after Diamox, we can see this is a type 3 response where there is a significant cerebral blood flow reduction, which got paradoxically reduced after Diamox. So we went on to do the STA-MCA bypass in this patient. And this is the post 6 months after the STA-MCA bypass. We can see that from type 3 response, it became type 1 Diamox response, as you see here. So this patient went on to do well, and she's still in our follow-up. Again, this is a 37-year-old recurrent TAAs. We can see that the left M1 is chronically occluded, and we can see that there is some amount of compensation from the vertebral basa and the ACA collaterals, but they are not sufficient. And this patient, again, we did a SPECT Diamox challenge, and we did an STA-MCA bypass in this patient. And we can see that this is the STA-MCA bypass working well. And this is the 4D trans MRI images. You can see how nicely, we need not do DSA in these patients post-op. You can see this is good MRI. You can see that this is very specific sequence called trans. You can see how the STA enters into the MCA and perfuses the whole brain. So these images can be of help. We can avoid invasive investigations, follow-up surgery. And we also do a perfusion in these cases. We can see that the perfusion typically increases immediately after a STA-MCA bypass. This patient presented with a slight hemiparesis on the right side. On the left side, what we see in the MRI is just a watershed infarct here. And we can see that the ICA is completely occluded. We do a perfusion scan, and we can see that not just the small areas, the whole hemisphere is hypoperfused. So what I call this as a tip of iceberg phenomena. What you see in an MRI, regular MRI, is what you see is a small watershed infarct, but when you do a perfusion, you can see a significant amount of hyperperfusion. And so these are the patients whom we did an STA-MCA bypass, and we can see that immediately after that, the perfusion typically improves. So these are the patients who are generally definitely indicated to do bypass patient, and this patient went on to do well, and he's still on our follow-up. Again, 42-year-old male working in Middle East, he had acute onset weakness, and then he was airlifted. We can see that the clinoidal ICA is near completely occluded here. And we can see that the perfusion, not only on the ipsilateral, even the contralaterals was showing hypoperfusion. And we can see that we did a sort of a rarely semi-emergency bypass in these patients. And we can see that immediately after bypass, how the perfusion improved significantly well, and the patient went on to have a normal life. This is again a limb shaking TAA in a 42-year-old male. You can see that the right AM1 is completely occluded. There's not much of collateral. There's a capillary filling delay between both right and left. And we can see that the perfusion image is showing a significant hypoperfusion in the right side. And we did an STA-MCA bypass. And we can see that typically the perfusion improves after the surgery. And we can see the bypass, again, patient completely recovering well with a normal life. Again, multiple such examples. You can see that the 32-year-old male, very young male, he has vasculitis. You can see that the right membrane is completely occluded, chronic infarct, exact dilatation, and you can see also had some cognitive dysfunction. And we can see this patient was on medical management, presented to our ER with a further stroke. We can see not only in the ACM-MCA territory, also in the MCA-PCA territory, left hemiparesis. And then we can see because of the not much collaterals, this patient continued to develop stroke. And we did an STA-MCA bypass in this patient. We stabilized this infarct. So there was some amount of a cortical reperfusion, and whatever the old infarct stabilized. This is a very, very interesting finding. So I see here that at 1 year follow-up, you see how the STA on the left side, this is a normal STA, the right also was like that. After the bypass, the hungry brain takes up more blood, and the STA also dilates over a period of time to give cerebral circulation to the whole hemisphere. So this is the importance and advantage of an STA-MCA bypass in these patients. This again is a limb shaking TAA in a patient. You can see that this is the video. You can see that the right ICA is completely occluded. I just show you most of the time these patients are mistaken for seizures. And you can see that. So this is the typical limb shaking TAA, what we see in the hemodynamic stroke. And we can see that we did an STA-MCA bypass in this patient, and we can see that the post-op, a good amount of perfusion improving in these patients. Not just in middle-aged people or young people. This is a 72-year-old complete M1 occlusion, atherosclerotic, and we can see that the whole right side circulation was hampered. And we can see that we did an STA-MCA bypass, and there was a progressive improvement in the perfusion. And we can see that, and she was back to her normal routine domestic life with activities of daily living after the perfusion. So not only in young patients, even in old patients, these patients do well, improve well with this type of reperfusion. This patient is a young middle-aged female presented with acute dysphagia, right hemiparesis, and we can see that the multiple watershed infarcts. We did an STA-MCA bypass, and we can see that this patient improved quite well. This is a very interesting case of an ITP, patient with idiopathic thrombocytopenia purpura, and here at tight stenosis of M1, they were planning to do a stenting, intracranial stent, but then he needs to be put on antiplatelets. Because we already had an ITP, the patient was referred to us, considering that we can at least do an STA-MCA, we will be able to stop antiplatelets after 3 months. And we went ahead and did STA-MCA bypass. And we can see that. So we gave aspirin only for a very short period of time. After 6 weeks, once the perfusion was improved, we stopped, and then this patient continued. So these are some indications where we can always go ahead and do. And not only in fact, in adult myomia patients, these patients have IVH, and so these patients also, this patient has not a real myomia disease, but myomia syndrome. You can see this left side was normal, right ICA completely occluded, and this patient presented with an IVH. And then this patient, we went and did an ICA-MCA bypass, and we prevent this. You can see that the typical shrinking of collaterals after the bypass is done, and then we are preventing further IVH. Can we do emergency STA-MCA bypass? This is a patient, software engineer, who presented with acute onset dysphagia and left right hemiparesis. And we can see that the right ACA had probably a thrombotic occlusion, chronic occlusion with a supraorbital thrombus. And this patient was initially admitted in the ICU by neurophysician, kept the BP high. Whenever the BP was brought down, he became more symptomatic. And so our neurophysician asked whether we will be able to restore, do a flow augmentation. And we did an STA-MCA bypass, and then this patient stabilized. So So this is the typical indication for an emergency STA-MCA bypass. I'll show you one more example of a 65-year-old female who had presented with the right side hemiparesis and dysphasia. And what was interesting in this patient is that the left ICA was almost completely occluded, the right ICA was occluded, the left vertebral was occluded, the whole cerebral circulation was just depending only on one vertebral artery on the right side. So this patient, we went ahead and we did an STA-MCA bypass emergency on the left side, and we could restore the circulation. And we can see that a 3 months follow-up, she was reasonably well managed. So the hemiparesis was improving, and she also improved. This is a very interesting case of a left ICA dysplastic aneurysm. Patient underwent a flow diverter with coiling. She was well for 1 week. And then after 1 week, she presented in the casualty with the right hemiplegia and aphasia. And we could see that the left ICA was, the stent got thrombosed, flow diverter, and she presented with an emergency situation. Our endovascular colleagues tried to open up the vessel, but they couldn't. And then we had to do an emergency STA-MCA bypass, double barrel anastomosis. And then she quite improved well. And we can see that the 6 months follow-up, we can see though the IC is occluded, we can see how, again, a typical example of how an STA can dilate to accommodate and give the circulation to the whole of the hemisphere. So again, this is a very, again, interesting case, one of the last cases which I show you. This patient, gentleman, presented with some mild dysarthria and mild hemiparesis. And we can see that the M1 was diseased. And this patient was put on antiplatelets, and he continued to do well. But when you have some follow-up with the neurophysician, we can see that the M1 slowly got completely occluded. We can see that there is a further thinning, and this patient developed mild symptoms, but he was put on medical management and he was doing well. He presented to us with a different reason, who had acute sciatica with a synovial cyst, and we can see we had to operate on him. And we can see immediately during the induction, there was a slight drop in the BP when he woke up with a dense hemiplegia again. We can see that the MC1 was occluded, the whole hemisphere was hyperperfused, and we had to go ahead and do an emergency STA-MCA bypass in this patient. Unfortunately, and he improved after 3 months, and you can see he was back to his normal state. Again, an insurance bypass, what we call, this patient had a dissection of the M1, and we can see thinning. We did a bypass for this patient, and we can see that the STA-MCA bypass could restore this vessel. And we can see that this is an insurance bypass, and so we can see the whole perfusion of good improvement in the perfusion. So we can also do on-table assessments. This is a typical example where we do the STA-MCA bypass. We can see that the immediate improvement as compared to the other surrounding vessels, which takes time for reperfusion. So I just go to conclude my talk saying that it's not a given up chapter. For a chronic atherosclerotic IC occlusion, not all patients are candidates for medical management. In spite of medical management, there are some group of patients who continue to develop CAS and stroke, and we have to work up these patients and find out who are the beneficial. So this is one of the recent study which was published in the World Neurosurgery, and you can see that the long-term stroke rates had a favorable outcome in a group where surgical revascularization was done. My personal experience goes to close to 88 cases in the last 20 years, close to 20 years. Initially, I was doing SPECT CT perfusion, and now I'm doing MR perfusion for all these patients, and with the Diamox challenge, and to assess whom are the patients who can really benefit. No new infarcts in 85 out of 88 patients. You can see the reasonably good results. One patient died during the COVID time. It was after 6 years, and 2 patients had a mild stroke in the immediate post-op period, but they went on stabilized. So, and this is some of my publications on a relook at the bypass on patients with chronic occlusive disease. And to conclude, Professor's contribution to STA-MCA bypass was remarkable, and this is where we stand on his shoulders to extrapolate the indications and to do further. And what Professor highlighted in his first case was a chronic IC occlusion, MC occlusion. And so, though there was initial enthusiasm, it faded away, but then I think there is a resurgence of this technique, and now a lot more centers are taking up STA-MCA bypass for these patients. So there is definitely a role for a chronic occlusive disease, where when we do properly evaluate them with the Diamox challenge, identify who there is a definite role of a revascularization in these patients. So thank you very much again, Professor Same, for this opportunity.
Thank you, Dr. Ubish, for this excellent presentation. Is there any question? Thank you. And now we will shift to next speaker, Dr. Kiran M. Please start sharing your screen.
Uh, Good morning, good afternoon, good evening. Can you all see the screen?
Yes, please make it full mode.
Presentation mode, please.
Yeah.
Put it in presentation mode.
I think it's in presentation mode now.
Perfect.
Yeah.
Thanks.
Yes. Okay. Thank you. My talk is a little deviation from the previous other talks, but it is important considering that we consider Yasergil as one of the masters. So always the question, what used to perplex me was, what is mastery? Is it something innate, or it is somebody who is born with it, or can it be learned? And I reflected upon my own life and many lives of masters, and I studied, and these are the reflections which I would like to share. This is one of the drawings from alchemy. That is where, previously they wanted to convert all metals into gold, and this was, even though they could never achieve it, it resulted in huge discovery of, many chemicals, and led to what is now we know as modern science. So let me start with a life question. Here, one of, in Arab countries, I think Samay will be knowing it. In village, they will host a feast every once a week like that, and anybody can attend. And one of the Sufi master, along with his pupils, attended these feast. And there it is a convention that you ask each person, who are you, what is your name, which family, which tribe you all and belong. And looking at that, this Sufi master went into a pensive mood and he started thinking. And one of his students asked him, "What is the problem, master?" Then the master asked, master was said, "How tragedy it will be if I know all these things, if I don't know who I really am." So this is the question as a professionals we always tend to ask and we should reflect upon. Many of you know about Mahabharata war, where there is a combination of two people. One is Arjuna, who is a real technical master, and a Lord Krishna, who was who represents ethical and higher values. If anybody asks who was responsible winning this war, everybody will say Krishna, but he never shot even a single arrow. So the mastery involves not just, master of the trade, it involves the master of life. And many of the masters we know are not just masters in trade, they also are masters in life, and learning from them will be a good lesson. This is one of the scenes from a real good Chinese movie which talks about mastery. It's a martial art which is derived from martial art. It is called Hero. The martial art mastery is at 3 levels. The first level is mastering a weapon as if it is an extension of your fingers. This is what we do in microsurgery. After a few years, it almost becomes like our fingers we do it. At second level is where your heart and the weapon all become same. So what you intend to do with the patient, it happens. Whether it is a difficult tumor or whether it is anything, when your intention is there in the heart that, okay, let us do good to happen to the patient, automatically the results improves. We have seen the previous, some of the most difficult surgeries, but many of them have done. Third, when there is no weapon at all, and our mind and patient mind works as a sync, and this is where we decide to do what is good and what is best for the patient. There is a master's hierarchy, all we know. We start with the self or what is called as satisfying our own ego, and next we move to a profession of learning, contributing. Then our circle expands to include friends, society, and family. So this is one of the famous book, Mastery by Robert Greene. I would like to quote from that. I've taken many from many of the popular books and their summaries. I acknowledge them even sometimes if I have not mentioned in this talk. First is your calling, but I feel in a profession like ours, the calling comes little later. Apprenticeship, that means, and be an ideal apprentice, what it means to be, and learning from mentor and cultivate social intelligence. Next stage, we move to creative activity where we become multidimensional. We start inventing things, new procedures, and new ways of approaching things. And then we combine the intuition with rationality. This is where somebody says his intuition says this tumor, something can go wrong. That intuition can be believed only when he has achieved some sort of mastery or he has achieved some experiences. Otherwise, it will just be like astrology. And finally, the calling comes. So I have learned many of these things from many of the places where worked, right from Bombay Hospital, Nimhans, Amrita, Narayana, and the present where it is Chinmaya. The first is a deep observation mode, that is a passive mode. We learn to imbibe as much as knowledge, whether from book, whether from surgery, etc. Next is skill acquisition, where we do residency, and ultimately the experimentation mode, where we know that there is something beyond what is already written or what some people do, recognizing the limitation in the current model. This is what prompts, as we saw in Yasergil's own studies, or whether he did STA-MCA bypass, aneurysms, etc. Apprentice, this is where one of the best models is there. Unfortunately, it is being weeded out, but many studies have found this apprenticeship is the most efficient and productive form of learning. Otherwise, we'll end up doing many literatures, many things, and ultimately we'll go on. How it is effective is we choose the mentor who best fits your needs and connect to your tasks. And we should have a sense of humility, and we should work on ourselves and improving our knowledge first, rather than commenting this is good, that is bad, etc. So we can have more than one mentor at different aspects in our or different levels in our life. And of course, it can be beyond books also, like how we are doing literature and etc. Absorb the master's power. It is a dynamic, it is not just static. So we need to observe, we need to spend time. That is where this fellowship, residency comes into play. In fact, even we can imbibe knowledge when we are having dinner with the master. And we need to look behind the man, the thoughts of the man, their idea, their feeling, and how they express, whether to the patient or into the life. This is what makes interesting. This is a story where one of the favorite students of Buddha, Ananda, once asks, "Master, have you told me everything?" Buddha replied, "I've told everything, but have you listened?" Many a times we comment that, oh, our teacher has not taught this, etc. When we reflect back upon, they would have taught us, only we were not mature enough to receive it. Then we move to the next of strategy for creative active phase. That is, we need to listen to our own authentic voice. What exactly we need to do? I spent about 10 years before I chose, skull base, endoscopic, and CV junction as my area of calling. Similarly, each person's will have. Concentrate on the areas that will give you best yield. Superior craftsmanship, that is, action speaks better than words. And we should develop what is called as multi-dimensional thinking. We should not be having dogmatic approaches. We should see many things, whether it's endoscopic, microscopic, or is it SRS, different approaches. And this is where what we call the modern alchemy comes into play. Don't jump to specialization early in the life. And strategies now to attain the mastery. First is we need to connect to your environment. This is where the most powerful, whether it is surgery, whether it is patient, we need to connect to them and feel that and try to get the maximum. And always try to play to your maximum strength, your focus, and where you can contribute, or where you feel your hands, your skills are best suited. And transform yourselves to practice, continuous practice, whether it is cadaver lab or fellowships, attending, seeing, etc. And internalize the details. That is what we need to do. And widen our vision. We need to widen our vision to different approaches, different places where they do their cultural values, how they develop this. And we need to submit to others. We need to have that humbleness even at we are very experienced, and we need to learn and synthesize all forms of knowledge. And ultimately, this is what we may not get the gold enough, we'll get something which is worthier than gold. They say the mastery takes about almost 20,000 hours to master any craft. And once we know, this is a short thing about finding your purpose. This is one of the books which I have taken and I want to share with you. Whatever written you expect is proportional to your time and work. So you cannot say I want expectation more and give only less time. It doesn't work out. And which is not only work, family is also important, because time spent with family is important. There is very important study which shows you cannot choose work now and family later. We say, oh, now I'm in initial phase, I will do a lot of work, neglect my family, and then choose family later. By that time, the family will be independent of you. When you say I want them, they will no longer be in your house and you will be all alone. So have a purpose and choose what exactly do, and segregate your priorities. You can't be master of everything. You need to have that integrity and say, okay, this much I can do. I need to concentrate on family so much. And this is the book I was talking about, from which I've taken. How will you measure your life? This is from a famous motivational thinker and business who introduced the term disruptive thinking. That is Christensen. Before he died, this was one of the last lectures, and what I quoted was from his book. And what he says is important is relationship, experiences, what you can accomplish and what you can accomplish, and continuous learning. That is what gives you happiness. And wealth, it need not be only physical wealth, it can be health, mental well-being, etc. And what you can contribute to yourself, your family, friends. Ultimately, it will lead to happiness. Another beautiful thing I learned about is have a metrics for each one of these. It's not that, okay, I want to contribute to relationship and keep quiet. Say how much you want to take your family, what time you want to give to your son, you want to take him to a movie, holidays, what exactly, you should have a metrics for that. So even in work also, we should have a clear-cut metrics to measure our accomplishments. And ultimately, I want to quote from Mark Twain, who said, two most important days in our life are the day you are born and the day you find out why. That is, in our Hindu custom, there is a Dvija, we call, that is twice born. When we go into study proper, then they say that we have become twice born. Similarly, to live is one thing, but to love is another, which is at a higher level. And the need to learn and legacy is the ultimate. And another thing about purpose, that is some of the misconception I read. Purpose is not one thing, one time, okay, I have this purpose. No, it is a thing you build on as you mature. Today, my purpose may be to become better in surgery. As you grow, the purpose keeps on maturing. And purpose is not a single thing, and it can be changes over time. And it's not what you do, it's how you do that matters. And clarifying your purpose as a leader is critical, because your action speaks more than your words. And ultimately, I leave this with a small quotation from a book by a gerontologist, Cal Pilmer, who interviewed many people, volunteers from in their prime of their life, by 80, etc., 70. And what his 30 lessons were very surprising. Not one single person said it is important to be at least as rich or wealthy as the person around you. We we like to acquire wealth and all, but at the end of the life, it matters very little. And no one, not a single person said you should choose your work based on your earning power. Ultimately, it is what gives you satisfaction. What they did value were quality friendship, being part of something bigger than themselves, spending quality time with their children and family and loved ones is what ultimately matters in life. Thank you very much.
Thank you, Dr. Kiran, for this motivational lecture. Is there any question? Thank you. Now we will shift to next speaker. John, could you please play the record of Hasegawa? Hello?
Yes.
Hey, hello.
Yeah.
Okay, so you can't screen share. Okay, let me see if I can get your.
Okay.
Thanks, and sorry for the inconvenience. I'm actually driving now to move from hospital to hospital, so please start my video presentation. Thank you.
Thank you, Yaşargil.
Okay, I'm sorry it takes some time. I'm working on it. Um, Okay, let me go back to my mail. Just 1 second. Okay. Okay, can you see it
Good
okay?
afternoon. It is a great honor to speak at this special Zoom
Can you
meeting
see it
with
okay?
Memoriam of
Yes, please raise the volume.
Okay.
the legendary Turkish neurosurgeon who forever transformed the way we approach the brain. My name is Hirotaka Hasegawa from Saitama Medical Center, Saitama Medical University, Japan. Today, I would like to share with you our journey from microsurgery to endoscopic microsurgery, transcending traditional limits and redefining surgical standards. Professor Yaşargil is widely known as the father of modern microneurosurgery. He introduced the surgical microscope to neurosurgery, pioneered safe access to deep-seated lesions, and established key techniques for aneurysms, AVMs, and epilepsy. Most importantly, he championed microanatomical dissection, a philosophy grounded in precision and a profound respect for anatomy. His legacy continues to guide us today. Professor Yaşargil said, surgery is art and science. His approach was never just about technique. It was about anatomy, precision, and the profound responsibility we bear as surgeons. I had the great privilege of meeting him in person in 2016 when he visited Japan to give a lecture at the Keiji Sano lectureship in Tokyo. I still remember the strength in his voice and the clarity in his message that every movement under magnification should reflect humility, excellence, and a deep anatomical understanding. His spirit lives on each of us and in every microsurgical and endoscopic movement I make. Professor Yasergil described surgery as a conversation with nature, grounded in anatomical respect and precision. Building on that legacy, I now focus on endoscopic transnasal surgery. It offers a direct midline route with minimal bone retraction, a clear anatomical advantage over conventional approaches. However, traditional ETS has its challenges. Narrow working space, one-hand limitations, and restricted precision around critical structures. These limitations led us to evolve the technique toward what we call endoscopic microsurgery. So this is the concept of endoscopic microsurgery, combining endoscopic visualization with microsurgical principles. By expanding the corridor and enabling bimanual dissection, we can perform delicate handling of nerves, arteries, and brain structures, just as we would in traditional microsurgery. This approach allows us to tackle intradural skull-base lesions with the same precision and control, but through a minimally invasive route. One of the major complications of endoscopic transnasal surgery is CSF leakage, which can lead to life-threatening meningitis if not properly managed. The incidence varies significantly depending on the grade of intraoperative CSF flow as classified by Professor Esposito. In high-flow cases, the risk may exceed 10 to 30%, making reliable skull-base reconstruction absolutely essential. To prevent CSF leakage, no single layer is insufficient. The first key is a multi-layered reconstruction. We use a combination of materials and techniques, starting with intradural and inlay grafts, which is sutured in a watertight fashion, then only fascia, rigid support, and sphenoid mucosa. You can use a fat if there's a large dead space, otherwise sealant to secure everything, and sinus and nasal packing. Second key is watertight dural closure using a fascial patch and a suturing technique. We use either multiple interrupted stitches or continuous sutures. This technique is not only technically feasible, but also highly effective in preventing CSF leakage, even in high-flow Esposito grade 3 cases. In our recent series of 50 consecutive high-risk cases, we had only one CSF leak, which was due to balloon self-extraction, not reconstruction failure. This highlights the importance of active watertight closure as part of multi-layered repair. For deep skull-base lesions, precise approach planning is critical. This is a large pliable epidermoidal cyst which is encircled by cranial nerves, brainstem, cerebellum, and a temporal lobe and bone. While we would have to get through the cerebellum and the temporal bone and handle the cranial nerves through the retrosigmoid approach, transnasal corridor would give us a direct access to the tumor without being interfered by critical neurovascular structures. What is true, it can be difficult to imagine how it looks during surgery. In such situation, precise 3D simulation play a significant role to preoperatively check the surgical access to this deep skull-base lesion. So this is a 3D simulation created using a grid, which was invented in the University of Tokyo by our colleague. Now let's move on to actual surgical cases. As I showed, this is a large pliable epidermoidal cyst in a 29-year-old man. You see, this is a large pliable opening, and after cutting through the clival dura, you can directly see the basilar artery, and this is the 6 cranial nerves. On the other side here, and using the 30-degree endoscope, you can remove the tumor up above the through the nerve and tip of the basilar artery. So this is the lateral side cranial nerve, 7th and 8th, 6th nerve, and 5th nerve. And After that, you can do multi-layer reconstruction using the Dural and Fascia, which is sutured, this time used using the 4-0 strata fixed spiral continuous suture here. And then you can just cut it out. So this is a nice reconstruction, and some septal bone for rigid buttless and fat and fibrous glue to fill up the space, and covered with nasopharyngeal flap. And finally, some sealant is added and nasal packing.
What happened? Are we okay here? Um, let's see. Hold on. I'm sorry, folks.
Next case is a large craniopharyngioma in a 52 years old woman. This time, I selected transplant tracheal approach with hemihypophysectomy. After the dural
John, we don't see the
and the superior hypophyseal artery, and this is nicely resected. And you see some PCOM and its perforator inside the tumor. On the other side, I dissected the tumor from the third ventricular floor. And this is a P2 and a PCOM on the other side. And this is the posterior arm perforating arteries from the top of the basilar artery. Again, the left side, this is a PCOM and its perforating arteries, which is meticulously dissected. On the other side, I dissected the tumor from the third nerve and the P2 here. This is the T2 and the part of the anterior artery, and this is the posterior artery from the top of the basilar artery. Again, the left side, this is the PCOM and its perforating arteries, which is meticular, finally dissected completely off of the tumor. And now the tumor is being dissected from the P2 and its perforating arteries, and now the whole tumor is out. Again, the left side, this is nice show that the patency of these vascular structures confirmed using the ICZ video angiography. Now, again, the reconstruction is used with the watertight suture, PET graft,
John,
the
we
fascia.
didn't see the video. Please start sharing your screen.
And the post-op scan shows the complete tumor removal. This time, there is a very small diffusion high intensity spot here, but as you can see here, the patient recovered well without any weakness.
I'm trying. Sam, we're gonna have to go to the next one.
Okay, John.
Sorry.
Okay. Dr. Nursing Rao, please start sharing your screen.
Yes, yes.
Hasigawa, we will
Am I
back to you
audible?
again.
Am I audible?
Yes. Yes.
Yeah, good, great. Is my presentation on the screen? One moment.
Still not.
Okay, okay. I need to share. Give me a moment.
I click share first button, share.
So I had talked about endoscopic transnasal surgery for median to paramedian tumors. Next, when I want to remove tumors lateral to the cranial nerves and the carotid artery,
We don't see the video. We don't see the video.
Endoscopic transcranial.
John, please mute yourself.
This is a large petrocranial meningioma causing trigeminal and abducens.
But what's happening for me is that I'm unable to find where is my share.
After radio surgery, so severe adhesion to the brain was anticipated. I chose an endoscopic anterior transpitulatory approach to minimize invasiveness, starting with 7 cm skin incision and a small 3.5 cm craniotomy. I exposed the Kawase triangle and did transpitulous circulating with a partial mastoidectomy to
Yes, it's coming.
the off-meter triangle for
It's coming?
exposure.
Yeah.
After Dural
They are seeing your screen.
and
Yeah.
Tentorial incision,
Yeah, is it
John,
better now?
I
John,
detected
please mute yourself. Okay. Okay, Nasim.
Yeah.
You can.
Yeah, you're able to see me as well as my presentation, I guess.
Yes, please
All
go
right.
ahead.
So I'll go ahead. Thank you. So first of all, at the outset, I want to thank from my bottom of heart, Dr. Same, for this organizing this wonderful meeting in the memory of Gazi Yaşargil. It's a pleasure. It's an honor. I'm privileged to be part of this meeting, and definitely it's addressing the August audience like this and memorizing Gazi Yaşargil. Yeah, I feel really honored. So I chose the topic of a bloodless field in surgery for Cavanoma Meningioma. So I'm from India. I'm working in Hyderabad in India. So the field of Cavanoma Meningioma surgery is always bloody. We all know it's a highly vascular tumor. So I try to propose the technique by which you can make the not completely bloodless, but to some extent the loss of the blood or the oozing of the blood can be controlled. So before I start the topic, first of all, definitely as a resident and the student, when I was a student at the age of 2008, I just finished my residency just three years before. Then we were all told that Gazi Yaşargil is coming to Mumbai, a place in India, to the Bombay hospital. So we were all, these are all my colleagues. You can see my juniors and my classmates. We were all excited to see him because till that point at the time, we would just listen that Gazi Yaşargil is a person who has done extensive surgeries in neurosurgery. And not only that, he has written volumes of 4 volumes of microsurgery. But we were all excited to see him. We all booked the tickets and we went to this meeting in 2008 on 14th and 15th March. And here we see the Doyen. He entered the hall and the program would start from morning 7:38 till 8 o'clock in the evening. He would not give even a space for us to have lunch or, something like a break between the meetings, which usually happens in the meetings. He would not give. And he has shown extensive videos. I hope I am clear and audible. Is my voice is clear?
Yes,
Getting some sound?
Yes,
Yeah.
it's okay.
So that this meeting, I still remember because those 2 evenings which we spent with Gazi Yasergil was wonderful, and it's a lifetime experience. So there were serial snaps of the photographs. Here is my colleagues there. We were all taking the photographs with Gazi Yasergil, and everybody was rushing to get the snaps with him. Whoever were lucky, they had a chance and was taking, and we had a dinner time, wonderful time with him. Here I am in dinner with him, and you can see the enthusiasm of these 2 young neurosurgeons listening to the every bit of a word what is spoken by him. And those 2 days we can never forget. And today we do not have a wonderful personality like Gazi Yasergil with us, but it's an honor and a privilege, of course, to be part of this wonderful meeting. Thank you once again. So coming to my topic, there are some highly vascular tumors in the brain when we operate. Sometimes we anticipate this preoperatively, and sometimes you don't. So the classic histologies which present with highly vascular tumors, the moment they touch, they bleed, and they create a mess in the field. They are hemangioblastomas, Cavanoma hemangioma, the topic which I will be highlighting in this talk today. And glioblastoma multiforme, sometimes they bleed hell. Meningiomas, especially atypical and malignant meningiomas, hemangiopericytomas, and rarely the vestibular schwannomas, who are sometimes can be very vascular in metastasis, predominantly from thyroid. So these are the tumors which will have a lot of blood in the field. And the cavernous sinus hemangiomas are relatively rare tumors, and they are highly vascular and extraaxial masses. We all know they are predominantly in the cavernous sinus region. Surgical option is becoming the second line option, because the smaller tumors respond fantastically to gamma knife. So when these lesions are diagnosed early part, they can be irradiated with the gamma knife. But of course, cavernous sinus hemangioma, when it's large, when the surgical option is also a good option, but we need to be prepared for operating within the blood. So this is a paper from the previous institute where I worked, from NIMHANS. There are the multimodality management of cavernous sinus, which shows that both the options are really good. But when the tumor size is small and amenable for gamma knife, the results are best. This one case I'm just presenting as a technique to how do I control my bleeding in cavernous sinus hemangioma surgery. A person whoever has done the surgeons, this is a rare tumors to operate. It's my privilege that I could get some 4 or 5 cases of them. And this lady unfortunately presented with a chronic disabling retroorbital pain, the most classical presentation which they will have, with the drooping of eyelid for 1 year and double vision, and a right complete third nerve palsy, as you can see in the clinical examination video like this. So when I am asking her to see to her left side, the right eye is not moving, and a complete right third nerve palsy, something like a frozen eye, is seen in this presentation. So this is the imaging. We have typical classical features of cavernous sinus hemangioma. Uniformly hyperintense lesion. There you can see the ICA is pushed anteriorly. And the contrast is you see that the brilliant enhancement of the lesion is seen. This is the Petrus ICA, and this is the cavernous ICA, and the ICA which is pushed anteriorly, and beautiful enhancement with the smooth margins, the more classical features of the imaging features of cavernous hemangioma. These are the preoperative images shown. This is the ICA which got stretched by the tumor. Just a moment. I just want to show we have a CT film which shows, yeah, here is the, this is the important thing. This is the ICA which is there, which is stretched. As you can see, this is the MR angiofilm. Yeah, in the CT, as you can see, the lesion is large, and you see a large anteroclinoid process, which I will be showing in the surgery also. We need to create a space here, so it was difficult, and the ICA is totally stretched out by the tumor. These are the two or three important points to see in the preoperative imaging. These are the preoperative images, which shows the ICA is totally stretched out on right side. So this is an operative video. I'll just go through this small video. It shows that I have done a cranio-orbitozygomatic approach. Of course, zygoma I didn't remove in this, only the cranio-orbital approach was being done. And the sphenoid wing, which we all know is the main crux, which we have to take it out. This is the orbital opening, which I'm making on the right side, frontotemporal craniotomy, along with part of the orbital removal. This is the keeper hole point. And after that, when I went inside, I see that anterior process is quite long. I would just like to pause and just show that this is the right-sided approach. This is the orbit which is exposed, and this is the frontal lobe. This is the temporal lobe, and I'm cutting the meningorbital band to just orient. So here you see the frontal dura is being removed, dissected off from the frontal base. This is the meningorbital band which I'm cutting. And here is my clinoid process as shown in the image. It was quite large and it was difficult for me to really get the total clinoid out, but I did a partial drilling to some extent extradurally. Then I moved on to, as I told you, it could not be completely removed. Then I moved on to the coagulation of the middle meningeal artery in the foramen spinosum. The pure skull base approach, as we all know, in all Cavanoma sinus tumors, we have to do this. This is the middle meningeal artery being identified and coagulated. As you go on, we need to expose all the roots of the trigeminal nerve. This is the identification of the GSPN is being done. As you see in the photograph that the V3, V2, and V1 portions, I had to expose it. This is the foramen rotundum being drilled, opened up widely to expose now with the V2. This is the opening of the orbital fissure. So here I'm delineating the clinoidal segment of the ICA after the partial clinoidectomy. I'm using a Doppler to identify it. So this is the large cavernous sinus hemangioma, which is seen here. But what happens is that you cannot expose the tumor completely. And over about 50% of the tumor can be exposed, as I shown in the diagram. Once you start dissecting, what happens at one point, you cannot go to this plane. So you need to open intradurally to really get the feel. So here I have opened the dura, and this is the extradural portion which I've exposed. And I'll be joining this point with the extradural exposure. So that's how you remove these kind of large tumors. And here you see what you are seeing is that the last bit of the anticlinoid process, I had to go intradurally and remove it completely because it was unusually long. So this is the ICA. This is the optic nerve, which is seen there after the cylinder pressure opening. And then this is where I'm telling the technique of making the tumor. Till now, the tumor was not vascular in the sense you are going around the tumor, but you have not entered the tumor. And here, I thought that I have thoroughly coagulated the tumor. And here you see what happens once you want to really touch the tumor. This is the tragedy of Cavanoma sinus hemangioma. It bleeds hell. It would not allow you to go around the tumor until unless you do the internal decompression. Of course, you can do it with CUSA, but the thing is that the field will be very bloody. And what I did in this case is that I thoroughly coagulated to the extent. Now you can see that I can dissect the tumor. I can cut the tumor without any so the thing is that this is the technique. You need to really coagulate to the extent that you can mobilize it like something like meningioma. So here, what I'm dissecting is the branches from the ICA, and these are the neurovascular structures which you can easily dissect it off once you can do the internal decompression. But despite that, the last portions of the tumor would still bleed, but this is okay. most of the tumor, you can remove it by overcoagulation. That means coagulating with a broad tipped bipolar, and you keep on coagulating to make it completely charred so that the vascularity is reduced and you can make it. This is one technique which I found to be really useful, and the patient was doing. This is the post-op scan, which shows the complete removal, and the removal was only possible through this technique. Previously, the cases which I was doing, I wouldn't coagulate to the extent of completely lack of blood in the field. So this technique of overcoagulating the tumor, I find, is really useful, particularly in cases the tumors which are very vascular like this. So this patient post-op didn't have any post-operative neurophysiological defects. Thank you very much for the opportunity. And also, I thank Dr. Sami from my bottom of my heart. Thank you very much for your attention.
Thank you, Dr. Rao, for this very nice presentation. Is there any question? Thank you. John, could you please share your screen again?
Okay, you got the screen sham, right?
I need to stop this screen.
Yes, yes.
Yeah, got it.
Okay, what needs to be done, Sam?
Play the video of Hasegawa from case 2.
Okay, who needs to be featured? Okay, we got him on the screen. He has to share the screen.
Yeah. Share your screen.
Yeah, Narasimha is presenting, correct?
No. We
Who
are
is
waiting
presenting?
we are waiting
presenting?
for you.
Who is presenting, Sam?
We are waiting for
My
you.
presentation is over.
Okay.
Play the video.
Okay. Okay, Sam, what are we waiting for? Sam?
We are waiting for record of Hasegawa. Could you please play it from your side?
Okay, Sam, I'll make you host and you pick who you want, okay? Okay, Sam?
John.
You're making,
Share-
okay, you're the host, Sam. You pick who
Share
you
your
want.
screen.
Okay.
Okay, share your screen. Open.
Sam, you're the host now. You have to pick who you want, okay? You're the host. Pick who you want, Sam. Sam, are you going to pick who you want? Oh, man. I'm sorry, folks. There's problems in Egypt with the internet. Go ahead, Sam. Are you going to go?
Okay. Please check WhatsApp.
Sam, are you going to pick someone? You're the host.
Okay, Dr. Suresh.
You're the
Suresh.
host, Sam. Will you pick who you want?
Okay, Dr. Suresh,
Can
could
I
you
come?
please start? Could you please start?
It's okay. You have called myself or somebody else?
Yeah, yes. Please share your screen.
I am Suresh Nair. Can I share my screen?
Yes, please.
Okay, thank you. I will. Are you seeing my screen?
Yes.
Oh, thank you. Thank you very much. Okay.
Perfect.
Okay, fine. Okay. So at the outset, let me thank Professor Samir for inviting me for this great lecture, which we are paying our respects to commemorate the great deeds of Professor Gazi Yasergil, whose work really reshaped the field of microneurosurgery. And today, say I had the good fortune of visiting his department many years back at Zurich. And this is the issue of Neurology India. This is the premier journal from our country, which this article got published yesterday only. This journal, which is the premier journal of neurosurgeons. And I was fortunate enough to write with my colleague obituary of Professor Yasergil. And we all learned so much microsurgery from him. And let me start. So this is one area Professor Yasergil's microsurgery techniques flourished, because you cannot have any, take any risk with the spinal cord, because all the tracts which and white matter and gray matter are all very vital. So I don't have disclosures and intramedullary tumor. It has got so much intruding factors, and sometimes it will be very difficult to diagnose whether it is a tumor from history. There are so many mimickers of intramedullary tumor, and deciding the nature of tumor from imaging may be extremely difficult. Then are we allowed to give radiation without histology? And what is the best route of entry into the spinal cord? What is the role of frozen section? How much tumor to be removed? What are the strategies for ependymoma, hemangioblastoma, and even astrocytoma? These three are the commonest tumors. Is there any role for adjuvant radiation? Let me highlight quickly on this. Starts with the clinical vignette where a patient presents to us with muscle ache, cramp, subacute onset of weakness. Spasticity is not grade 0, hyperreflexia. Upgoing plantar, this is the image. And you can see CSS space around, you can see hyperintensity inside the cord. Obviously, the diagnosis with this subacute onset presentation was not a tumor. And the CSF study was done to see whether it could be the first episode of multiple sclerosis. And it was not helpful. Oligoclonal bands were negative. And again, the differential diagnosis remain whether it is a tumor or a demyelinating lesion. Ultimately, neurosurgeons were asked to operate. And we did midline myelotomy. It was firm tan tissue. Frozen section was gliosis. Ultimately, it came as inflammatory infiltrate, and it turned out to be a multiple sclerosis only. So diagnosing intramedullary lesion from MRI sometimes becomes extremely difficult. But what clue is there? Cord appears enlarged when a tumor is present. Of course, in inflammation also, in early stages, cord can get enlarged. And these are some other reports which have come, spinal cord biopsy, when to do. And there have been various reports of spinal cord inflammation presenting as neoplasm, and vice versa. Intramedullary neoplasms presenting inflammatory lesions presenting as tumors, and tumors presenting as mimicking inflammatory lesions. So we have seen all this, and what are the pathological entities which can really fool us? And these are the things which can, other than glial neoplasms, you get so many other pathologies, non-neoplastic intramedullary lesions. And if you look at this intramedullary, this picture, what is written, seen in this white, these lesions are notorious for mimicking a tumor. And if you see, most of it are demyelinating lesions. Of course, a sectorial astrocytoma can come. Other tumors usually don't come in the sectorial location, and other common is ischemia. So MRI, a sectorial lesion, chances of having an astrocytoma is not very great. And if you look at axial section again, most of these mimickers, especially this is a mimicker, transverse myelitis or neuromyelitis optica, even long segment multiple sclerosis, they can mimic a tumor. Of course, these things can also mimic a sectorial astrocytoma. If you look at the long segment lesions, in a long segment lesion with swelling, if you see on MR, again, if you see, most of it is transverse myelitis, neuromyelitis optica. But when there is a swelling, other than transverse myelitis, you could suspect a tumor also. So if you see, there are many mimickers of intramedullary tumor. And these are some of the mimickers of intramedullary tumors. Most of it are inflammatory lesions or demyelination. And the thing is, symptoms not specific to spinal cord tumor may be present in any myelopathic process. Because of slow growth, symptoms precede tumor discovery by an average of 2 years. And this is a typical chart of multiple sclerosis. You know, so most of this multiple sclerosis, they have this relapsing remitting pattern, but occasionally they can be primary progressive, which can mimic like a intramedullary tumor. So what is it is, you know, an acute or subacute clinical course is always characteristic, and especially if there is systemic involvement like lupus erythematosus or like that, you should suspect a infectious or para-infectious pathology. But with demyelinating lesion, this is occasionally could be progressive and recurring. So what are the steps to identify intramedullary spinal cord tumors? First is cord expansion. Cord expansion always suggests a neoplastic pathology. It is very unusual for an inflammatory lesion. Then enhancement. Although all spinal cord tumors show some enhancement, the converse is not true. And you know the pattern of enhancement in ependymoma, astrocytoma, all of us know. Ependymoma have uniform, while astrocytoma have a patchy enhancement. And the location of enhancement also, you know, tumor is ependymoma is central, astrocytoma is eccentric, hemangiobastoma is pile-based. And fourth is tumoral cyst. You know, you have two types of tumoral cyst. One is tumoral cyst and non-tumoral cyst. Cyst located at the poles of the solid portion always represents a tumoral cyst. And these are not part of the tumor, but it should be a reactive part. And there's, if you can always sometimes see a mural nodule with the cyst. Cysts are not usually seen with inflammatory lesions, but they are very common in both astrocytomas and ependymomas. These are some of the things which are very important. Significant cord enlargement is rare with non-neoplastic lesion. A ring enhancement is not often seen in intramedullary tumor. It may be due to cord infarction or radiation myelopathy. Unlike brain tumor, ring enhancement for intramedullary tumors is extremely rare. Most intramedullary tumors demonstrate either a homogeneous or heterogeneous or patchy enhancement. Non-neoplastic lesions have more rapid presentation. These things I will not tell because all of us know where is the location, characteristics of ependymoma, astrocytoma, and the differentiating features between that. And other common is pile-based hemangioblastoma. You have to look whether these patients are having VHL disease. And this is an important slide which I have got from somewhere. So you can see two lesions, both mimic each other. So it's one is astrocytoma, other is ependymoma. If you look, these spines are all of a pediatric patient, so more likely this is astrocytoma and this is ependymoma. The what message I am telling is pre-operatively, it's very difficult to identify from a MR image whether it is ependymoma or astrocytoma. All the time you should go there thinking that my patient is going to be a ependymoma, I will be able to take it out totally. So there is the timing of surgery. Normally, I don't do surgery if the patient is asymptomatic. I wait for some symptoms to develop. So the thing is, management philosophy is assume pre-operatively that lesion is benign and plan for total removal. You should not predict histology from MRI. So if you do just a small myelotomy and take a biopsy from the surface, it will be usually inaccurate, and pathologists will tell it is a glioma because they are biopsying. This surgeon may be taking out glioma tissue from surrounding. So surgeon, what he should do, should see for clear dissection plane, and every attempt should be made to remove the tumor if there is a good dissection plane. Best approach is either through posterior midline, or if it is appearing superficially, you can go directly subpially from there. Ependymomas, always I used to do a midline approach, astrocytoma depending upon imaging. And always you can see this dorsal veins usually won't be in exact midline. So normally how we judge midline is by the roots entry zone of either side, and you look for posterior median septum. You can see these vessels, the blood vessels diving into the septum. So this is what is in simple diagram. You do a myelotomy. You have to do myelotomy over the whole length of the tumor. Open the spinal cord like a book with pile traction sutures, and then take a biopsy and send it for frozen section. If frozen section, the pathologist confidently tells it is a malignant astrocytoma, then there is no role for radical surgery. There are some differentiating features between astrocytoma and ependymoma, but usually polar cysts are present in ependymoma. It is very easy to start dissection and get into the correct plane from that location. And what I do is, you do decompress the tumor with micro-QSA. Once it, just like any other surgery, tumor starts folding in. The ependymomas are unencapsulated tumors. There is no capsule. If you hold it, it becomes friable. But you can decompress this thing, start folding. You can get into the plane and lastly take care of the vessel coming from ventrally. So in astrocytoma, many astrocytomas can also be removed because you get into some plane. But if you lose plane, you should not chase. You have all this monitoring, which I am not going to tell. All of us use this muscle evoked potentials and D wave, but IONM is not a substitute for poor surgical technique. Look at this, is a large astrocytoma. You can see tumor is actually pushing the medulla up. It is not, medulla is not getting infiltrated. It is pushing the medulla up. And see what I have done. Say this patient, I hope the video I can show. Yeah. So this I have already taken the tumor from the cervical cord. Fortunately, this astrocytoma, there was a plane of cleavage with the cord which I could take out. I have put that area covered with cotton. Now I am going to the medulla. There is some tumor in the medulla, and I have done a myelotomy over the medulla. You can see this tumor is easily coming out. So this happened to be a staff nurse. So I could remove this astrocytic tumor because I could get into the dissection plane and take out the tumor in total. And you can see the whole thing opened out like a book, and the whole tumor came out. And then we closed with the pile sutures. Let me go to, so many a time astrocytoma can be removed if you get into a good dissection plane. It is not always true. I'm sorry, this is coming again. I'm sorry, 1 minute. Yeah, and this is the patient immediately after surgery, after 2 days in the ward. A patient could walk without problem. So now this is a case of ependymoma. If you look, this ependymoma, this is the pons, this is the medulla. This is exactly in the cervicomedullary junction. You can see the tumor is occupying whole of medulla. But then this again happened to be a staff nurse. So I went and operated on this patient. I knew that patient is here again, put pile traction sutures. You can see tumor. Open the spinal cord like a book and then you get into the dissection plane. It's very easy. Ependymoma, if you are in the correct dissection plane, you can take it out post-op scan. And this is the patient had a tracheostomy because I had to open the medulla there. So this patient also did extremely well and went back for work. Look at this tumor. This is a large tumor, which is ependymoma, which what we used to do in later years. We never used to do a laminectomy. We used to do this laminotomy. And you can take the bone. It will prevent the post-operative curvature problem. Then do this myelotomy, get into the plane, put pile traction sutures, and you can, with sharp dissection, you can get into the interface between the tumor and spinal cord and take the whole tumor out and then close with this suture. And this patient also did extremely well. This is the patient after surgery. And I will skip this video for want of time. I just want to show one image of a girl student is ependymoma. You can see tumor is occupying the whole girth of cord. You can see cord is this dark thing. We advised this girl surgery. She refused. She went home, came back in respiratory distress. I went and operated. This patient was on ventilator for 3 or 4 months. But I remember this day when she came to my room, consultation chamber, walking. And so it's always a rewarding thing. So she also recovered without much problem, even though she was on ventilator. This is another tumor which most neurosurgeons see. It's a VHL. First we took out the cerebellar hemangioblastoma. Then we went for this tumor. And we embolized this tumor. This is, again, this is like a AVM only. AVM, here there is capillary. In AVM, there is no capillary. This is like a AVM with capillaries inside. The best, you cannot go inside and decompress. Most of the hemangioblastomas, they have a polar cyst, so you can get into the correct plane and get into the correct plane and start dissecting the tumor from there. And these patients, you can see the engorged vessels. And lastly, you sacrifice the draining vein. And this patient was extremely frail patient, but you can see frail patient. You can see this patient after surgery. This patient had a flail limb to begin with, and she also did extremely well.
Dr. Suresh,
we just finishing.
We don't see your videos.
We are not seeing?
Your video.
You are not seeing my video. You are not seeing my video. Oh,
okay,
you are not seeing.
You can,
I'll continue. Okay.
Okay.
Sorry.
You can continue.
Okay. I'm sorry. I thought you are seeing my video. Sorry, I'm so sorry.
Never mind.
Okay.
Never mind.
Okay. So, is there any place for radiation therapy? Yes, there is a place for radiation therapy when you partially remove a ependymoma, which you cannot remove, or astrocytoma where you have done only biopsy. And the survival is, ependymoma reasonably good survival, 10-year survival. If you do a good resection, 90% 10-year survival. Outcome of surgery is usually very good. These patients usually have the dysaesthetic pain because, when you cut the cord posteriorly, this can persist for some time. But in certain circumstances, the neurologist will tell us to open. We know that these things are not intramedullary tumor, but they want a biopsy so that they can go for further treatment. This when they suspect a fungal, bacterial, or tuberculous lesions on MR, or an isolated primary sarcoid. And once you diagnose by giving a biopsy and confirm diagnosis, they can put the patient on proper treatment. So conclusion, quality of life depends on accurate diagnosis. MRI with tractography, preoperative status always determine how a patient fares postoperatively. Always experience of the surgeon, meticulous microsurgery, as told to us by Professor Yasergil, and always collaboration with neurophysiologists. I am so sorry you couldn't see the videos. Maybe next time. Thank you very much.
Thank you,
Thank you.
Professor Suresh, for
Thank you,
this
Sami, again. Thank you.
presentation. Thank you. Is there any question? Okay, and now we should
Okay, thank you. Thank you very much. Okay.
for next speaker, Professor Abu Zar, please start sharing your screen.
I think you can see.
Yeah.
Yes.
Perfect.
Okay. I would like to thank Same to organize this big event. I will talk about the supracerebellar approach and its relevance. I have nothing to declare. Also, this brief look at the accomplishments over the 100 festivals and extraordinary legacy. This tent was established this year. We are lucky to have Yaşargil and his students and fellows with us. And also you can see Uğur and Yaşargil is discussing about surgery, and we are observing them. And he always with our laboratory. And also I am keep learning from the Turel, his student. And I will talk about the supracerebellar approach. You can find information about our articles. And when we talk about supracerebellar approach, we must mention about its ones like the median, paramedian, lateral and extreme lateral, and also transtentorial variant. When you go laterally, you will have a long distance, but will have a direct view to the midline structures, as you see. And we mostly use the paramedian or paramedian approach to the supracerebellar approach, and you can reach most of the hours with the supratentorial and infratentorial hours with supracerebellar approach. And the supracerebellar approach mostly used for pineal tumors. Or also you can reach these area with occipital intermediate way, but you must you may need to a bit of affection to the occipital lobes, and it may cause the visual deficit. And with structures you can reach where the supracerebellar approach the pineal and brainstem structures like superior and inferior collical and trochlear nerve like trochlear schwannomas, and the brainstem like midbrain. And also with pineal way you can reach the third ventricle and the middle part of the thalamus, and also posterior part of thalamus pulvinar thalami, and branch of the P2 and P3 and medial temporal lobe structure, superior surface of the cerebellum, and the temporal lesions like meningiomas. And you can see these structures here. This is the cerebellum. We removed the tentorium. And after opening the tentorium, you can reach the mesial temporal lobes and the parahippocampal jaw, and lesions located here, also mesial temporal sclerosis. You can remove this part with supracerebellar approach, and also pineal gland, pineal region. And as I said before, the superior and inferior collical, and also the ambient system and the lesions located in the ambient system like 2P2 worms, and also third ventricle and the pulvinar. And also you can see the pulvinar here and the ventricular surface. And also you can reach the venous and arterial structures like gallerian venous system and the P2, P3 blinds. And after opening the tentorium, you can reach the supratentorial structure. In this photo, we are looking from the superiorly, this tentorium, the hippocampus, and the P2 blinds located above the tentorium. After cutting the tentorium, you can reach this area and can remove any lesions located here. When we open the supracerebellar surface, the most challenging issue is the bridging veins, and we just published the determination of these veins, and mostly located at the mid part of the tentorium. And if you have a big lateral, you can have a direct access to the midline structures, and you can also you can combine supracerebellar approach with the retrosigmoid approach with extending your craniotomy, and you can reach all these structures with combining the retrosigmoid approach. And lastly, this is the view when you go deeper, the gallerian venous system and the splenium and the third ventricle and the pineal gland. And if you go a bit laterally, you can have a direct access and direct view to the midline structure, as you see the pineal gland. When you open the tentorium, you can reach all P2 blinds and the mesial temporal lobe structures. Endoscope always will help in this approach, and with positions are used in this approach, the semi-think position. As you see, one of the most popular while using the supracerebellar approach to use gravity. But you must have a good anesthesiology team because of the risk of venous embolism. And we just described the dynamic lateral semi-think position for supracerebellar approach. During the operation, we can change the angle of the table, as you see, and get in semi-think position. And also, you can see a semi-lateral sitting position. Also, you can change the angle of the table and continue your operation. And you must aware with preoperatively an evaluation of the venous system and also bridging veins. As you see in this cadaveric photo, you can see the bridging vein and its venous drainage. As you see, this is the bridging vein and its venous drainage. And also middle fossa structure can be reached via this approach, like epidermoid tumors. And we recently published this article with Professor Turel, the temporal cut technique to release the bridging veins and to get the more space to reach the deep areas. This is the cadaveric view. You can see after observing the drainage, we can cut the tentorium, release the vein, and can continue the operation. And this is from one of my cases, the mesial temporal biliary tumor. As you see, we are cutting the tentorium to release the vein. Before cutting the tentorium, we determine its drainage. Its drainage going laterally to the transverse sinus. As you see, the vein is released and we can continue to operation. Because of this, the preoperative examination of the all venous and arterial anatomy is important in supracerebellar approach. And also, we demonstrated all these steps. Our incision, our craniotomy, we open the boreholes above the transverse sinus, and we release the fourth sternum magna, then open the dura parallel to the transverse sinus. And with cutting the tentorium, you can reach all mesial temporal loss structures. You can see lateral ventricle, hippocampus, and P2 branch. And also after removing the hippocampal jaws and hippocampus, you can reach all these areas, and also you can see all P2 branch and also ICA with using the endoscope. And I will show some illustrative cases to thalamic cavernous malformation located in the posterior part of the thalamus. We're using a semi-sitting position, semi-sitting lateral position. After releasing CSF from sternum magna, we relieve the attached veins from the cerebellar surface and the tentorium. And after releasing the vein, we can go directly to the lesion, and always navigation can help. And we remove the hematoma and the cavanoma. And also you can reach the midbrain lesions with cerebellar approach. So occasionally midbrain cavanoma, we decided to go lateral mesencephalic sulcus, and also as you see the bridging veins, we dissect from cerebellar surface and the tentorial surface, then describe the lateral mesencephalic sulcus. We will use the lateral mesencephalic sulcus. After describing the sulcus, we just enter the lesion and remove without touching any other structure. This is the postoperative view. And also we talk about it is mostly used for pineal tumors. We are using the unilateral craniotomy and going from the laterally and direct access to the midline structures. As you see, in 5 minutes, you can reach the midline structures and can remove. And also P2 branch, you can reach with supracerebellar approach. This is the P2 aneurysms. And after cutting the tentorium, we describe the proximal part of the P2 and put a temporal clip, then put clips to the aneurysm neck. This is the postoperative view. And also superior surface of the cerebellum, you can reach via this approach. And also contralateral approach can be used in this approach. And also for tentorial meningiomas, for T2 meningiomas, you can reach with supracerebellar approach. Also, you can use the subtemporal approach, but you may need a temporal lobe retraction. And after finding the tumor, we cut tentorium and remove the tumor with preserving the or bridging veins. This is the postoperative view and the postoperative MOS. And I want to invite you all laboratory. This is Yeditepe University microneurosurgery laboratory. Whenever you want, you can visit our laboratory as observer, as a fellow. We are working with Professor Turel. I want to thank all my fellows and mentors. And this is the photo from the last visit of Professor Yaşargil. I think 1 year before his death. Thanks for listening.
Thank you, Abuzar, for this very nice presentation. Is there any question?
Yeah.
Thank you, Abuzar. Now we will shift to next speaker, Professor Mustafa Bashkaya. Please start sharing your screen.
Hello, dear Sameh. Good morning, dear participants, panelists. Thank you for being here and doing this webinar for Professor Yaşargil. And I appreciate your efforts in general and in particular for doing this event for the Professor Yaşargil. And as here in the morning, like, I don't know, 5:22 a.m. And wherever you are, good afternoon, good evening. Hope you enjoy. I have no conflict of interest, and you know, many of us visited, watch Professor or scrub with him, or most of us didn't have opportunity to do that. But you don't have to be trained by Yaşargil or see him to be his pupil. So we learned a lot from him. His contributions are unremarkable, remarkable, and I had privilege to meet with him, in my early life in neurosurgery when I entered the neurosurgery, and I never stopped following him. So we are saddened with his loss, but he'll still with us, and I'm sure he's watching us and how we're gonna do today. His contributions and his life, microneurosurgery, started in Europe, in Basel, Switzerland, and thousands, 10,000 direct angiograms that gave him the 3D view of the pathologies, understanding much better and learning the stereotaxy further contributed to his 3D understanding of the neurosurgery. And then that this opportunity to work with Donaghy in Vermont and doing these microanastomosis, vessel dissections was tremendous contribution. And then he did the first STA-MCA bypass after that. And his instruments, his designs, we use and will continue to use. And the main thing is his philosophy is using the arachnoid dissection, opening the systems, opening the sulci, using natural corridors, getting access to the pathologies, lesions, revolutionized the neurosurgery and opened the era of microneurosurgery. Sylvian fissure was one of the largest fissure in the head, and his daily teachings focusing on how to use different type of micro techniques, like a sharp dissection with the scissors, sharp dissection with the arachnoid knives, but never using the blunt dissection. If you're gonna use it, you're just using the bipolar spreading ways, and description of the variations of the Sylvian fissure, variations of the vascular anatomical structures. I don't know, you guys know, but he dissected when his early ages, like a 400 cadaveric brain hemispheres. So that techniques we learn from him will continue to use as these corridors to access the lesions, not going through the brain instead. Interhemispheric fissure is another fissure we widely use in daily practice of neurosurgery to access the cranial pathologies like thalamus, ventricle, lateral ventricle, third ventricle. And we need to be familiar with the not only the anatomy but the techniques and the preserving the normal anatomy. Not going to try not to go through the brain. Use these natural paths to the pathologies. This is a callosal IVM I am doing, and I don't know why, but I am very attractive to these veins. These veins, whenever I do surgery, they grow, multiply as I am doing the surgery, but we have to dissect these veins. And we need to be facile dissecting these. When we have a trouble, we need to know how to deal with that trouble. Main philosophy, Yaşargil philosophy, not giving up and keep trying, finding the best corridor. And yes, we're gonna run into trouble, and I'm gonna repair this vein because this vein I can sacrifice easily, and patient may not have any problem, but you don't know. It's unpredictable, and best to preserve. And if you cannot preserve, don't do this approach. That's simple. We're gonna keep going and keep dissecting until we find the way to retract this. If you don't elongate these veins, if you don't dissect them, you're gonna avulse them. If you dissect problems, but we can repair. If we cannot repair the vein, why should we do neurosurgery? And finally we'll go around, dissect, and elongate these veins so I can easily apply traction. Okay, and then we're gonna find a way. That's done. So no brain retraction, nothing with the gravity, and we'll close the dura as much as we can. Aneurysms, that's what we learned from him. Million aneurysms he did. Nowadays, people won't like to touch these aneurysms. They like to stand, and not many new generation, they will not know how to deal with these aneurysms. So when you deal with these aneurysms, you need to be prepared. You need to prepare for low flow bypass, high flow bypass, inside to bypass, or combination of these, because you are diving into the unknown of that pathology. Even though you gather all the information from angio, MRI, CT angiograms, 3D this, 4D this, but you don't know until you get there what you can do. And if we can, we would like to clip reconstruct this, avoid extra procedures. So as I debulk this aneurysm with the thromboendarterectomy, I am gaining space. I expose all the branches proximally and distally. So now I feel like I can clip reconstruct this. This is a heavily calcified part, and under the temporary clipping with the neuromonitoring, I am reconstructing pilot clipping, the Yaşargil described, right? Initial preliminary clipping. So you don't know, and then you get the temporary clips off. Now you have time to refine your clipping, okay? And keep cutting the aneurysm dome and getting better view. See that one clip is holding, and I'll keep changing it, and I'm bypassing doing the bypass. If I can clip reconstruct, why shouldn't I? And we are done, and it's the good way to practice the aneurysmography. Okay, so at the end, what we did the direct clipping while we were prepared for all kind of bypasses, and you get the mass effect out, you get the potential source of stroke, embolic strokes, and you gave patient your best. So that's the Yaşargil philosophy, his legacy, right? And there will be times you cannot clip reconstruct these giant fusiform aneurysm. This is a PCOM segment, ICA aneurysm, fusiform, And people try 2 separate sessions, each 12 hours, trying to pipeline this. They couldn't. If we cannot do this aneurysm, what's going to happen to this patient? She's going to get blind, she's going to rupture, eventually die. So what is the best way? Best way is the high flow bypass from common to M2, trap the aneurysm, preserve the choroidal, you are done. And you gave patient many, many more years. See, she's normal. She's living normally. This is her post-op angiogram. Clinidectomy is done, clip distal trapping clip in the distal to the ophthalmic, and I'm sorry, proximal trapping clip. Distal clip is proximal to the choroidal. You trap the segment, you decompress the aneurysm, and you give best to the patient. And Yaşargil philosophy is also not giving up. Keep trying. And this patient comes with the a loss of consciousness in the ER, develops a dilated ipsilateral pupil. You can see the extravasation on the CT angiogram, and she became fixed dilated in our ER. So you see this. This is the only chance, and you can give this patient your best. What is the best? When I open the dural, aneurysm keeps bleeding, right? I did go to the temporal pole and get the temporal pole, get to the inferior horn, decompress the brain, quickly expose ICA, put the temporal clip in the ICA, and temporize the catastrophe. Okay, this is a choroidal aneurysm, pilot clip philosophy, initial clips, removing it, clipping it, and believe or not, this patient had the MRSA score 0. Fixed dilated. She was lucky she became fixed dilated in our OR. She was unlucky to develop this condition. Bypass start with the Yaşargil. He pushed his limits. Okay, and today we are pushing our limits too. We do all kind of different bypasses, and this is the just standard STA-MCA bypass. This is how I do. I talk about this many times. I don't want to spend time, but I want to emphasize one thing. These studies, cost study, Chinese cost study, that study always fail to show beneficial effects of bypass, right? What's going to happen if you have this kind of patient? No multiple strokes, keeps getting the TIAs, keeps getting multiple medical trials, nothing happens. And plus, he has no right common carotid artery, no STA, no external carotid. You have only 2 options to do bypass in this patient, either from contralateral STA to ipsilateral M2 or ipsilateral V3 segment of vertebral artery to the MCA. So I chose the Bonnet bypass. We did it. Neurologists called me crazy when I decided to do this case, and patient was so scared because of the neurologist's recommendations. We did it. Not only 3 years. So this bypass is patent now 6 years. And he is only on aspirin, not having any TIAs. This patient was homeless because he was encephalopathic. He wasn't getting any blood flow to his brain. Now he's living normal life, working. 6 years. Cost study was correct, right? No, it wasn't correct. It wasn't correct choosing the right patients. AVMs are to me, is where you can do ultramicroneurosurgery. This unbelievable descriptions of AVMs in his volume 3A and 3B. This is again a case considered inoperable. Grade 4 precuneal posterior cingulate AVM is close proximity, right adjacent to the motor cortex. Multiple bleeds, at least 4 or 5 bleeds, and all reputable centers call this AVM inoperable. It is not. This is not motor cortex. You need to know the anatomy. If Yaşargil didn't teach us the anatomy, I will have said the same thing. Oh, inoperable. Go have this little embolization there, little gamma knife there, and become more miserable. Okay, you can remove these AVMs, and same with this Palestinian boy. Okay, he's 27, auto mechanic, works in Chicago area. What happens? He keeps getting seizures, and people keep telling him this is inoperable. Only we can do partial embolization. Right-handed, Sylvian AVM, and involving the temporal. We can do this. This is right sitting in the Sylvian fissure. All you need to do, employ the techniques we learned from professor. Open, arachnoid, open, circular fashion, okay? Define the normal anatomy first. That's what we need to know, right? Once you define the normal anatomy, then you define the pathological anatomy. Get feeders one by one. Don't just jump and do the cortisectomy, go around and make this surgery ugly, bloody. You lose blood and then you say, this surgery is very tough. Yes, this is the toughest surgery probably in microneurosurgery. But when you understand these techniques, when you use these techniques, you make the surgery simple, more understandable. Okay? Same techniques we learn from him. Spreading, peeling gently, and using your suction hand, and then getting the feeders. Once you do that, this AVM will become, this monster will become you are basically killing the monster slowly and gradually, okay? Then you take the feeders, you do your subpeel dissection, get around, and these AVMs, large AVMs, in my experience, see this hemosiderin staining, that these AVMs ooze, bleed, but they are under-recognized. When patient has a headache, people attribute, you have a headache, then it go away. Whenever I explore grade 3 AVMs, grade 4 AVMs, I found this hemosiderin staining. So they bled at one point in their life. Okay, so then you remove, lastly you get the draining vein and remove the whole thing. And don't touch this plastic perinatal vessels, okay? Leave them alone. Intrinsic tumors. He opened a new era in this, okay? People were considering these inoperable tumors, thalamic tumors, insular gliomas. He operated, and he operated through the natural corridors, Transylvian route. So what we do? We go through the brain. And that's unbelievably going like a backward, okay? He showed these surgeries in early 80s. And what we do? We go through the brain, remove the opercula, and we call it glioma surgery. Okay? That's not a surgery. You have to open the Sylvian fissure, use the natural corridor, respect the veins, respect the arteries. Turn this insular glioma surgery is a best microvascular surgery, and remove as much as, and calling these low grade is horrific. They are not low grade. You don't know what it is. So they watch this patient becoming like this and becoming like that, and creating our own monsters. Okay, this is microsurgery. This is microsurgery. Nothing difficult about this. Opening the Sylvian fissure, this biopsy-proven GBM, he's gonna die if we don't do anything, just biopsy, radiation, and chemotherapy. He may die, he will die again, probably even with the best surgery, but I'm giving him my best. Okay, this is the philosophy of microneurosurgery. And this maximal safe resection, I'm gonna touch base on this. What is maximal safe resection? 10%, 80%, 100%. Maybe to 10% to somebody, maybe 95% to me. So please do not use these vague terms to make you feel better. This is not microneurosurgery anymore. This is ultra microneurosurgery, okay? So this is the insular glioma GBM going into the anterior perforated substance, okay? You open the fissure, you define the normal anatomy, and you move veins away from your way. And then you can go through the Sylvian fissure. And be aware of the variations, okay? This tumor, when I look at it, I knew it is going to be encasing the lenticular striate arteries, okay? I knew it's going to be encasing all the M2 insular branches, M3 branches, okay? I'm defining the anatomy, getting the feeders, going into the tumor, and removing slowly, dissecting with the techniques we saw professor was doing. And you can go like the amygdalohipocampectomy all the way to temporal horn, finding the lenticular striates. I suggest you don't do this dissection unless you develop tactile sense skills, because you can hurt these vessels, okay? These are lenticular striates coming from M1. And if you go to the lab and you learn these techniques, you just don't start in the real patient, okay? Peeling the tumor from the lenticular striate, using this low intensity sonopet on the lenticular striate. This is the revolution of neurosurgery. These are the techniques we learn from him and we use every day. That's why we are grateful to him. Thalamic gliomas, again, the same business, calling inoperable. Occipital interhemispheric splenal approach is the best approach. In this case, I thought, and it worked out very well. But we studied anatomy, we learned anatomy in the lab, then we employ in the real life. Okay, this patient is a prone position, and respecting these veins again, and going into the interhemispheric fissure under the splenium, relaxing the brain, and getting into the tumor, peeling the tumor off the internal cerebral vein, and then you can do the surgery. Okay, we'll get it, we'll remove it. And this is the immediate post-op MRI, okay? Gross total resection, GBM grade 4. This patient survived 4 years. Without this surgery, she will have needed shunt on steroids, this trial, that trial. So far, I wish they'd find some good medications or good way of treating these GBMs, because they are bad disease process. But surgery remains the gold standard still. And we have to do our best to do at least gross total resection in these tumors, okay? Please try. So, what are the problems we are having? I mean, we see beautiful presentations. Atul is here, Suresh, beautiful presentation. Abuzer, everybody does good work, but we are few. That's the problem. We neurosurgeons are the main problem. We create our conceptual problems. We call it inoperable. We call this in minimal invasive, maximally safe resection. And we have tons of problems. I don't know how in the rest of the world, but in the United States, tons of problems in training new neurosurgeons, okay? So this is the reality. And we always face to this, operate or not to operate. And there was a microneurosurgery era, started by Yaşargil, okay? Then anti-microneurosurgery era came. These trials, Aruba trial, COST trial, ISET trial, they killed the microneurosurgery. And we start neglecting the basic principles. We don't train in microsurgical techniques. We go look for the crazy things. Microneurosurgery is there. It's for you. And we overemphasize technology. Yes, you use everything. I have intraoperative MRI. I have robot in the angio suite. I can do surgery simultaneously while I am doing the angiogram. But they are not doing the surgery. We are doing the surgery. Neurosurgeons are doing the surgery. And these defensive neurosurgery, this is inoperable. This is very tough. You need to go have a trial. And overuse of radiosurgery, abuse of endovascular procedures, and getting stuck with this terminology. Do this keyhole approach, minimalism. Yes, you do everything, but at the end, everything we do is not minimally invasive. Everything we do is maximally invasive. We need to learn the way of getting there, minimizing the invasiveness. Again, I hate to use this term maximally safe. What is maximally safe? 10%, 40%, 100%. And I showed the case. Let's observe. This is a benign tumor. You don't know it's benign. Or on the contrary, this is a cancer. You are not going to make just to remove a little bit, debulk, radiate, and chemotherapy. That's unbelievable. And staying away blood vessels. We are neurosurgeons. We live in the systems, in the arachnoid spaces. We deal with these vessels, veins or the arteries every day. If you stay away from them, you're gonna get into trouble. And I show you this case, right? I mean, this is unbelievable. Get surgery in a very reputable center, maximally safe resection. They remove 60, 70%, and then the rest is there. A young patient, incidentally found tumor. What I did, instead of going to brain, their route, I went to the sylvian fissure, secured the vasculature first, decompress all the frontobasal, frontobasal, I reach all the way to the ventricle. And that's the professor said,
emerging
actually.
tendency to declare some vascular and neoplastic lesions as inoperable and advocate partial or subtotal removal. And the concept is maximal safe resection. This sounds very ethical because it should save the integrity of the patient. But some way it is not logical because the lesions don't stay brave and silent. They trouble the patients even after subtotal removal and radiation. Second and third surgeries are necessary, which are naturally much difficult.
He gave the answer, we refused to use it. And my final recommendations, anatomy. Anatomy is everything. Please go to the lab, learn anatomy. If you don't have an anatomy lab, there are so many anatomy labs now, neuroanatomy, skull-based labs, and everywhere. Visit those labs, spend time, so you can correctly localize the pathology and you can use the correct surgical route to the pathology. Don't do indirect ways, okay? Directly go. And please don't get stuck with this keyhole, minimal invasive that, minimal invasive this. Or on the extreme, you don't need to combine anything, right? One simple retrosigmoid approach, one simple terminal approach is good enough. So every patient, you need to do enough approach for that particular patient. Yes, if necessary, I combine. If necessary, I do the smallest, if I can, smallest, safest craniotomy. But that's enough approach. So please do not get stuck with this terminology. It's not going to make you better neurosurgeon. And go to the lab, please. Okay. How many times we emphasize, right? Anatomy is everything. This is the dissections Professor Turel gave me. Professor Yaşargil's dissections in 1957. 3D pictures. These are the first 3D neuroanatomy pictures. He did it in 50s. And this is what he says now.
Beijing some years ago, I recognized Professor Ling Peng has already introduced microvascular techniques on hand-on laboratory, and the participants had to show their ability by transplantation of kidney by small Beijing mouse. Then they get qualified certification. I discussed this problem with my colleagues and whether we should create an initiative that this should be introduced in all departments. But we didn't have time and energy for a substantial initiative. I hope this Congress is an opportunity to bring responsible colleagues together and discuss this issue again, because the time is asking for this.
Yeah. And this is what he envisioned the laboratory training, okay? Everything you need to study. That's why we have these labs. We bring these people from low income, middle income countries. We train them and we teach them in these labs. Yeah, you don't need this lab, okay? You need only one small microscope and you in the corner of your house, basement or anything, you can create your own lab, okay? We can teach you this. And there are so many nests of these University of Wisconsin Medicine Microneurosurgery. There's a New Delhi, there's a Mumbai, in China, Japan, and everywhere. There are these nests. You please go visit them, okay? And professor tells you what to do. Train harder and better. Get better than your master, okay? You have to be better than us. Pass the flag. Spread and sprout, okay? This is Yaşargil showing your peak level, okay? Peak is not 160 meters, peak is Everest. Okay, I'll stop here. I got very excited. Thank you very much. And thank you again, Same, doing this. and all the participants. I'm happy to take any questions, comments, if you have any.
Thank you, dear
You're
brother.
using the ultra microneurosurgery term, Mustafa.
Hi, IP.
Is there
See
any
you using
question?
the ultra microneurosurgery term.
What?
See you using the ultra microneurosurgery term. That's the future.
Yeah, I started to using it, I don't know, 2019, 18, something like that. But ultra microneurosurgery, or whatever you call it, is microneurosurgery at the end, or neurosurgery in general. Whatever we are doing, spine, peripheral nerve, cranial, we should be the ultra microneurosurgeon.
Mustafa, excellent.
Thank
So,
you all.
Sami, can I start today?
Okay, thank you, Mustafa. Is there any question? Okay, go ahead. Okay. Thank you again once more.
I'm very glad Mustafa talked about ultra microneurosurgery. We started in 2017. We reverse engineered size pentero microscope, made this zoom into 42, and we started talking about operating at 40 plus zooms as ultra microneurosurgery. I mean, people were asking me that sometimes there's no need for microscope. What is the need for ultra microneurosurgery? I remember those times, but I'm very glad such a master surgeon like Mustafa is also into the same thinking lines. This is a little bit of history. So, Professor Yasergil, when I was awarded the best presentation award in ACNS Turkey, that's Professor Yuha and Professor Yasergil. Yuha was one of my very good friends. He passed away before Professor Yasergil. I owe to Yuha a lot. I mean, the spirit, the skills, and the attitude. Disclosures. I'm the lead consultant global neurosciences for Sanma Sahasranitra project, the Medaranya project with Palgat Surgicals, and Interop MRI project with accessdoctor.in. This is what Yasergil would have asked us. I have remembered that I have been sometimes called a cadaver surgeon by a lot of people. Of course, when the initial part of my career, I focused very much on anatomy. It was not available. In India, it was not freely available. So when I was in Nepal, we created a cadaver lab, and we created, probably Vladimir will remember, we created our own classification for the carotid and how we build the skull base, unlockings, different unlockings, axial unlocking, sagittal unlocking. So that's a distal ring, that's a proximal ring. So all these anatomy dissections, we did it in the lab. We started doing these under very high magnification. So this is a transcavernous approach. And so that's Dorello's canal. That is a petrosphenoidal, posterior petroclival ligament, and the petrosphenoidal ligament both can be cut. This can be cut in real cases also to free up the points of attachment for petroclival meningiomas. So this is the anatomy that you see. I mean, when you come for these dissections, we've done this countless times in skull-based conferences over probably from 2011 onwards. posterior clinoidectomy, we published a paper on the importance of posterior clinoidectomy in posterior fossa pathology when you have to get proximal control with the basilar. I used to do that in cystonostomies as well, as crazy as it may seem. So this is going into the middle fossa, the minimal cavasses, the normal cavasses, the extended cavasses. All this you learn in the lab. Basically, you chart your own territory. And that is where you learn. And this is what most neurosurgeons are missing. Some of them, because they don't consider important, the lab work is important. I think the lab work is the most important. So that's the entire Transcallosal approach. Now, starting from anatomy, first thing that we did was to start with cystonostomy. It's a skull-based procedure. It's opening the cisterns where the brain is under pressure. So this is in 2019 WFN as a session on cystonostomy. This is the textbook on cystonostomy. The last World Neurotrauma Congress, we had the single workshop that was cystonostomy. And now we have surgeons over 80 countries who do it. And I don't need to talk too much, but I'm going to show you a case here. This is as bad as it gets, midline shifts and burst slopes. Herniations, herniated already. So you take off you take about 30 ml of bone. You can take 30 ml of bone. That is the beauty. And once you do that, then the brain becomes much more lax. It is not like when you have all the basal bone. It's just like any other skull base case. If you don't open without the skull base, if you open without the skull base work, then the brain's going to be very, very tense. But if you take off all the bone in the base, that's you get some time. So you can see the damage there. That's the posterior clinoid process. That's the carotid. You're going in. So that's the basilar, the EBD. Unherniating. This is something that we do. The temporal lobe is gone inside. We raise the temporal lobe just very gently. If sometimes we have to excise it, but sometimes raising is okay. You can see the post-op scan here. And for the post-op scan, you will see this patient. This is him. You cannot imagine this happening for a decompressive hemicraniectomy. Ultramicroneurosurgery, we started in 2017. So with the Tentorial microscope, which we put in a 3-step magnification changer along with the ProMag eyepiece. So we could get a magnification of 42 technically. Zeiss company knows about this. This was probably the only one engineered to be like that. Apparently the Zeiss people told us, because it completely, I had a 3D head and it completely, put the entire system in imbalance. So we had to send it back. But when they gave me the Kinevo in 2020, they put that 3-step magnification changer from the old microscope. But then in 2020, we shifted onto the exoscope, so which provides us magnification for over 40, sometimes up to 70. Now, this is an example. This is a Sylvian dissection. You can see the magnification, and you can see ultramicroneurosurgery in action here. You must remember is what we learned from Professor Yasergil and his students. Just that we are carrying the torch and moving forward so that, as Mustafa said, the summit is much more higher. we are at different points, but we have to define points. We cannot stop where our people before us, the masters before us, stopped. They showed us the way, and it's our job to go ahead. So yes, so we define vessels which are very small, and go ahead and define all corridors. Sometimes you can see the zoom as 5.18, but this is on a 56-inch screen where we use it. It's 10 times more, that is almost 55 zoom. You can see how we even designed our own instruments, because many of the instruments that we got were not ultra microneurosurgery ready. And this is exactly what I would want the young neurosurgeons to learn. Going between windows. Mustafa said, there are some things, of course, that are inoperable or are maybe common sense doesn't allow you to operate, but then there are very few. And the so-called maximal safe resection is something that people hide their incompetence. Sometimes what is necessary for somebody who talks about maximal safe resection is to visit the lab, but it is not. People have different perspectives. I have had a lot of tumors where unknowingly I have left a lot of tumor in the beginning of my career, and sometimes even now. So this is not the intent though, but if you go with that kind of an intent that I'm going to leave tumor, that's sad. So we all fail, but the intent should be right. That's the whole thing. If you have the right intent, then you're going to do well. So the whole thing is to, as Mustafa said, the whole thing is to go very patiently. And when people say it's impossible, when you hear the term impossible, you must think this is going to be fun. Okay, that's exactly how you need to go. And that's the attitude that will, take you. So you see, this vessel, even that vessel is important. So it's very easy to bipolar it and just take it aside. But at this zoom, when you see it, why not dissect it out? Okay, you can dissect it out. So, I mean, you may say, oh, this is not needed, but when you didn't have the microscope, this is precisely what people used to say, this is not required. So you see how you can open the whole door all the way, we're not even thinking about aneurysm at this point. The only thing that I am thinking of is the next white band. That's all. Where is the next white band? Where can I open the next white band? I need to focus, see, and open each band. I think the youngsters need to learn that. Another surgery. This is a ACOM. I wouldn't go too much into it now. So again, ultra microneurosurgery zooms of 40 when we go near the aneurysm. Yeah, I don't like taking gyrus rectus for most of my cases unless it is really necessary. So what I do is I open the interhemispheric system. And with the exoscope, the angle is beautiful, because with the microscope, opening the interhemispheric with the pterional sometimes becomes a little bit of not a surgical issue. The assistant finds it very difficult. It will be a very difficult position you'll be standing into. With the exoscope, there's no such problem at all. You can see the interhemispheric being dissected beautifully. And once you dissect that, you get into the neck of the aneurysm. And once you have the neck of the aneurysm, you can go and you can click This is under very, very high zoom. Go ahead, and then after you put the clip there, you can see the distal vessels there, and you can put the clip. Firm with an ICG. We've been lucky enough to be considered as one of the 3 classifications for the internal carotid extradurally. So this paper was published from a South American group, my good friends Matthias Baldoncini, and we've been talking about this classification schematic of IC segments, and maybe this is beyond, we will not talk in detail about this, but this is, you must remember all the segments that are vertical are odd numbered. So C3, C5, C7. All the others, horizontals are even numbered, C6, C4, and C2. And then it's so easy. And then you connect, and it is so easy. And the entire skull base builds around it. So this is our classification, very, very easy. So this has been our center in 2017, as I told you. We had the Pentiro at that time. We had an intraop 3 Tesla MRI suit at that time. We had the OR1 Neo from Karl Stoss and the Poinsettia. So we had a fantastic OR, one of the best ORs in 2017 anywhere in the world. And we were doing surgery. So that this is a place which is very distant and very remote in Nepal. And this is where we changed even further. This is intraoperative CT suite, which is in India. So it is a 192 slice CT, which we designed with Siemens to put it as an intraop CT. And then we started Sahasra Netra concept here, that's Esculapeos. We take the output from the CT, reconstruct it into VR, and inject into the exoscope field. This is something that we do with the DRDO and with a few agencies. The company that we do it with is Sanma, as I disclosed earlier. So we inject this into as a mixed reality field. And this is what you can see the robot moving there. And this is in my field. Even without operating, I can see the head, and I can simulate the head, all the vessels, everything. I can move it around. And this is the first exoscope life surgery conference. Must have been in 2019 or something. This was in Russia. We were on the national news for that. We did a giant MCA aneurysm. This is because the exoscope from the German companies were $1 million. So we went ahead and made the first generation exoscope in India with a company from India. It's called the Sanma Yoko. My daughter's godmother is Professor Kato, so hence the name Yoko. And this is a robotic holder, endoscopic robotic holder, named after my second daughter. It's a Santana. Both of them are now robotic, second generation, and this one, the third generation. Third generation combines this both, actually. So you can hold the robot as well as the exoscope is also there. So this is what we do for innovations, and this is the bypass set. Every single instruments, we have gone to zooms of up to 70, 80 and examined these. They're made of stainless steel, and the whole set is half the price of a German set. That's how I wanted it to be placed. So we are a lot of people from South America, Africa, Asia. They are getting this set because it's literally dirt cheap. This is hypervision, part of Sahasra Netra concept. Putting the VR. This is something that we put it on a textbook in 2017. It is a VR integration into the real field. This is something that we did with a special forces soldier. He was the mental fitness coach for one of our premier cricket teams. And then what we did is we using feedback like heart rate variability, pulse rate, and other parameters, we made a program so that we know that when somebody is being pushed, somebody is under stress. Even before they start to manifest, when somebody is under stress, we can tell them, see, listen, you're under stress. And there is a way to get over it. So why we termed it beyond flow is because if you see musical instruments being played, they play in flow. They do complex, very complex movements, and that is in flow. But for master surgeons, flow is not enough. You can perform in flow, but then when the aneurysm ruptures or something very unexpected happens, then it can throw you out of flow. So that is why we decided that we should say beyond flow. It's a completely scientific program where it is like the elite Olympic athletes being trained. And my friend is he's been training Olympic athletes in India, and he's also trained #1 badminton player from India. This is robotic surgery, and we are getting into this. We are already working with a company, and robotic surgery may be the new thing because Da Vinci cannot be imagined in a small craniotomy in the head, and miniaturizing robots are very, very difficult. So we are miniaturizing it, and we are doing it with a company from India. So anatomy again, this is a cavernous sinus meningioma. And you can see this is our orbitomeningeal band as a route to the transcavernous or into the cavernous sinus. So you can see how this is something that we described way back in 2017. This is the axial unlocking. So you can see the cavernous sinus and the nerves there. And first, the tumor outside the nerves is being taken out, and then you go in, and then you go into different windows and then take. So, of course, you have to unlock the roof. That is the third nerve. So that is the clinoid. And you're going to drill the clinoid with a 0.75 millimeter drill, dividing it into certain segments, 4 segments, and you drill this off. And after you drill, you can see the tumor in the roof, and you can take out that tumor as well. You can see the third nerve. The optic nerve is seen. That's a clinoid triangle. The third nerve, fourth nerve, V1, V2, V3, all these nerves are seen now very well. Go between the fourth and the V1 and take out tumor. It's a Parkinson's triangle. The nerves are quite thickened here because of infiltration, but still, as Mustafa said, you do not say it's inoperable and subjected to stereotactic radiation and partial surgery, maximal safe resection. Here, you can, with this kind of zoom and attention to details and the knowledge of anatomy, you definitely can go do this. Now the zoom is almost nearly 100 because it's at 10 now. It's nearly 100. You can see a small micro instrument, see what's the size of. So that is how it looks like. These are the special instruments that we use. Another project that we are into now is, again, Mustafa talked about this, is about salvaging the penumbra for incomplete strokes. Recurrent TAs can also be added to the spectrum. We've been doing it for 7 years. CT perfusion studies to document the penumbra. The beauty is that we have a 3-month window period. So if you improve the perfusion in the penumbra, plasticity is much better because penumbra is not, it's viable, but it's not functional. So if you reperfuse the penumbra, functionality starts there. This is our hypothesis, and we've had, this is the bypass that we do, again, ultra microneurosurgery. It's 0.7 millimeter vessels, 5 sutures here, 5 sutures there, 2 on each. So 12 to sometimes 14 sutures. We use 11 zeros. And you can see 31 patients from 2017 to 2025 is still continuing the study, incomplete MCA strokes. DSA and MRI ensure to assess the vascularity with algorithms that show the perfusions with the AI being developed. Significant difference in GOS at 6 months and improvement in perfusion. I see that Utah, my good friend Bill Coldwell is also doing this now. I think Barrow has also started. China, Zubin tells me that it is a part of the Chinese stroke protocols. Now, this is the surgery again, the anastomosis. You can see so M4, ST to M4, very, very high zoom. Wet dry field. You can see so that's the bypass. So doing the farther side first, and sometimes I do it both ways. I mean, there is no strict way for me to do it, whatever I'm comfortable with. You can see the bypass now, done. And you can see this vessel irrigating when you do the ICG. You can see the direction of blood flow also is beautiful. You can see the direction of the blood flow. And then it's being irrigated beautifully. So another thing that we developed over the years now we started talking about is the vestibular schwannomas. I see a lot of surgeons trying to do subtotal or partial resections, but anybody who does the complete resection takes it off with the capsule, and then you have problems saving the cochlear nerve. So we looked at it, and then we found out that there is a subperineurium around it, and if you go at the subperineurial plane, the vascularity is between the perineurium and the eighth nerve. Seventh nerve saving is not a big issue, but eighth nerve, when the tumor is large, if you disturb the perineurium, if you take it off, peel it off with the perineurium, then you're never going to get your eighth nerve function back, or improvements will be unheard of. So you need to go subperineurial. This is not complete. This is not incomplete resection. Please understand that. A lot of people say you're keeping the capsule there. There's not really a capsule. It's so thin. It's really so thin that you can see the seventh and eighth nerves through the capsule. People who have assisted me would have seen this. And this is the concept. So you go into the capsule. Usually you used to go in this plane. Now you go into this plane, take out the tumor completely, use an endoscope. If towards the brainstem side or towards the IAM side, you can take out the entire tumor. This is how it will look. So at the end of the day, you have this blood supply, that is a vasa nervorum, is not disturbed. The cranial nerves are not disturbed, and you can take it out. We've never had for the last 7 years, we've been doing it. We have seen some cysts, but never needed resurgery. We've been watching them. This is some work we do in South America, in Central Asia. We have fellows, as Mustafa said, passing on our knowledge is very, very important too. So Africa, and this is something that really excites me. It's a portable MRI which can be worked like a Lego unit. So it's something that really excites me. I'm with them. It's an Indian company doing it with the US company, and it's truly exciting. So it would be, I think, the future. It will change the way neurosurgery is done. I just wanted to show you one video. my life has been around this, that everything is simple. And I've tried to convince others, but when you are conditioned to think that nothing is simple, then you make things hard for you. I believe everything is simple. If you pay attention to the details, to the right details, then everything is simple. Thank you very much. God bless. Thank you, Sami. Thank you, all my fellow speakers. Honored to be on this podium.
Thank you, Ali, for this very nice presentation. Is there any question?
Thanks, Ike.
Thanks, buddy.
Thank you. Now we will shift to next speaker, Dr. Gobos from Turkey. Please start sharing your screen.
Can you see my screen?
Yeah, perfect.
Yeah. Thank you very much, Professor Sameh, for the kind invitation to this amazing event in the memory of Professor Yaşargil, the teacher of the teachers. So I'm going to talk about the bipolar coagulation technique in the clipping of aneurysms. So this technique actually is not a new technique. It was described by Professor Yaşargil in 1960s. In 1967, he already described it in its book, Microneurosurgery, Microsurgery Applied to Neurosurgery. And also, I want to remember the Professor Malis, the inventor of the bipolar coagulation. So I will start with the cases. This is a small posterior communicating artery aneurysm causing a big rupture. And the regular steps of the aneurysm surgery. Then after opening the dura, we reach the Sylvian fissure. And proximal Sylvian dissection is enough in this case. We see the optic nerve, atraumatic dissection, olfactory, opening of the chiasmatic cistern. Then we reach the internal carotid artery. This is a distally located ophthalmic artery. Then we come to the posterior communicating artery. We apply the temporary clip. This is the posterior communicating artery. And now this is the arising point of the posterior communicating artery. We started to create a neck to put a clip. And this is posterior communicating artery. Now here we assume that we had a good neck and we can put the clip across the neck. When we try the clips, many sizes, many shapes of the clips I tried, but no clip fitted the aneurysm, closed the aneurysm without compromising the posterior communicating artery and its perforators. So after trying all the clips, we decided to coagulate the aneurysm without clip. Now, with a single shot of bipolar in the lower settings, now the aneurysm is gone. The posterior communicating artery is patent, but now we will wrap it with the cotton. After complete wrapping, just to fix it, we put a fibrin glue and it's over. Another case is 74 years old female, again, and this time is incidental MCA aneurysm. Again, we open the dura, we go through the internal carotid artery, optic, cisterns, really relax the brain. Then we open the sylvian fissure with Yaşargil's peeling technique, very useful. We always use it when we open the sulci or the fissures. Then after sylvian dissection, we go to M1. We have to expose the M1 for the proximal control. We see the M1 and we put a temporary clip on M1 and we see the aneurysm. We have a very small window, not to sacrifice any vein, but still we can do it. This is aneurysm. But the problem in aneurysm, all aneurysms almost of MCA and in other areas also, they are irregularly shaped and they cover the trunks. You don't see the trunks, the branches, the parent artery, superior, inferior trunks of the MCA. So bipolar coagulation comes into action at that point. We coagulate the dome, we downsize it, shrink the aneurysm, and we start to see the around clearly. Now we dissect the aneurysm. And again, under the temporary clip, we bipolar the sac, shrink it. We see the trunks. Now coagulate the sac. Put the pilot clip as described by Yaşargil. You see the inferiorly bulging part? There is a rest there. We have to deal with that. Again, we remove the clip under temporary clipping, as you see here. Again, we keep on coagulating it. It shrinks. We create a neck. Then we put the perfect clip. Again, we see the rest and we continue with the coagulation. And finally, we put the final clip. Now, all parent arteries should be patent. You should revise clip whenever needed. Now, the all sac is included in the clip blades. We see it clearly. We puncture the dome, coagulate it, and we see everything around. So this is what bipolar coagulation remodeling of aneurysm helps and makes the things easier. This is the final product. And this is post-op DSA of the patient. The aneurysm was here. And another case, again, a ruptured MCA aneurysm. Regular steps, we open the dura, the brain is quite red, swollen. Still, a traumatic sylvian dissection is possible. We always try it. Jewelry forceps are needed for peeling technique. So we see M1 for proximal control. This is one of the major steps. Then we open the sylvian fissure completely. We open the lamina terminalis to relax the brain. And now we have proximal control on M1. Now we see the aneurysm. Again, it's irregular and thin-walled as usual, and we don't see the trunk under the aneurysm. So any manipulation can cause any premature rupture. So bipolar coagulation is useful in this phase. First, we try to see the inferior and superior trunks to see the three-dimensional architecture of the aneurysmal sac. And after some dissection, now we start to coagulate the aneurysm dome. You see, it suddenly downsizes, shrinks, and it's easier to manipulate and see the trunks, the branches arising from the parent artery. But we do not try to coagulate the ruptured site. It's dangerous. we are away from the ruptured site, just to the neck, sometimes to the nose, sometimes to the dome, but in unruptured cases or in selected cases. Now we have room for clip blades. We put the pilot clip, then we don't stop here. We coagulate the dome, shrink the included dome in the clip. Now we fully expose the clip blades. Now we see where the clip blades fitted exactly. Now we are almost sure everything is done. We use Doppler for the patency of arteries, and this is the postoperative DSA of the patient. This case is an intracerebral hemorrhage with a large MCA aneurysm, Glasgow Coma score of 5. This patient, the hemiplegia, the patient was referred to us very late, unfortunately, but still microsurgery saves lives. We will see this. We are on the left side. This is a very bloody Sylvian fissure, but still we see the arachnoid. And then we try to see the M1 for the proximal control. Now we see the aneurysm. This is aneurysm. This is temporary clip on M1, and this is inferior trunk strongly attached to the aneurysm dome. Yeah, we dissect the aneurysm. Then after some dissection, we start coagulating the dome. This is a baby aneurysm over the dome. Now, under temporary clipping, we coagulate the dome. We make it smaller, and the wall of the aneurysm becomes thicker and safer to manipulate. Now, then we put the pilot clip, then other clips, a fenestrated clip for the rest, papaverine, Doppler, regular steps of aneurysm surgery. Then finally, we always puncture the dome just to be sure of that the aneurysm is closed. And the patient was neurologically, of course, the decompression was done, but 6 months later, an aphasic and hemiplegic patient started to walk and started to speak. So microsurgery saves lives. Another patient, an anterior communicating artery aneurysm, a young patient, again, Sylvian fissure splitting in an atraumatic fashion. ICA lamina terminalis, we always open it to relax the brain, and we expose the area a little bit, gyrus rectus resection as performed by Yaşargil. Contra and ipsilateral A1s are clipped with the temporary clips, and the aneurysm is here. A2s are here. And now first we put a pilot clip on the aneurysm. Then we shrink the aneurysm under the clipping. And then we check whether it is closed or not. When we check the aneurysm, inferiorly bulging part of the aneurysm is not in the clip. So this is very dangerous. We should handle it. And then we remove the clip. We coagulate the inferiorly bulging part of the aneurysm. After effective coagulation, a bayoneted clip is applied. And then we check again whether the previously rest points are clear or not. Now it is clear. All the aneurysm is included in the clip. This is the final product. And this is the DSA of the patient. Another case, this is a MCA aneurysm. This time it is incidental. Again, Sylvian fissure dissection, and we come to the aneurysm. Now, there is a vein here crossing. We don't sacrifice anything. We prepare M1 for proximal control, but the area is very narrow. We put the temporary clip on ICA in this case. Now, then we see the aneurysm. Now, this is the aneurysm. We see a branch is attached to the sac. We have to separate it. And bipolar coagulation is very useful in also in separating the arteries. Now we start to coagulate the aneurysm. This is ICA, temporary clip on ICA. And now we coagulate the aneurysm. It shrinks. This is a very thin-walled, baby-like bulging part of the aneurysm. Now, when we coagulate it, it gets away from the branch, so the branch becomes easier to separate from the sac. So after some coagulation, so before coagulation and after the coagulation, it is smaller, easier to manipulate. Then we put some clips, pilot clip, we revise it, remove it, put it, remove it. After we find the perfect clipping, and after 3 clips, reconstruction of the aneurysm, the procedure is done. And this is the postoperative DSA of the patient. And the last case is MCA aneurysm on the left side. Red brain and swollen brain also. Now we try to see the proximal control, the first step. Now the temporary clip is on M1. This is the aneurysm. This is the superior trunk, and inferior trunk is under the aneurysm. It's hidden under the aneurysm. There is a vein attached to the dome. We want to dissect the vein from the aneurysm sac, but it's impossible. We bipolar the dome. Then regular sharp dissection is safer in this case. Temporary clip, some preliminary clips or pilot clip. Then we revise the clip. Then finally, after we find the perfect clip, still we want to cut the dome just to be sure where the clip blades fitted. I mean, it is a perfect clip or not. And after all, we will puncture the dome. This is the dome. This is the temporal inferior trunk. Superior trunk is just here. So we puncture the dome. It's not filling. And also we cut the dome. The vein is still there. It's working. Now we cut the dome. The vein is free. And now we fully expose the clip blades. We see where the blades are. Where is the aneurysm? Where is the parent artery? Where are the trunks? So everything is clear now. We are sure. And papaverine application is routine. And this is post-op DSA of the patient. And in conclusion, bipolar coagulation technique is very useful to gain some room for insertion of the clip plate. It's safe. It should be done with high quality bipolar forceps under low bipolar settings. Irrigation and single shots are essentials to prevent sticking, and it should be performed under temporary clipping. It's better to mostly to the neck of the aneurysm, but in some cases, it can be used to downsize the dome, shrink the dome, make everything easier and safer. And also baby aneurysms on the sac can be coagulated to make the further manipulation safer. 2 points we have to be careful about. It shouldn't be done to the ruptured point because there is a small clot closing that point. We shouldn't do it, can cause premature rupture. And also it shouldn't be done to a calcified neck because there is a very thin wall over the calcification. And when you coagulate it, it will cause a rupture. So I would like to thank my mentors. We have listened some of them today, and we have to thank the mentor of our mentors, our teammates, and thank you very much for listening to me.
Thank you, Professor Gobus, for this very nice presentation. Is there any question? Thank you.
Thank you, Professor.
And now we will shift to next speaker, Professor James Lowe. Please start sharing your screen.
Can you see my screen?
Yeah, perfect.
You can hear my microphone? Okay. Well, thank you. Thank you so much for organizing this event. It's a true honor to be part of this panel to honor and pay tribute to our great teacher, Professor Yasergil. Today, I'm going to talk about microsurgical interruption of dural arteriovenous fistula. And I want to show you that this is a simple and effective curative strategy. And as you know, Professor Yaşargil has taught us many things through his microsurgical principles, and he detailed some very nice methods on treating these dural arteriovenous fistulas, particularly the concept of disconnecting the cortical venous reflux. And this is a curative treatment that can be achieved by eliminating abnormal drainage and not having to resect the entire dural region. As you know, these dural AVFs account for 10 to 15% of all intracranial AVMs, and they are acquired lesions where the arterial inflow go through the dural matter, and they can or cannot involve the walls of the dural venous sinus, and then they may or may not exit out of an adjacent cortical vein. So the ones that are considered high grade or dangerous venous drainage are the aggressive ones that include a cortical venous drainage. These are the ones that are dangerous and aggressive because they can present with spontaneous intracranial hemorrhage, and they can also present with venous hypertension. This is from the Borden classification, where types 2 and 3 include a retrograde cortical venous drainage, and the aggressive ones, according to the Cavanoma classification, are the ones that also have the presence of cortical venous drainage. And these are the aggressive ones because these can present with spontaneous hemorrhage or venous hypertension. The various forms of treatment that exist include surgical excision, the fistula, skeletonization of the dural sinus. I'm going to show you simple interruption of the cortical venous draining vein as a simple and effective curative treatment. And of course, endovascular treatment has become popular in more recent years, and also radiosurgery as an option. But really, the simple interruption of the connection of the arterial side to the venous side can be demonstrated in the early writings of Ed Oldfield, where he described these for spinal dural AV fistulas, and then also applied the same concept to cranial dural AVFs as well. This is the paper that I wrote some years ago when I was a fellow with Dr. Delishaw. On his series of 23 patients of dural arteriovenous fistulas, and highlighting the important concept of obliteration of the venous outflow. And unlike AVMs, where the obliteration is directed on the arterial side, dural AVFs is the opposite, where if you occlude the exiting draining vein early on, you eliminate the outflow for the dural arterial inflow to come in, and this can be a curative treatment. And here we had 100% complete obliteration with no recurrences. And here are some examples. This is, you can see this patient, 44-year-old woman, presented with a subarachnoid hemorrhage. You could see the dural AVF was exiting out of the posterior fossa from the midline. Here's the exiting arterialized vein. And just with simple clipping and disconnection, you could see the venous outflow has now become blue. And this is the post-op angiogram. You can see complete obliteration of the dural fistula. Here's another example. This is a tentorial dural AV fistula presented with subarachnoid hemorrhage. The exiting vein here is coming off of the tentorium. This is the Dandy's vein. This is the superior petrosal vein, and that was arterialized. You can see by simple disconnection after clipping and cutting. You can see here's the post-op angiogram, a complete obliteration of the dural arteriovenous fistula. This is done through just a simple retrosigmoid approach. We recently published this meta-analysis on ethmoidal dural AV fistulas. In the literature, you can see surgical microsurgery resulting in 89% obliteration, whereas endovascular treatment resulted in only 70% obliteration, and 20% of those endovascularly treated required open surgery. This is an example of a patient in our series of ethmoidal dural AV fistula. You could see the exiting vein coming off of the anterior skull base. Here's the 3D model showing the exiting draining vein. And intraoperatively, this can be done through a right supraorbital craniotomy. We're looking medially at the falx. Here's the arterialized draining vein. Here's the other one. And just by simple disconnection and disconnecting the fistula, we could separate the connection from the artery from the venous side. And this is the post-op angiogram. You could see complete obliteration of the fistula. Here's another example. This fistula was coming from the feeding from the right side, but the exiting vein was on the left side. You could see a large venous ectasia, venous pouch, seen on the 3D. But the exiting site coming out of the dura is this point right here on the left side near the cribriform plate. So we do a left-sided supraorbital approach. And you can see here's the exiting vein, tortuous venous anatomy. And by simple disconnection, you can see the ICG, the draining vein, is now obliterated. Now, it's important to be aware that there can be more than one cortical draining vein. Here you can see this dural AV fistula in the ethmoidal origin has two exiting draining veins coming out here. And we'll do this through a right-sided supraorbital approach. You can see opening the arachnoid sharply. And here's one draining vein. There appears to be a common trunk here. And it's located right above the olfactory nerve. So we'll carefully coagulate one of the exiting veins here and disconnect this. And then here we're separating the vein from the olfactory nerve, trying to preserve the olfaction. And then coagulate one exiting vein. Here's the second exiting vein. You can see on the ICG, there's still early venous filling. So this is part of the fistula. This is the second one. And then just by simple disconnection, you'll see that this is a simple and curative strategy. And in my opinion, a much safer and longer term durability than endovascular techniques. These high-grade fistulas, in my opinion, are microsurgical procedures. And it's very direct and very precise. So here's the pre-op angiogram. Here's the post-op angiogram. And this is the patient at 2 weeks post-op for her first follow-up. You can see it's a very safe and effective procedure. Is endovascular treatment curative? I think although you can have radiographic obliteration of the fistula, you have to be aware that long-term follow-up is warranted because recanalization is an issue and long-term durability has been overestimated. So these are published examples of recurrences after onyx embolization. This is one of my own cases. This was a tentorial dural AV fistula. You can see the venous outflow was coming out here from under the tentorium. And this was originally treated by my colleague with transarterial embolization. You can see there's nice obliteration of this fistula at the fistula's point. However, within a week, repeat angiogram shows already early recanalization. And the reason is because there's no physical disconnection of the fistula. And there can be micro recruitment of more fistulization. So we're going to go back in surgically. We did this through lateral position, infratentorial approach. Here you see we're working under the tentorium now in the supracerebellar corridor. Here you can see this is the venous varix that's starting to appear. And you can see it doesn't light up very well on ICG because it's already filled with onyx, but we know angiographically the fistula is still present. So we're going to dissect around the venous outflow. And here we're going to apply an aneurysm clip. And then here we're going to make the disconnection here with using micro scissors. You can see there's a very thickened wall of the vein from the arterialization. And you can see there's still some connections here deeper as we see. And then we'll use an endoscope to visualize to see if we got a complete disconnection across the tentorium. You can see there's still one outflow here that concerns me, that I don't think is completely disconnected. And with the endoscope, we can, under direct vision, target this last connection and then apply a longer clip to it. And eventually get across the entire fistula. So this is the post-op angiogram. Here's the pre-op. You could see a complete disconnection of the tentorial fistula. Now, at the craniocervical junction, near the foramen magnum, you can get dural AV fistulas. These are very analogous to spinal dural AV fistulas at the craniocervical junction. You can see this one is coming off of the right vertebral artery at the C1 and C2 level. And the procedure is simple. It's just a simple midline suboccipital craniectomy. And we can find the exiting draining veins on the right side, just to the right of the spinal cord. And then we can disconnect it using bipolar and scissors and eliminate the fistula. Here's the post-op angiogram afterwards. Here's an example, another one. Patient all had an MCA and basilar aneurysm previously treated, but here also has a high-grade C1, C2 fistula coming from the vertebral artery. And similar to the last case, we find the fistula here near the C1 exiting nerve root. We can disconnect it. Here it's wrapped around the nerve root. This is C1, so you can disconnect it without any consequence. And you can see the fistula that was here is now eliminated on the angiogram. And then I show you this fistula coming from the V4 vertebral artery. This is the fistula that's coming off of the vertebral artery directly. And we'll do this through a right-sided far lateral approach to access the vertebral artery. This is a right-sided far lateral, opening the dura, and then cutting the arachnoid and dentate ligament. And we have to be careful not to injure the 11th nerve. This is the spinal accessory nerve. And the fistula is coming right here. You can see the dura has this very arterialized appearance, and the exiting draining vein is coming out directly off of the vertebral artery. So we'll go ahead and divide these small exiting arterialized fistulized exiting veins. And then here is the fistula, you can see. The vertebral artery is here, deeper. Here's V4 coming, exiting the intradural side. And then we'll disconnect the fistula here and coagulate the vasovasorum here of this arterialized dural cuff where the artery is, vertebral artery is entering. And then we'll finally do another ICG and show complete obliteration of the fistula. This is pica. This is normal anterograde flow of pica. You can see preserve. And lastly, I want to show how surgery can assist transvenous embolization. This is a CC fistula where the exiting vein is coming out into the sylvian vein. There's no other venous access that can get to this area. They've been occluded. And so here you could do a transsylvian approach, canalize the sylvian vein and pack off the CC fistula with coils. And you can see on the post-op angiogram the elimination of the CC fistula. This is an example of a isolated sigmoid sinus, arterialized sigmoid sinus, where the exiting vein are these two veins of Lebet that has flow reversed. This has resulted in seizures and temporal lobe edema from venous hypertension. We published this case some years ago, doing a retrosigmoid access to allow venous canalization of the isolated arterialized sinus and packing it off with coils and then eliminating the fistula. And of course, you can also have CC fistulas where there's no transfemoral access. And in such cases, you can access through a cut down with your ophthalmological colleagues. And here we've accessed the inferior ophthalmic vein that can be surgically assisted to give you access through this vein to get transvenous embolization and then elimination of this fistula to eliminate the symptoms of her CC fistula. So in conclusion, successful treatment of dural AVFs aims at occluding venous outflow to obliterate these fistulas, especially the ones that drain through direct leptomeningeal drainage. Radical excision of the fistula is not necessary. The simple and effective treatment is disconnecting the arterialized vein, and surgery can also provide access to a venous access where you can use it for direct transvenous embolization. Thank you for your attention.
Thank you, Lo, for this very nice presentation. Is there any question? Thank you.
Thanks, James.
And now we will shift to next speaker, Dr. Srinivas, with start sharing your screen.
Thank you. Thank you, Dr. Samay, for obliging me and also for organizing this wonderful talk. It's a beautiful series in memory of a great master. So I'll be speaking on the Sylvian fissure, which basically the inside out, which was described by Professor Yasergil. So this is our tribute to him on how to open the Sylvian fissure. So the Sylvian fissure was named after Francis Sylvius, who was a German-Dutch physician, and the most important structure which it carries is the MCA and its branches. The importance of the Sylvian fissure is that it provides a surgical gateway. It connecting the cerebral surface to the anterior part of the basal surface and the cranial base. So the Sylvian fissure has been divided into the superficial part and the deep part. The superficial has its stem and the three rami like shown in this figure. The posterior, the anterior ascending, and the anterior horizontal. The deep part is actually the more important one, which has two components, the sphenoidal part and the operculo-insular part. The sphenoidal part extends laterally from the cistern around the internal carotid artery between the temporal and the frontal lobes and has the roof, the above roof, and the floor. The operculo-insular part basically consists of the opercular cleft, it's basically where the Sylvian fissure of Sylvian surface of the frontal parietal lobe and the Sylvian fissure surface of the temporal lobe meet. And the insular lobe is not visible, but it lies in the depths of the operculo-insular sulcus. So the important structures which include here are the pars opercularis and the pars triangularis and the superior temporal gyrus. So like I said, the most important component or the component of the Sylvian fissure is the middle cerebral artery. And the middle cerebral artery anatomy has been divided into the M1 and the M2, where the M1 was before the bifurcation, M2 is after the bifurcation. It's been classically divided anatomically into the M1, which is the sphenoidal segment, the M2, the insular segment, the M3, the opercular segment, and the M4, the cortical segments. And also based on the drainage area, it has been divided into M1, M2, and M3 segments. Generally, the MCA in the Sylvian fissure is the bifurcation into equal trunks, but also can divide into a dominant superior division, a dominant inferior division like here, or a MCA trifurcation where it gives rise to 3 branches. So these anatomical features have to be kept in mind while you are dissecting the Sylvian fissure. So the question is, what type of Sylvian fissures do we have? We have the type A, type B, type C, and type D fissures. The type A, the easiest to open, is also known as the atrophy. It's called the atrophic fissure. If the surfaces are closed, they're the opposed fissure, or one of the lobes can herniate into the other lobe. So they are either the frontal herniating, where the frontal goes into the temporal lobe, or the temporal herniating, where the temporal goes into the frontal lobe. It's also to remember the various venous variations. You can have the Sylvian variations where you have single vein, parallel veins, or a complex of veins. The complex of veins makes dissection much more difficult than when there's a single vein or there's no vein. And also, before sacrificing the veins, it's important to know the anatomy as to where the vein is draining, whether they're superior draining veins, anterior draining vein, posterior draining vein, or they have a mixed drain. So when you start opening the fissure, the first cistern you see the Sylvian cistern. This leads into the carotid cistern and then into the lamina terminalis cisterns, which are showing over here. And this is the direction of the dissection from outside to inside. To do the classic Sylvian fissure, this is the position of the Turel craniotomy. I'll not go into this, but it's important to know the surface landmarks. And this is the squamous suture, and you do the key burr hole, and the Sylvian fissure is going to be somewhere below over here, going up. So this can be marked by the on the surface marking. Then the classical McCarthy's burr hole is made, then a single piece craniotomy is done, and the lesser wing of sphenoid. And once the lesser wing of sphenoid and the sphenoid ridge is seen, that is where the Sylvian fissure starts. So what are the steps in dissecting the Sylvian fissure? You have the cortical, first one is the cortical arachnoid dissection. Then you have a temporal mobilization of the Sylvian fissure. Then you follow the cortical MCA branches to the opercular branches, and then to the insular MCA branches, thus exposing the MCA aneurysms. So historically, there have been two different dissection strategies. One is from proximal to distal, another is from distal to proximal. The proximal to distal strategy is generally followed when you have an MCA aneurysm and you want to expose it last and you want to take proximal control. So you start off from proximal or from distal to proximal, which is the more classical used for brain tumors, etc. So I will show a small video demonstrating both the distal to proximal opening as well as a proximal to distal opening. So this is the classic distal to proximal opening when there is no significant pathology in the MCA fissure, MCA in the Sylvian fissure, like an MCA aneurysm. So here you open the distal arachnoid first, drain the CSF, and then follow do the arachnoid splitting towards the skull base. So this is the more classically described Sylvian fissure opening. And this is used in most of the cases where we are operating on tumors like pituitary, craniopharyngioma, etc. Or like in this case where you are trying to expose the M1, M2 for the bypass as a bypass recipient. So you have to be very careful because there are going to be lots of vessels attached. So you have to dissect the arachnoid. You could use a water dissection also if there's not enough CSF, where we inject saline into the Sylvian fissure, try to spread it out, and then do a opening. So this arachnoid peeling method is especially very useful when you encounter veins which are vessels which are stuck to the surface of the arachnoid. You do the arachnoid peeling technique, and then you open the Sylvian fissure. So as you see, as you go more proximally, the Sylvian fissure gradually opens up, and you get a very wide exposure of the structures. So once you open up the superficial layer of the arachnoid, then you expose the MCA, and then once the MCA is exposed, you can follow it back. You get the M1, the bifurcation of the MCA, and here you can see the insular surface of the brain. So that is the M1. That is a bifurcation, and these are the two trunks of the MCA, or the M2 trunks. So at the end of the procedure, you have the entire M1, M2 segments and going into the opercular segment completely exposed. The other strategy is doing from a proximal to distal, where you go to the skull base directly, open the arachnoid there, and then follow it back towards the distal parts. This is especially done when there is an MCA aneurysm and you want to take proximal control. So the safest part to open the arachnoid is over the optic apparatus. Here you make a sharp incision and then start the Sylvian dissection. So the arachnoid is dissected off, first bluntly and then cut with sharp scissors. And proximal control is taken. First, you will identify the ICA. Then you dissect the arachnoid and follow the ICA, which then bifurcates into the MCA and the ACA. And then you do the exposure from distal to proximal. So I'll just quickly run through this video as it's much of it is a repetition. This is classic. This type of opening is classically done when you have an MCA aneurysm and you want to take good proximal control in case the aneurysm ruptures during dissection. So as you can see here that the MCA is completely exposed, and then we go about tackling the aneurysm, and there the aneurysm is coming into view. And if you see this one, you can see the MCA exposed, a temporary clip is put, and then the aneurysm is being tackled. In some cases, you would like to expose the sylvian fissure much more. For example, in this case of a cortical aneurysm, aneurysm from the cortical branch of the MCA, you can still do a detailed exposure. And here you are taking out the M3 and then following it onto the M4 segments. This is the M3 segment, the opercular segment, and there we are following it by a combination of blunt dissection and sharp dissection. And there you can see the aneurysm which has just come into view. Then you put a temporary clip and then you reshape the aneurysm using a permanent clip. The variation of the classic transsylvian approach is when you're doing an extended transsylvian approach. For example, for these basilar top aneurysms or the superior cerebellar artery aneurysms, where you have to do a more extensive opening. This is a superior cerebellar artery aneurysm. So for an extended transsylvian approach, you need to do a clinoidectomy. Here, then you open the dura. You see, identify the frontal and temporal lobe. Then do a sharp dissection of the sylvian fissure. And then you have to open it widely. This wide opening gives exposure to the undersurface where the PCOM and the PCA and the choroidal take origin from the ICA. This is also known as the half and half approach. Then you reach the MCF base. See, identify the tentorial incisura. Identify the third nerve, identify the fourth nerve, and then the tent is cut before the point of entry of the fourth nerve onto the tent. So here we are cutting the tent. This bleeding can easily be controlled by injecting either glue or flow seal into the bleeding point, which is basically the petrosal signage which is bleeding. After that, the attention is again turned onto the dissection. The third nerve straddles the superior cerebral artery as well as the posterior cerebral artery. So it lies between those two. And if you follow expose the SCA distally and then follow it proximally, you will identify it towards the basilar artery. So the trick is to do a wide sylvian exposure, cut the tent, expose the third and the fourth nerve. And as this anatomical relation of the third nerve to the P2 and the SCA is a constant, you identify both the vessels and then follow them retrogradely onto their origin from the basilar artery. So here you can see the PCOM coming in and joining the P1, this point of joining demarcates the P1 and the P2. So now we are going to expose the arachnoid over there and then continue the dissection. Going retrograde back and trying to identify the trunk of the basilar artery below the aneurysm. Got to be extremely careful here. Since we know that the aneurysm is at the origin of the SCA, we can follow the top of the P1 onto the basilar. And now we are going to come below the suspected origin of the aneurysm and follow it retrogradely back onto the basilar trunk. So here finally we have identified the origin of the aneurysm, and there you can see the neck, both the proximal and the distal necks have been identified. The clip is applied. So this extended transylvian approach, along with it, combined with the tentorial sectioning, gives very good access to the basilar apex as well as the superior cerebral artery. P1 example. So similarly, you can use the extended transylvian for a clipping of the basilar aneurysm. So I will not go into this detail. I just quickly run through it. So this is the ICA being exposed. Then the dissection is done, like I mentioned. Identify the third nerve, go around it. Follow the SCA and the P1 back to the basilar trunk, and then you get the aneurysm. And to identify the bilateral P1s and the superior cerebral artery, and then identify the aneurysm, take proximal control and do the clipping. So in end, it's like there have been multiple references both in Indian epics as well as in Middle East about the parting of the Red Sea. So the ciliary fissure is something like the Red Sea parting, by you can open up ciliary fissure and you reach your destination. So I would like to conclude by saying that the ciliary fissure slitting is the workhorse of neurosurgery. It gives you a very wide area of exposure up to the superior cerebral artery when combined with bone work, which sometimes might including removal of the posterior clinoid processes. It can be used for a wide variety of pathologies, both vascular and skull base, but you need to have a thorough knowledge of anatomy before doing the dissection. Thank you.
Okay, Sema? Hello, Sam, are you there?
Hello?
Oh, I guess Sam stepped away. Thank you very much. Any questions from the panel?
That was a wonderful presentation, Nick. And I am very happy to hear Dwarka giving some demonstration of microneurosurgery. So congratulations, dear Dwarka, on your beautiful presentation.
Thank you, sir.
Okay, very good. And now, thank you very much. And now to the next speaker, the King. The King is here. Atul Goel travels all over the world giving webcasts. Very generous to the neurosurgery community globally. I'm glad to see the King. Welcome. It's all yours, King.
Thank you, dear John. And let me get my slides here. So can you see my presentation, John?
Yes.
So this is the most well-known and most charming face on the planet of neurosurgery. And we have recently lost this great man who not only taught the art of neurosurgery, he taught the world the art of being a surgeon, the discipline in the operation theater, the discipline of microneurosurgery, and he went from point A to point Z, complete neurosurgical training that he gave to the world. So I can only say thank you, the most respected neurosurgeon of the world. And several accolades, several honors he has received through the years, from being father of neurosurgery, from being neurosurgeon of the century, and so on and so forth. So this great neurosurgeon we all remember, we all admire, and we all want to follow. He introduced several neurosurgical methods and techniques, and most important being introduction and propagation of the art of microneurosurgery, the art of aneurysm surgery and clipping, the most wonderful introduction of Layla retractors, and of microscope, the floating microscope. Most important, and we have all heard him, and we have all seen him, and we are all hearing about his work on aneurysms, on AVMs, and epilepsy. So first chapter of his life in neurosurgery was dedicated to vascular neurosurgery, AVM and aneurysms. The second chapter of his life, which actually we may not know and we may not realize, that Osama Al-Mefti gave him that second opportunity of his life, about 25 years to work with him in a full-time capacity in Arkansas, where he developed and propagated the art of glioma surgery, of epilepsy surgery, and various other contributions. These 6 volumes that he wrote was actually before, most of this work was before he joined Arkansas and Sam Al-Mefti. His work on aneurysms, on AVMs, his most celebrated works, the way he could do AVM surgery during that time is most astonishing, and one can only wonder with awe and admiration the kinds of arteriovenous malformation that he could do so many years ago. What I am trying to talk about is on glioma, which formed the latter part of his work, and what we have further tried to modify his work a little bit here and a little bit there. And we coined this word confined tumors for glioma. And we said that these tumors arise and grow along a named white fiber tract. So I introduced before you, my dear friends, an absolutely new and novel concept of glioma surgery today, in memory and in admiration of the work of Professor Yasergil on low-grade gliomas. We are used to operating on high-grade gliomas. We start neurosurgery with high-grade gliomas. We learn the art of tumor dissection. We learn the art of hemostasis. We learn the art of radical resection, and all those things we learn on gliomas. But as I grow further in this field, as I have spent several decades now in this field, I realize that high-grade gliomas are really high-grade surgeries. They are top-line neurosurgery, where the art of neurosurgery is, of course, important. Most important is the philosophy of neurosurgery, the respect for the values of the life of patients and for his future. When the patient is already destined to have a miserable time, we cannot create disasters and create further hemiparesis and deficits in this patient. So it is very, very important to be absolutely correct in these cases. What I'm going to talk on, the definition of diffuse gliomas. These low-grade gliomas were called diffuse, invasive, and infiltrating. And also these tumors are in more critical areas like insula, like supplementary motor areas and things like that. So if you say that these are diffuse, if they are in critical areas, the symptoms are minor, they are low-grade gliomas on imaging. They know, you were not able to remove it radically. There was no role of radiation. So these tumors, even in my career of neurosurgery, they were not treated. if at all, little bit biopsy here and there. But then came the work of initially by Yasergil and then by various other people, including Hunt Batcher. Then Dufault came in picture, and then this thing started. And now the general observation is, general agreement is that these tumors are, you have to remove them radically, because you not only relieve symptoms, you reduce tumor burden, you improve the quality of life, you increase the longevity of life, and you delay the malignant progression and transformation. So these tumors need to be removed radically. And in this objective, there are, in the last 15, 20 years, there have been a lot of technological advancement in monitoring, in intraoperative MRI, CT scan, ultrasound, functional neurosurgery, fiber tract mapping, intraoperative blue, red, pink, all these kinds of dyes, and recently connectome theory. We all know, we are all hearing about this all the time and quite a regular basis. Awake craniotomy has progressed. Functional mapping has been used quite extensively. In my view, the most important, the most critical, and the most wonderful advance in the field of intra-axial brain tumor surgery is understanding of white fiber tract. These tracts were not understood 20 years ago. Nobody knew what are white fibers and how they extend and what are their function. It was initially Kliger who had a beautiful manuscript on white fibers, and this was adopted by Gazi Yasergil, who further modified his work and projected his work. And we in our own department, as many of you must have seen and heard, that we have done quite a bit of study on white fibers, several articles from my department on Papez circuit, on brainstem anatomy, some beautiful dissection on anatomy and white fibers have been produced, and they have helped me personally in developing a concept which I feel is a complete revolution in glioma surgery. Our concept is that gliomas are confined tumors. They are not diffuse, they are not infiltrative. They are confined. They are confined to a white fiber tract, and they grow along a white fiber tract. And in the process of growth, they displace the adjoining tract, and the adjoining tracts are deformed and displaced but not destroyed. So this concept that they are confined tumors and you can develop a plane of dissection from normal to abnormal in a well-defined plane of dissection, on the consistency, on the vascularity, on the feel of the tumor, you can do, and you can do en masse tumor resection. So this paper I described several years ago. Now my experience is much, much more, and I am getting more and more and more convinced about the concept that these are confined tumors. These are confined to a well-defined pathway on a tract, and you can design a well-defined plane of dissection. So we describe various classification of white fibers depending superficial group, middle group, deep group, and vertical projection fibers and things like that. Depending on the fiber tract, like short articulate fiber, fascicle, we call them localized glioma. In association fibers like this, like corpus callosum, we call them diffuse glioma. So this is our classification. Now, corpus callosum is a huge, solid, robust structure that we have never really realized. You see, these fibers go from one side to another side. This tumor, we have been calling them butterfly glioma and all these kind of butterfly words we have used, but we have never said that these tumors are confined to these white fiber tracts, which are transversely oriented. And they have a well-defined plane of dissection, which you can use during resection, during your surgery, and can get a beautiful plane of dissection. If these tumors, we have said in our article here, that if these tumors, if you find an intra-axial tumor in a haphazard pattern of extension, not along a named white fiber tract, these may not be glioma. So it is a concept which is different from what is existing. Now here you see, this is in a supplementary motor area. You will all agree that this is a dangerous tumor, and this can create hemiplegia in low-grade gliomas, which are not so rapidly growing. You are not allowed to create hemiplegia in these patients. And you are now thinking of doing a radical resection. They displace the projection fibers like this, but do not destroy them. I want to quickly show you that these tumors in very critical area of the brain. You see, I have a little bit advanced my cursor here, but you see how this tumor in the most dangerous area can be removed like a meningioma. Of course, this picture will be not as beautiful as you see for an aneurysm surgery where you are showing blood vessels which beautifully look the pulsating vessels. These are intraaxial surgery. And you see tumor consistency, you see tumor vascularity, and I have to tell you, I have edited the tape on my cursor. I have done this tumor in exactly 10 or 15 minutes. The whole video is there with me. And you will see in the entire dissection, very, very little or no coagulation will come in picture. And this well-defined plane has to be designed by a special technique. You see my suction is in my right hand, and I am dissecting even underneath the tumor. You see how the tumor nubbin is coming, and this kind of dissection is different. This dissection is, in my view, quite a positive way to do a radical tumor resection based on this concept. And you see this tumor has been quite radically removed. This is another tumor which is not in such a greatly dangerous area, but in the supplementary motor area. And I want to quickly show you the video. And you see the whole thing by the color, you can identify where is the tumor and where is the normal brain. Just I'm showing you some little steps in this operation, which is a very highly edited video. Not I edited video, this I am editing on the cursor here. And you see a plane being designed around this tumor with this suction in my right hand and with very, very minimum coagulation. Of course, there will be some coagulation here and some coagulation there. But I can tell you that this tumor, which is right in front of you, which is quite a huge tumor and quite a big glioma, I must not have coagulated more than 3 or 4 times. So this is a unique property. I am wondering how these tumors get their supply and where are the normal vessels gone? Where are the abnormal vessels coming from? And this kind of dissection is a real possibility. And you see here, the whole tumor with so many vessels on its dome is being resected in a fashion which I think is a unique kind of dissection with a unique pattern of dissection depending on the consistency of the tumor, the feel of tumor, and with this special dissection technique which is around. Dissection is not only, my suction is not only just feeling the tumor, but it is continuing to dissect in a well-defined plane. And this plane is and this is the way my feeling is, this is a safe resection, this is a radical resection, and you can limit the kind of monitoring that you need during operation. Of course, I do awake craniotomy in many of these patients, but in several of these patients, I can even avoid awake craniotomy. Now I will show you another tumor. You see, all those who are doing low-grade glioma surgery will definitely agree that this is the most dangerous location of the tumor. You can create, if you are not, very confident of a concept, you can actually create a very big deficit. Let me show you this glioma surgery in this most dangerous area, depending on the color, depending on the consistency, depending on the neuronavigation imaging, depending on the ultrasound imaging. I first identify the tumor. Then I take sharp incision on the arachnoid. And then I remove this tumor in a plane by identifying. That is the trick. Identify normal from abnormal in this most horrendous area of the brain, where you can create, if you create damage, it will not be accepted. It will not be accepted, and the patient is not going to die too early. And if he lives with hemiplegia for next 30 years, all his 30 years, he will keep on blaming you in a fashion that he will never leave you. So unless and until you are terribly and thoroughly convinced about this concept and thoroughly conversant with this technique of dissection, you're not permitted to do any of these kind of dissections. So this is what I am showing you, that in the most critical area of the brain, you can design such a plane of dissection with confidence, with a technique, and with very, very minimum coagulation through the operation. And you have to remove the tumor and nothing but the tumor, because if you remove anything but the tumor, you have removed a very important pathway. And this is possible, and this is very elegantly possible. And in my view, if radical surgery is the answer to this tumor, this is the answer to radical resection. It is possible. And, you know, I am not saying I have never had a complication in my lifetime, but in our life of neurosurgery, we develop a philosophy and work on those concepts. And we have to be confident of those concepts. So this is the article that I had written several years ago. As I have mentioned, my experience goes now far and beyond. And I have no hesitation to say that these are confined tumors. So this tumor, if you see this tumor, and this is a low-grade tumor, you see there is some kind of, the bone is eroded here. You see this tumor, it is whitish, this is normal, and it is more firmish. You can easily observe on the surface view, and then you can remove this tumor. And this is a very straightforward tumor, of course, but we have now removed all kinds of tumor in all kinds of areas with this kind of dissection, with this kind of concept, with this philosophy that these are confined tumors, and you can develop a plane of dissection even in the most horrendous areas of the brain. High-grade gliomas are high-grade not by virtue of their, by their extension or by their propagation, but by virtue of their multiplication factor. And even in high-grade gliomas, you can design a well-defined plane of dissection and you can remove the tumor en masse. Insular tumors, where Yaşargil's contributions are immense. Many people have worked on those concepts. Mitch Berger, my dear friend, has worked quite extensively on this, and Dufault has worked extensively. And these insular gliomas, if we know the paths, the arcuate fascicle, if we know IFOF, if we know middle longitudinal fascicle, if we know the optic tracts and pathways, if we know all these wide fiber tracts, we can do a beautiful dissection. You see this tumor, nobody in the world will say it is in a safe area. This is in the Broca's area, most dangerous area. And I will show you, I wanted to do this awake, but this fellow was completely fidgety and would never agree to this. And here I want to just show you this in the most dangerous area, in the most critical area. You see this and this color is different. This is glioma. And now I'm going to do a dissection in the in the Broca's area, acknowledged area, in the region of insula. The most and final trick is, if you take a vessel, you can possibly damage the person irreparably and permanently. You're not allowed to take any blood vessel of the insula, because you never know which vessel is more important and which vessel is critical and all those things. So here now I will show you how I'm doing this dissection with this suction. This suction is not just a suction, it is a dissector. It is a blunt dissector. It is sucking blood, but it is simultaneously dissecting and developing a plane of dissection. And whatever editing is going on, I am doing on the screen myself. The whole tumor is, the entire thing is unedited version of the tape. Now you see how this nubbing of the tumor is being, you see how this is going? And how I am elevating the tumor of the Broca's area and the motor area and all those things. And this tumor, most important, is not a single time in this operation any coagulation has come, and that you will see that, I'm doing this and coagulation is not coming in picture, and the tumor is coming in a form of, a different kind of low-grade glioma that you have seen. This tumor is coming in a form of like a meningioma. Of course, this surgery does not look as pretty as a vascular surgery. I would have loved to show you some AVM surgery, but I want to show you this concept, which is an absolutely novel concept, and in my view has the potential to completely revolutionize low-grade glioma surgery. So this is the tumor, and this fellow is speaking here. Some voice was disturbed, but now after this was done 6 or 7 years ago by me, now this guy is completely all right. I don't want to show because he's talking in Indian language. Insular gliomas are a trick to operate, but this concept has to be understood and developed in the surgery of insular glioma. Corpus callosal gliomas, corpus callosum, I never knew corpus callosum per se is a foundation of the brain. It spreads all over the brain. It spreads over the ventricle, it spreads over the lateral ventricle, over the temporal horn, and it covers the entire. What a beautiful structure this corpus callosum. And along this corpus callosum forms the gliomas. And when you see a glioma in this territory, identify the tract from which it is growing. When you see this glioma, this is from the corpus callosum. This is along the fibers and distractions of the corpus callosum. And that you have to realize. And if you see the corpus callosum, what beautiful tapetum, forceps major, forceps minor, going over the ventricle, spreading into the brain. This corpus callosum, I never knew till we did this dissection and produced this most fascinating paper on corpus callosum and its connections. I wish that you please read this paper because it is my very favorite paper. And when we do corpus callosal glioma surgery, don't start calling it butterfly and all those things. It is a very well-defined, beautiful paper, with beautiful subject, which you can remove radically. Whether this radical is possible or not, it depends on how you use your instruments and how convinced you are with the philosophy. More important is you can do it. So we had described several years ago orbital cortical approach to intraaxial brain tumors on the basis of location of uncinate fasciculars, on the basis of location of IFOF, on the basis of anterior commissure fibers, and on several kind of, and then we wrote this article on how we develop this orbital cortical approach. And the basis is not approach, basis is the design of surgery and the pattern of surgery. So this tumor, you will come into hemispheric, you will come in, but there is a possibility of coming using the fiber tracts coming from the orbital cortical surface, then developing a plane of dissection, and you can do a very radical resection. So these are some parameters that we have discussed in our article, and you please read it. So fiber tract is the key. Fiber tract is the foundation, and not only of the brain, but foundation of intraaxial brain surgery. This fiber tract has to be learned and has to be absolutely imbibed in your philosophy of microneurosurgery. Pape circuit, limbic circuit, this beautiful anatomy. For the first time in the world literature, the whole Pape circuit we removed from the brain, and I am showing you on the screen. So this is what white fiber tract can do to you and to our patients. So thank you very much.
Very good. I'm going to take off the screen there, Atul. Most people I say, are you done? But I just say the king has spoken. Thank you very much. Any comments or questions on what the king said? Anybody? Okay, I guess, okay, thank you, Dr. Goel. Okay,
Thank you.
now we have Basant Misra. Basant, are you ready? I'm not sure he's here.
No, he's here, John.
Yeah, he was. Basant, are you there? Maybe he may have stepped away. There you are. Okay.
I'm there. Can you see my screen?
Hold on, Basant. I can't. Oh, yeah, is that your screen? Yes, it is.
You can see my screen?
Yes, I just want to briefly introduce you. Basant is a well-known neurosurgeon from India. And go ahead, Basant, it's all yours.
Yeah. Okay, let me see my time. Yeah. All right. So this is what I'm going to speak to you, Yasergil and his contribution for neurosurgery in Asia. His first India trip was 1988, and that he came to our national meeting, did some presentation, went to our National Institute in Bangalore, did some presentation, and he had problems and he had the characteristic reaction, but then he helped get them because the carousels were not working, so he sent some carousels from Zurich when he went back. This was his second trip to India in 2008, and some of these slides have been given by Mr. Robinson Gupta and some by Dr. Dev Pujari from Bombay Hospital. And a lot of us were there, both in the first and the second time he visited India. So the Japanese neurosurgery, I got it from Professor Akio Morita. You can see here, I just can't read that, first microneurosurgery course in 1970 was by Professor Yasergil in Japan. and then many kind of eminent neurosurgeons they had joined, and this is the photograph of the first meeting where Professor Yasergil contributed to the microsurgery neurosurgery development in Japan. And Taiwan, this is from Professor Chu. And again, Professor Yasergil he went to Taiwan to do a course on the invitation of Ali Krish, and that had tremendous impact in the development of microneurosurgery in Taiwan. This was from Hong Kong by Wai Poon, and Wai Poon told that he had come twice in 80s and 90s, and of course he was the honored guest speaker at our Asian Congress in 2002, invited by Professor Kano. And this is what Dr. Poon writes. Our standard joke is Professor Yasergil's 1 hour lecture is last 2 to 3 hours. Anybody who has attended the 2002 ACNS would remember that, nobody went for the food because his lectures continued, and we had a long delay. This is the first time Professor Yasergil went to Hong Kong, and this was along with Professor and Mrs. John Gillingham from Edinburgh. Unfortunately, Professor Yasergil never visited Australia, Pakistan, Indonesia, and many other Asian countries because he was busy teaching people mostly in Europe and North America. My first encounter with Dr. Yasergil was in 1986. I was in Edinburgh that time as a registrar, and from there I had gone to Newcastle in the CNS meeting, and he was the honored guest. And we had the privilege, the registrars, to have a luncheon seminar, lunch with the honored guest. And we had a great time, and his lectures actually were much more interesting than the half day at the French Quarter. That was something very interesting for an Indian, because part of the scientific 1/2 day was free to visit the French Quarters in the CNS meeting in 1986. And my next time I met him interacted in the World Academy meeting in 2008 in Brazil, and I requested for a photograph. With very reluctantly agreed, and he was very unhappy because somebody flashed, and which he didn't like. From that time, 2008 to 2017, my most memorable day, this was after a plenary talk in the World Congress in Istanbul. He appreciated and congratulated my talk, and that was probably the most happiest moment and most memorable day of my life. What did I learn from Dr. Yasergil? Everything I do, like many of us here in this group and many all over the world. So I'll tell you what are some of the things which we learned, and this is just the last few couple of weeks back. This is a STA-MCA anastomosis, bilateral carotid occlusion, and this is how we did it. This is the opening of the superficial temporal artery, and then preparing the graft. Everything, the skin incision starts with microscope. This is again something which has been influenced by Professor Yasergil. So the opening of the dura, this is preparing the recipient M4. This is an adult patient, and we can take off 3 to 4 small branches, which you do. And then I prepare the STA. This is putting a temporary clip there. We first put the distal temporary clip so that the vessel remains engorged. So preparation is easy. And then we prepare again the MCA distal temporary clip first. So the proximal temporary clip. So the vessel remains engorged, because this opening a collapsed vessel is much more difficult, takes time consuming. And there was a vessel, actually it was bleeding, so I repositioned the vessel. And there's a micropots, which we have designed indigenously there. Put some dye so that you can identify properly 10O interrupted sutures to do the anastomosis end to side between the ST and MCA M4. And we do interrupted first on one side, then the second side, and then bleed before the last suture. We close it so that we back bleed both the recipient and the donor arteries. And if there is any bleeding, we can put an extra suture there. Just fast forward and see after the end we can. So then we do the, once we have completed the anastomosis, we do a ICG. We take off the temporary clips. If there is a little bit of bleeding, this is good. So the patency is maintained. You don't most of the time need any extra vessel, extra suture, and it just takes care of it. Or no. Now you see the my donor artery have back bleed everything. Then so there is no significant oozing there. That was a rubber dam below that. And then we do the IC. That's the donor. That's the recipient. M4. Very nice feeling of both the arteries. So we're happy with that. Then we close. We along with that we do EDAS. I mean, so the durals are reflected back, and that helps in increasing the indirect anastomosis. I think somebody's talking in between. If you can stop. If you can be muted, organizers, if you can mute the guy, gentleman, or lady who is talking, that will be helpful. Somebody is talking. Okay, again, aneurysms, all of us have learned, and my first actually, when I saw the videos, 3D videos in '86, that was a meeting, which is the first time neurosurgery 3D videos were played in 1986, and he demonstrated his videos, talks, and all that. And this is some general principles of aneurysm surgery: wide opening of the sylvian fissure first, and then identifying the branches and identifying the neck of the aneurysm, leaving the fundus as kind of undisturbed as possible. Temporary clipping. I'm a very big fan of temporary clipping before I do the clipping of the aneurysm to soften it. And the risk of rupture is much less with that. And once I have done that, you see this is a fenestrated clip. First fenestrated, again, you see the fenestrated Yasergil clip, okay? And the blades take the distal part away from you, the neck, and then the permanent clip which takes towards you. Now, the clip application is not the end of it. Once you have done that, we need to see all the vessels. Again, learn from Dr. Yasergil. Okay, and then we take the temporary clip out. When you're doing the temporary clip, we bring the blood pressure off, and then again ICG to see that we need to see all the vessels. The left A2, the right A1 is visualized. So all the vessels, this is right A1, and this is left A2, right A2. Aneurysm is not seen, and then we coagulate. Again, this is something which Professor Yasergil taught us. You reduce the aneurysm by coagulant. There is some residual aneurysm. So I can see that it is not complete. So we need to reposition or add additional clips. You will see that. So we are repositioning the fenestrated clip. It has to be complete occlusion, not 90% or not 90%, 95% or 85% as some classification of endovascular treatment. No, microsurgery should kill the aneurysm. It should be complete and 100% occlusion with all the branches and perforators in the MAC. Again, killing the aneurysm, open the aneurysm, and then subsequent post-op imaging, again, critical. I think this I showed, okay. What happened? Yeah, so again, this approach, microsurgery, that can be done. All the cavernomas, whenever it is required to be treated, we do by microsurgery. We do not agree with the concept that this should be treated by radiosurgery. Now, this is a thalamic, posterior thalamic left side, and we did the tractography. We thought the best way to come from the supracerebellar approach is a wide opening because we don't know where the veins are, but we are going from the right side. We have taken up just one vein. Other veins are intact. The arachnoid is very thick. We need to cut it. So we coagulate and cut that, respecting all the veins that is possible there. When you're coming from the right side through a narrow opening and going to the left thalamus. And we use image guidance. We use an endoscope so that where we are. Now you said this splenium. I'll fast forward. That's the third ventricle, the choroid plexus at the roof of the third ventricle. That's the left thalamus. And then we use neuronavigation to see where the closest to the area, the cavernoma is there to the surface. And this is a this is the instrument we use for pituitary, micropituitary endonasal procedure. And you see it's a bend at the tip so that your visualization, this is a beautiful instrument for small areas, narrow areas in the depth. And this is a micropituitary rongers, which we have done, used to take out this. And once you remove, we think that we have done, then we will see that that some part of it is removed. And again, piecemeal, we put the endoscope. Very nice educational tool. Roof of the third ventricle, you see that. That's the foramen Monro there. And then we put in the cavanoma cavity, because we want a complete excision. Otherwise, it will come back. Dr. Spetzler used to joke that by the end of the surgery, cavanoma recurs if you have left it. So that's some residual cavanoma you can see there. So that is what we now take it out under the microscope. We remove that. So to have a complete excision of the cavanoma, and then we wash it everything, and then see that I just want to show at the end the brain cerebellum is all intact. There is no retractor. The vein is still intact. Clean cavanoma bed and preserved. And this is the post-op blood there. The whole cavanoma is removed. Colloid cyst. Again, the transcallosal approach, something which he talked about it. We have a very large experience, about 300 odd cases, which we have operated over the period of years. Again, opening of the white corpus callosum, you cannot miss it. Everything starts from the beginning, from dura. You saw the STA-MCA from the skin on microscope, and here from the dura under the microscope. So that's the choroid plexus going into the foramen mondo. That's the best guide to the foramen mondo, not the thalamus strident, the choroid plexus. To trace it forwards, one reaches the foramen mondo. And once you reaches that, you see there's a large the colloid cyst. So we decompress it. Many times these adhesions to the choroid plexus to the posterior wall of the colloid cyst, and we want a bloodless surgery here. So we coagulate and cut it, and the total excision, and that's the third ventricle. And you see at the end, this is the amount of corpus callosum section. It's hardly 1 centimeter. And the incision on the dura, less than 1 centimeter and 2.5 centimeter anterior posteriorly. So that's all you need to do it. Now, acoustic, again, something which was something he taught us how to do it. Again, a disease which is very close to my heart for the last 40 years. And this is not a big tumor, Cus 3. And you see that the whole tumor has been removed completely. You will see that with total excision, drilling of the intraocular canal, decompression of the tumor first, get some space, no retractor, and decompression. After the decompression, where is my, yeah. So you see that tumor now. And then we will open up the intraocular canal, which is almost routine in my practice. So with that, we can achieve a total excision, a wide opening of the intraocular canal, very wide. And that makes the safer to use instruments inside the intraocular canal. If you do a narrow opening, or you start pulling out tumor from inside without opening, you have a higher risk of damage to the nerves. Now we can use the QSAT at a very low strength, and then you dissect out the tumor from superior to inferior, inferior to superior. This is something which Dr. Yaşargil talked in the Hong Kong meeting. If some of you are there, you would remember. And this is the best way to preserve the vascularity of the nerves. And you can see the tumor, last part of the tumor being taken out. That's from the brainstem end. Again, the suction is acting like a dissector with a patty between the neural structures and the my suction. The solid form tumors, we cut it. And then this is again the brainstem end. You can see the brainstem end there. This is without suction. This is being used as a dissector. Now you remove the tumor completely. That's the 7th and 8th inside the intraocular canal, opened intraocular canal. Now we check. We continuously having a BERA, and we monitor the facial nerve continuously, and also by stimulation. At what stimulation you are getting it. Now at 0.8, 0.08, if you get the stimulation at 0.08, less than 0.1 or 0.2, then you have very good facial function. If it is more than 0.2, then patient has a temporary. If you do not stimulate, of course, the patient has a palsy. And then we fix the bone also there. And this is, I have shown in some meetings before. This is actually a young patient from young girl from Iran, which I had operated this fat graft there. You see normal face, normal hearing. Now, this is the last example, again, the petroclival meningioma. The first successful series of petroclival meningioma was published by Professor Yasergil. Before that, nobody talked about the excision of petroclival meningioma because the risks were so high. And the standard retrosig approach, again, no extensive, dedicated skull-base approach, which you moved away from that, and we working between the nerves. And you see that arachnoid, staying away from the arachnoid and respecting the arachnoid is the key to success and having no problem, no deficit. And the nerves are all intact. You work in confined spaces. So we need to have that practice to work in confined spaces. I'm sorry about that. Now, at the end, you see that arachnoid covering the brainstem, and that's probably the best site for a neurosurgeon at the end of tumor excision, because you know that you have not damaged the patient's veins intact. That's the sixth nerve, that seventh, eighth complex. This is the arachnoid, and that you will see the third nerve beyond that. That is supratentorial compartment there. And that arachnoid over the brain, that's the third nerve. And that's a beautiful site at the end of surgery. And you see the arachnoid, and that's again a very, very, kind of satisfying. And that's the fifth nerve there. So once you see that, you know that you have not created any problem. So before I close, please, friends, join us to respect the only legend which is left. Yaşargil has gone. Now the only legend left, Professor Sami. We have the Majid Sami Society International Meeting in Mumbai, 2026, May 14 to 17. Please do join us, and we'll be so happy to host you. Thank you very much for your attention.
Okay, thank you, Dr. Misra. Excellent. Do we have any comments or questions from the audience? I'm going to get you off the screen there. Okay, now I'm going to introduce Atabati. He's going to be working with us at Neurosurgical TV, and he's going to introduce the next speaker. He's originally from Pakistan, now practicing as a dual neurosurgeon hold on, get off the, okay. Okay, I was going to show the, let me just quickly show, I don't know if I can, I guess you've already screened. Can you see the screen? Dual trained neurosurgery? Can you see that or no?
Hello, John?
Perhaps not. Okay, go
Yes,
ahead.
we can see it.
Go ahead, Atta. It's all yours.
Hello?
Yes, go ahead, Atta.
John, my screen is sharing.
Yeah, okay. I'm going to boot you off there for a second to introduce the new introducer. Can you get off the screen for a second so we can meet up?
I'm Anup Singh.
Yeah.
I'm Anup Singh, John. Are you listening me? I'm audible?
Okay,
My screen is
that's
shared?
okay. It's okay. Go ahead.
Okay. Thanks, John. Thanks, Dr. Sameh, for giving me this opportunity. And it's indeed an honor itself to talk after Dr. B.K. Misra and Dr. Atul Goyal sir. And for such a giant personality, we are thankful to you all.
Sorry.
Hello.
Yeah, go ahead. We muted that person.
Okay. My screen is shared and I'm well audible, John?
Yes.
Okay. So after such a very heavy academic dose, it is something which is related with the emotional talk, which I used to have some kind of experience with Dr. Yaşargil sir. So the lessons I learned from him. So it was my first interaction was way back in 2008 Jinde oration, and it was the only interaction with him as a person. And like all Indian neurosurgeon, I was also in Mumbai to see him, to hear him, and I was very keen to see the person who was a living legend of that time. Regarding me, I was from middle class family, just a 1-year-old neurosurgeon, just born in neurosurgery and working at a remote periphery in India with practically no resources, with minimal essential instruments required to save lives in emergencies only. And then I was there to see a person who was a giant, neurosurgical giant of my era. So this is a photograph of that particular event, which was happened in the Bombay hospital at that particular time, way back in 2008. And I was astonished to see a person of 84 years. He was 84 years young. Age was just a number for him because he was so much enthusiastic and energetic to give every neurosurgical tips to everyone who was sitting there. His session used to start at sharp 9 a.m. till 6 to 7 p.m. And during lunch hours, a question he used to ask with us, are you people hungry? Go and take your lunch. I'm waiting for you. So he's just like that for the teaching purpose. The neurosurgical river Ganga was flowing like anything in those hours. And I was a just one neurosurgeon, was witnessing a mesmerized Indian neurosurgical audience where no one was ready to miss any single drop of that particular holy river. One of the delegate used to ask with him, because every time he used to talk that I resected this tumor with the CUSA, then he used to ask him, sir, if you don't have CUSA, then what to do? He just humbly answered him, my dear friend, you can go ahead with the bipolar coagulation and then the cutting, and then you can remove that tumor. But why you don't have CUSA? Do you have car? Sell your car and buy the CUSA. And then he further explained this thing. How much time do you spend in your car and how much time in OT? His message was very clear that where you spend more time, that place should be full of all luxurious things. And for any neurosurgeon, it could be only one place, and that is his operation theater. So after coming back from Mumbai, I was completely changed in my thought process and my priorities were clear. The book, Microneurosurgery, which he had shown in that particular conference, and to equip myself and my OT. This microneurosurgery book, it took almost 8 years for Dr. Yaşargil to pen down and compile his neurosurgical experiences in form of microneurosurgery. Not surprisingly, it was at the top of my priority list. And following purchasing this book, it becomes my habit to read the books on regular basis, and I created an entire huge library. Mumbai hangover was still on, but I was not having much finances. A very small car, Maruti Jan, for my big family till 2012, when an ongoing discussion about the need for a big car was started in my family. And then I convinced my entire family that a microscope is more important for me than a car. And I finally purchased my first microscope, that was Vario. And with the use of that Vario, my entire neurosurgical vision was changed. This is the message which I want to give to my younger generations, my younger fellows, my younger friends. Then I developed a theater which is equipped with all the luxuries. It became my hobby to have all possible technologies to make them available in my OT, whether it is CUSA, NIMS, navigation, or the Kinovo 900, the India's first 3D Kinovo, which we purchased for our hospital. I equipped my OT and library. They made me what I am today, a result of that one physical interaction with the giant named Professor M. Gazi Yasergil. So there is hardly any day in my life when I don't used to take his name. So my mentor was a holistic personality. I'm sure that whoever come under his influence changed completely, both neurosurgically and beyond it, like me. His neurosurgical Bible, Microneurosurgery, remains a big source of knowledge for my generation. Here are a few lessons that I have learned over a period of time from that particular interaction, which I had way back in 2008, and from his book. First and the foremost thing, I would like to mention here, in 2008 February, I was in KM Bombay with Professor Atul Goyal sir. After completing his wonderful surgery, he came to me and he asked me, Anu, looks easy? Because sir, in some hands. He kept his hand on my right shoulder and then he told me that you can do it. But I was not knowing how to do it. And after meeting with Professor Yaşargil, I found the way how to do it. I learned the aggression towards the pathology with Professor Atul Goyal and respect of the brain from Professor M. Gazi Yaşargil. And he was very clear in his commitments that the minimal invasive neurosurgery doesn't mean small incision, but the minimal invasiveness to the brain. For that, he further explained it, the atraumatic exploration. These are the quotes from the microneurosurgery book. The brain is, however, not an isolated, compact structure, a so-called island unto itself. It can more readily be compared to a continent with a multifaceted coastline and many water inlets. It floats in a sea of CSF. reverse of which allows access to its anterior. And here we can see how to do this. Then he described further the technique of arachnoidal approach. The concept of this technique is to follow the arachnoid plane, folds down into the sulcal, fistulal, and cisterns, and leads to the site of both extrinsic and intrinsic tumors. Let's see how. This left motor strip Cavanoma patient was a well intact patient with only a mild right grip weakness. The rest neurological examination was normal, and here you can see the left frontal cavernous angioma. This lesion was just sitting just anterior and below the motor strip. Someone is talking. So I proceed further under awake craniotomy, under brain mapping, under navigation guidance, and I prefer the most direct sulcus, which was taking me towards that particular lesion. I opened that particular sulcus, and then under the navigation guidance, I found that particular sulcus, that particular gyrus, which was harboring this cavernoma. And then finally, a very small cortisectomy to locate the lesion, and then the lesion was dissected all around, and a complete lesionectomy was done. It was dissected all around, and the lesion was removed with just a sulcal approach. And here it was the post-operative result. Another patient which I just operated yesterday, because Dr. Yaşargil very frequently used to say the deep bleed should be operated with the transsulcal approaches. This patient I operated yesterday just for this conference, and here you can see there is no cortisectomy on the surface, and here is the surgical video of this particular patient. This time it was not under navigation guidance. I specifically located this lesion with the anatomical and radiological findings, and then I found with this I opened this sulcus. It was very clear that when you are operating on the transsulcal approaches, your field should be absolutely bloodless. With this blunt point probe dissector, I just opened this. I just opened the sulcus completely, and then with the help of suction cannula, at the depth of the sulcus, the overlying cortex was dissected and the hematoma was located. And with the help of this, my further dissection proceeds with the help of Panfield number 3. And under microscopic guidance, I remove this entire hematoma. And here is the end of surgery. So again, I would like to show the pre-operative and the post-operative image. It is just immediate 2 hours post-op scan of this patient. So he described very briefly about the tactics of CSF release to gain the working space in whatever procedures you are going to perform, whether it is terional, whether it is lateral subcondylar, temporal approaches, anterior approaches, supratentorial, infratentorial approaches. Everywhere he used to describe the tactics of CSF release to gain this working space. And they used to work in all such kind of procedures. Here, this is a case of microvascular decompression with supracerebral aortic conflict in the left trigeminal neuralgia patients. I keep 8 minutes to drain the CSF from the cisterna magna and from the cisterns. And by the time I move on the superior aspect towards the trigeminal nerve, you can see the entire, there is no need of any retractor at this point of time. I just opened the trigeminal cisterns, and the arachnoid on the 7th, 8th, and the lower cannula was completely intact. A Teflon patch was put between these two structures, SCA and the trigeminal nerve, and then I found a vasospasm in the SCA. Dr. Yaşargil always used to say, be ready always with the papaverine, and then I put this Abgel soap papaverine, and the vasospasm resolved. Proximally, the SCA was still very in close contact with the DREZ. So I put another Teflon patch to keep it further away from that particular DREZ zone. And then this was the end of the surgery. And here you can see, just by removing ample amount of CSF from the cisterna magna, I don't require anything else to dissect except my trigeminal nerve. All the rest of the arachnoids are well intact, and my patient was completely intact, just with such kind of minimal invasion was recommended by Professor Yasergil. So repairing small tear in a fine vessels. There are he quoted as a guidelines for preventing sticking and how to use the bipolar forceps. He recommended to repair small tear in vessels with 0.3 mm. Like in this case of rather difficult, quite big aneurysm in fenestrated account. So every scenario was quite difficult. It was a fenestrated account, and during dissection, recurrent artery humor little bit it started bleeding at its origin, and just by putting point coagulation at the tip, I found I specifically secure the vessels and achieve the hemostasis. Dissection moves further, and then I put two 7 mm clips over the aneurysmal site after the dissecting the entire area. But again, when I remove the temporary, after completing this, putting both of the clips, when I remove this temporary clips, again a bleeding starts, blood does start from a small tear from the accessory account, which I again follow with the same principles. I again coagulated and put a small amount of surgical on that, and I was well able to secure this hemostasis. And finally, a small aneurysm present on the A2, I put a small temporary clip on that also. So regarding the skull-based approaches, way back in 1999, when this book was published in Microneurosurgery was published, he specifically quoted all kinds of approaches of his era from 1958 till the 1994, and he mentioned all such kind of approaches, but specifically mentioned that using only the terional or subtemporal, transtentorial or lateral paramedian and medial subaxial approaches, the senior author could efficiently remove most of the skull-based tumors. And this gives me a lot of confidence, and this it used to remain my routine habits. Whenever I used to found uncomfortable myself in any such kind of lesion, I used to do staged procedures. Like in this case of right CP angle epidermoid with supratentorial and right medial temporal extension, a two-stage surgery was performed. Right arm mesocraniectomy, that was followed by subtemporal approach with complete excision of this lesion with completely intact patients. Approach was minimally invasive. It was it never used to follow with the routine extensive approaches, skull-based approaches. Glamour surgery with anatomical precision. When I saw the pre and post operative images of his patients I found that specifically he used to resect the lesion and with intact with no collateral damage. So this is the butterfly glioma, and here we can see the pre and the post-operative complete excision. The entire butterfly is removed from this scan. And in the right superior frontal gyrus lesion, anaplastic astrocytoma, covering from all around with the motor strip, and it was completely excised. Only the right superior frontal gyrus was removed with completely intact patient. Another middle frontal gyrus oligodendroglioma, WHO grade 2, it was completely excised with well boundaries, like just Dr. Atul sir had just mentioned it, and there is no collateral damage. Only the lesionectomy is done. Well, respect of the surroundings. Another cingulate gyrus glioma, it was completely excised following the anatomical boundaries. I'm very much convinced, I used to remain with Dr. Goel sir, glioma used to remain confined to a particular gyrus, and only that particular gyrus is the culprit, and there is no need to go with other things. And this can be seen with the Dr. Yaşargil sir series also. Another right parietal parafalcine glioma, the lesionectomy was done completely, only focusing on that particular gyrus under the navigation guidelines. Functional correlation is also remains very much important. This left motor strip low-grade glioma patients in a barber was present on the left side, and here you can see it was surrounded all around because it was just in pre motor area. So it was all over the DTI was showing all around this motor fibers, and it was with the help of radiological detail imaging, I found that this vein is the my boundary on the lateral aspect. Medial aspect boundary was already clear. It was the FARS, and then the complete lesionectomy was done. And here is the post-operative scan and the post-radiotherapy scan. There is showing complete lesionectomy. And down the line for last 3 years, patient is completely normal, performing his job and earning the money with this because he was a barber. Another big left temporoparietal astrocytoma, WHO grade 2. It was operated completely, resected completely, and the complete lesionectomy was done, respecting all the surrounding brain. Left deep parietal low grade diffuse glioma. I did a transcallosal approach, and here because I can see on the DTI images that the motor fibers were bending around from the anterior aspect. So it was a transcallosal approach, and I was getting all the all mapping features on the motor features on the anterior most aspect. So I stopped myself here, keeping the patient intact. Hemangioblastoma surgery, Dr. Yaşargil sir mentioned that hemangioblastoma should be explored and removed completely on the first occasion. At that, when I go through this particular sentence, then I was not able to find out that why he mentioned specifically this thing. And he furthermore he mentioned that an incompletely removed lesion gain additional vascular supply from dura and become very difficult to remove on re-exploration, which I found subsequently in one of my patients. This most of these right cerebral hemangioblastoma routinely remain in a very in a routine proper manner. This pinkish lesion is dissected all around, and this is just because of time constraint. I am moving forward. The feeders are secured from all around, and after last coagulating the feeders, finally the draining channels is coagulated and cut, and the lesion is resected. This is a routine hemangioblastoma surgery, yes, okay, but what happened when the patient comes to you with such a recurrent situation? This patient undergone twice at a different center for the hemangioblastoma surgery, and then came to me with history of headache for last 4 months. And there was a recurrent right cerebral hemangioblastoma with infiltrating overlying soft tissues, infiltrating the dura, and even including beyond the dura, beyond the confinement of the cranial cavity into the scalp. And then I remember the quote of Dr. Yaşargil sir. It remained very difficult. So I decided to remove this entire lesion in mass, starting from the skin till the hemangioblastoma. I resected everything in mass. And here is the post-excision dural tumor. Sorry. And it is the post-operative scan. And for last many years, she is completely normal without any further recurrence. Regarding acoustic surgery, there's a beautiful video is just shown by Dr. Misra sir. And Dr. Yaşargil sir series, he specifically mentioned this in microneurosurgery that he was having approximately 50% facial preservation, and many of the times even well before 19 this century, in before 2000, he has mentioned in his book that many of the cochlear preservation he found in his patients. And here is the patients, and you can see there is complete lesionectomy, complete facial nerve intact, and the rather improved facial nerve, improved cochlear nerve functions in these patients. So Guru is an aspiration, Guru is an inspiration, Guru is everything. You were an ocean, sir. You're just a few drafts changed my neurosurgical life. I have no words to express my gratitude. Thanks, sir, for everything which I learned from you. Thank you.
Thank you, Dr. Anup Kumar, for sharing your emotional journey and influence you had by the Professor Yaşargil. So now I invite Professor Hisham Bession from Germany is going to talk about the versatility of Transcallosal Approach.
Yeah, hello everybody, and thank you very much for inviting me and this very special session in the Memoriam of Professor Yaşargil. I hope you can see my screen.
Could you put it on full presentation?
Like this?
Yeah, perfect.
Hello, John. Hello, Dr. Sam. Thank you very much. Well, I would like to begin how Professor Yaşargil, when he entered my life, my professional life, and how he influenced me. It was in the year 2000 during a meeting of the German Neurosurgical Society in Lübeck. It is a small town in the northern of Germany. And there was the German Neurosurgical Society annual meeting in September. And Professor Yaşargil in this meeting was honored by the highest honor, which is given by the German Neurosurgical Society, the Fedor Krause Medal. Fedor Krause is a German pioneer who, among others, developed the retromastoid approach to the cerebellopontine region. At this meeting also, Professor Yaşargil and also Peter Janetta was honored with the Fedor Krause Medal. In this meeting, I was giving a presentation about tentorial meningiomas, and I had these two images from the volume 4 of Microneurosurgery from Professor Yaşargil, and then he passed by, and I was just preparing for my presentation, and he saw the images, and I asked him if he allows me to use them in my presentation. And then we came to talk, and then he suddenly said, "Oh, don't you want to come and visit me in Little Rock? Just I can show you a lot of things. You can see my lab over there and see a lot of videos, and I can show you a lot of things." Of course, from this moment, it was in a very, very positive way, a shock for me. Because I was not expecting that such a neurosurgical giant invites me to his place where he was working at that time in Little Rock in Arkansas. I later had this meeting also inspired me to work on this topic, tentorial meningiomas. I published in Neurosurgery and later had the honor to write the chapter 18 in the reference book of Professor Hussam El-Mefti about meningiomas. So the next chance, it was in December, it was just 3 months later, I, for the first time, visited this extraordinary place, Little Rock, which was also an international meeting point with Professor Yaşargil on one hand and the skull-based giant, Professor Hussam El-Mefti, and a synthesis of both Dr. Ali Krisht, Professor Ali Krisht. It was an amazing time, an amazing meeting, and it was the first time. And then all my vacations I could get until 2002, I spent there in this amazing place. Also attending aneurysm surgery courses and skull-based courses in St. Louis, meeting other masters of neurosurgery like Selim Abduraouf and Jack Moros, for example, and other great people. So I'm not a selfie man. I have got no images, unfortunately, but this was assigned by Professor Yaşargil during my first visit. There are a lot of lessons and advices he gave me, but I picked two things out of these many advices. First, if you want to reach the highest skills and be a master and the highest levels of your profession, you have to dedicate your life to this beautiful art. We have the privilege actually to, and I think all in this, attendances in this round will agree that we have got a very beautiful profession, beautiful art. Professor Yaşargil was actually incorporating this art with his personality, with his teaching, with his mind, great mind, and open mind. So do it with care, love, and passion, and this is also what I'm telling my staff and all the visitors. I think this is very important, and this is what he actually was incorporating in one person. The second thing, at that time in 2000, I was not very happy at the place where I have been, and he gave me the advice: make the best out of the place you are at the moment. And this I remember very well, because I did so, or tried to do so, and I stayed in the place 17 years, and it was I tried to make the best out of it. So my presentation about retractorless microsurgical endoscopic assisted transcallosal approach. Why do I have chosen this topic? Because it combines some key features of Yaşargil's teaching, which is avoiding brain using the least invasive approach through cisterns and ventricles. Avoid also permanent retraction using the suction device PADIs for dynamic retraction. You have to be deeply familiar with the neuroanatomy in all your surgeries to achieve the best results and prevent any complications. And also this approach involves the limbic system, like the fornix cingulate gyrus, and this was structures which were fascinating to Professor Yaşargil. So these are images from another master and giant, neurosurgical giant, with Professor Roton. Amazing images showing you the interhemispheric approach, avoiding the bridging veins, and you go pass by the cingulate gyrus. Then you've got the corpus callosum, which you have to incise to reach the lateral ventricle. In order to reach the third ventricle, you have to take care about the fornix, the body of fornix, the column of fornix, and entering the third ventricle, you have to take care about the internal cerebral veins and the boundaries or the lateral walls, which is the thalamus. A closer view of the foramen of Monroy, which is encircled in its anterior and medial boundaries, which is the fornix and body of fornix and colon of fornix. And these are the important veins, which is the thalamothraeate vein. You have to take care not to injure this vein. You can take the anterior septal vein in order to reach the third ventricle, also the superior choroidal vein in order to enter the third ventricle. So this is a first example, a 59-year-old man suffering from progressive memory disturbance and sensory disturbance with this tumor in the anterior horn. I think this is a quite clear indication for the transcallosal approach, and these are the preoperative images with partial enhancement, contrast enhancement. This is the intraoperative view going in between the pericallosal arteries, and this is the tumor, which was a subependymoma of the lateral ventricle, and this is the pre- and postoperative images with complete tumor resection via a transcallosal approach. And this is the patient 5 days after surgery, having no neurological deficits or complaints. This is a more issue of controversy. This is a 44-year-old woman complaining of dizziness and headache of sudden onset. And this is in Cavanoma which has bled, which is just anterior to the frontal horn. In the geno of the corpus callosum. So you have the possibility or two essential approaches, which is the transcortical approach, transfrontal transcortical approach, or you have the transcallosal approach. In the sense of minimal invasiveness, I think the transcallosal approach is the less invasive. It is maybe the longer approach, but it is a less invasive because to reach the Cavanoma via the transcortical approach, you have to transgress this part of the brain, and in the transcallosal approach, it is a minimal invasive. You just have to split the corpus callosum at the site of the Cavanoma and the hematoma cavity, and then you can remove this lesion completely, as you can see here in the postoperative images, with complete removal of the Cavanoma. Pre and post-op, and very small incision in the corpus callosum and complete excision. This is the patient after surgery, having no complaints, and you hardly see any incision here. I think this is a quite elegant approach for this lesion. In order to reach the third ventricle, you have several approach options, one of which is the trans or interphoneal approach, which is not very often used. You have to take care about the internal cerebral veins. The next one, which is probably the most common used one, which is the transchoroidal approach between the choroid plexus and the fornix. And the third one, also not very often used, is the subchoroidal approach on the side of the thalamus between the choroid plexus and the thalamus. This is a classique, which is the colloid cyst in a 22-year-old man, emergency admission with severe headache, nausea, vomiting, memory disturbance, and papillary edema due to this occlusion hydrocephalus. This is a potential lethal lesion, as we know, and this is a typical location and typical configuration of a colloid cyst. Preoperative MRI. I'm going to this through this video a bit faster. This is the positioning. I like to use a longitudinal incision. This is the brain interhemispheric approach. Then going through then this is the corpus callosum you have to split. Then after splitting the corpus callosum, of course, you gain a lot, especially in the case of hydrocephalus, you get a lot of space. In this case, the septum pellucidum was fenestrated, probably due to the chronic pressure of this hydrocephalus. And you could have a beautiful view in both ventricles through this septum pellucidum, and you see the obliterated foramen Monroy on the left side. This is the thalamostrate vein, anterior septal vein, and you see the bulging of the fornix on both sides due to the underlying cyst. This is the right foramen Monroy. In this case, I used a transchoroidal approach. Here, coagulation incision of the anterior septal vein. This is the colloid cyst. Decompression of the colloid cyst. You have to take care not to avulse vessels on the wall of the colloid cyst. Sorry, was too fast. And this is the view after excision of the colloid cyst in both ventricles. So the foramen Monroy on both sides is now patent after excision of the cyst with preservation of the veins. And this is the third ventricle. The incision was around 1.5 to 2 centimeters. You can make it smaller, admittedly, and this is the brain after excision. So this is the pre and post-operative MRI with complete excision of the colloid cyst And this is the patient 12 days after surgery, having no complaints, and yeah, you could just a few weeks later end his job as an engineer without any problems. And this is the incision, as you can see here.
Okay.
This is another case, a 62-year-old man with a familial cavernomatosis. His son had cavernoma, and also his granddaughter had a cavernoma. And he had new symptoms, which was headache, short memory deficits, and hemihypoesthesia. And this was due to a growing cavernoma in the thalamus. On the left side, this is the preoperative MRI, as you can see here. This is the fiber tracking, so it's just beneath the pyramidal tract you have to protect. And this is jumping into the cetus. This is the pericallosal arteries going. It's according to the local anatomy, if you can go through or in between the pericallosal arteries or on one side of the pericallosal artery, and this is the corpus callosum, which is usually good identified with a bright color. And this is the neural navigation helps in these cases. Of course, in this patient, there's no hydrocephalus, so it's a very narrow avenue to get this to reach the cavernoma. And in this case, I used a subchoroidal approach, that's to say between the choroid plexus and the thalamus on the ipsilateral to the cavernoma site. So this is the choroid plexus you can see here. And going lateral from the choroid plexus, between the choroid plexus and the thalamus, taking care not to injure the thalamus. And here you can see the cavernoma abutting on the surface of the thalamus here. So with a small incision, you can see these islands of cavernoma. So in this case, the cavernoma was a bit scattered. It was not one mass which you can nicely remove. There are cases of this. In this case, there were many islands, and you had to take care not to leave any island. This is the main bulk, but as you can see, also these are small islands here of cavernoma which have to be removed in order to get a complete removal. So this is the interpeduncular fossa, which was open because the cavernoma was also abutting on the interpeduncular fossa, as you can see here with the neural navigation. And the endoscopy in this case helped because you can see here small islands of cavernoma left. So this was a useful tool in this case. And so I could also remove these areas of cavernoma left. And this is the cavity after complete removal of the cavernoma. No remnant, and this is the brain after the approach. So this is the preoperative MRI. This is the postoperative MRI with complete removal. This is 8 months after the surgery, pre and postoperative in the sagittal view, and also in this coronal view and with preservation of the pyramidal tract. I used also a stimulation suction in this case and could stimulate the pyramidal tract. And this is the patient 6 months after surgery with complete regression of the preoperative symptoms. This is another case, so you can also go beyond the third ventricle with this approach. A 46-year-old woman with acute double vision and due to a third nerve palsy, left hemihypoesthesia. This was the lesion causing these symptoms. It is in the upper pons, as you can see here. It was also a Cavanoma with an associated DVA here in the posterolateral aspect of the Cavanoma. And in this case, you have the choice, and this was nicely described by Professor Spetzler, the choice to go via the interpeduncular fossa to reach this Cavanoma. In this case, I chose the transcallosal approach because I was afraid of two things, the high-standing bifurcation of the basilar artery and also the injury of the third nerve. So I wanted to prevent, and you can see here the Cavanoma via the transcallosal approach through the floor of the third ventricle. And you see this was abutting on the peeled surface of the pons, and this is after resection. Of course, this is a very narrow avenue to reach the Cavanoma, and this is 5 years now after the surgery with complete removal and no recurrence of the Cavanoma. This is the sagittal view and preservation of all function, and this is the patient 2 years after surgery, having no diplopia and no eye movement disturbance after the surgery. So in conclusion, I think the transcallosal approach, if it is properly planned and if it's of course indicated, it is a quite safe, effective and elegant route to lesions to the lateral and third ventricle and beyond. And you have several structures, as I said, you have to protect during this surgery. And of course, each step you have to be dynamic during your surgery, no dogmatism, and each step is decided according to the local anatomy of the patient. So at the end, I would like to wish to thank Professor Yaşargil. I hope he's in a better world right now without any trouble and conflicts, and thanks to him for greatly enlightening my career due to meeting him and spending time with him. And thank you very much for your attention.
Thank you very much, Dr. Bassioni. Any comments or questions from the audience?
Yeah, I just want to comment that they are very thorough.
Go ahead.
Yeah, those retractorless surgeries, the keyhole surgeries which sir demonstrated were very elegant and very nice. And very beautiful surgeries.
Okay.
Thank you very much. Thank you very much.
Okay, Vlad, I have to kick you off there. Okay, you can screen share later. Okay, just give me a second. Hold on, Vlad. Let me get you off.
Sure.
Okay, I'm trying to. Okay, you off there? Vlad, can you get off the screen, please?
Looking forward.
Yeah, get
Hello,
off the
everyone.
screen. Yeah, get off the screen here. Please, Vlad, can you please get off the screen?
Everything's all right, John?
I'm determined to do this. Vlad, can you get off the screen, please?
Okay.
Okay.
Great.
I'm
Thank
gonna
you.
do this. I've been trying to do this. Vlad, you're being a bad boy. Can you get off the screen, please?
Good. John, when are you going to start your own practice? Because you are listening to all these webinars, you know, must be very experienced neurosurgeon, in fact.
Oh, I'm going to start operating soon. I've heard enough.
Start soon.
Listen, okay, let me introduce Ata Bhatti. He's a neurosurgeon originally from Pakistan. Now he's going to join our team and help Sam and I announce. And he's going to be introducing the next speaker. Okay, Ata, it's all yours.
Okay. After excellent talk by Professor Hisham, now it's turn of Dr. Avadesh Jaiswal from India, Sanjay Gandhi, Lucknow Institute. Please, Dr. Avadesh.
Okay, Vlad, it's all yours.
Professor Avadesh, floor is yours.
I think.
To me?
Yes, go. You're all set, Don.
Oh,
Right.
okay. Okay. Sorry, it's Professor Vladimir Bains first, and Professor Avadesh Jaiswal will follow. Thank you.
Can I talk?
Yes, please.
Very good. Hello, everyone. I'm extremely happy to be here at this remembering webinar on Professor Yaşargil. I first met him in 1971 in Prague. At the time, I was 18 years and not yet a medical student. But my father was Secretary General of European Congress, and there was a special session on microneurosurgery chaired by Yasergil. And the session was in quite a large lecture hall, and there was nobody there. So my father told me, go between the participants and push them in, because we need to have some attendance there. So I finally succeeded to get some 40 people there. I stayed there also. I was amazed. I didn't know anything about neurosurgery at the time, but that was something like eye-opening many, many years ago. Later on, I visited Yaşargil several times in Zurich in the 90s, and it was really amazing. The first impression was the excellent knowledge of anatomy. And if any one of you who remember him, anatomy was probably his most frequently used word. Anatomy, anatomy, anatomy. But then watching him, I realized that there are a few other features which are very unique. First was the efficiency. He was very efficient, very fast, and in his hands, and that was dangerous for us, let's say amateurs compared to him, because everything looked simple. And then you came home, you did the same thing with completely the different result. He really knew how to do that, and that was really the effectivity which amazed me. And later on, I came to the conclusion that he was making things simple. And that's what I would like to talk about now. What is simple? It should be fast, it should be routine, effective, and easy. When you fulfill these four conditions, then you are safe for your patient. And what's now being said quite frequently by many of you all is that simplicity trumps complexity. And that has been my philosophy for many years. So all the anterior and middle skull base, I do approach from Yasergil's pterional craniotomy. Of course, it has many variations, many deviations, and whatever you see it on the image here. But basically what we need are 3 centimeters along the lateral frontal base. So it's frontolateral approach. Of course, there is endoscopic endonasal, which I'm not going to dwell on, but this frontolateral approach in my hands is good for anything in anterior and middle skull base. See the aneurysms. You get all the vascular tree you need, and you can treat all these aneurysms from one single frontolateral approach. And it is not that difficult. It's only knowing your anatomy and knowing your efficiency. The same for basilar type aneurysms. The same from STA aneurysms. You see it, you go in. The first thing, when once you get there, is the aneurysm itself. You clip it, and you are done. Provided you know your anatomy. I think that I was talking about it, that you need a lab. You really need an anatomical lab and be going there, checking the anatomy like the arachnoid. You see all the cisterns, you see all the arteries, all the veins, everything. And once you know the anatomy, then everything's much, much easier. See this multi-compartmental meningioma, which can easily be removed. This is the part which is supracerebral in lamina terminalis cistern. you know that this cistern is specific, that you need to get there. Once you know that in advance, it's not really that impossible and difficult to resect the tumor entirely, provided you know how to do your anterior clinoidectomy. Going more posterior, even the tumor which is on tentorial edge, posterior to the vessels, posterior to all the perforators, posterior to MCA, you can reach it by the same approach, by the same frontolateral approach, and you get a nice result after the surgery with a happy patient. So just about anything in my hands which is supra is approachable from frontolateral approach. And I have, over the past 25 years, I virtually have not used any other approach but this. And I was always happy, from anterior skull base to the tentorial hiatus, everything. And in posterior fossa, it's again the same, simple, easy. There are three basic approaches: supracerebral, infratentorial, retrosigmoid, and infralateral. I don't much use retrosig. I use supracerebral infratentorial, which I really love. It's either microscope or even better with the exoscope. Look at the ergonomy. Here you have your hands extended, and small neurosurgeons are unable to perform this procedure. With exoscope, you get better angles, and you have your hands flexed. You do not get tired if the surgery is longer. If you use lumbar drain, small craniotomy, small dural opening to prevent the prolapse of the cerebral hemisphere, and immediately after the dura opening, you see the tentorial hiatus. You are there immediately, extracerebral and easy. Again, you need to go to lab and you need to study the anatomy, 7th, 8th, 5th. You see everything there. Here at the 5th, and you well know that the arachnoid caudal to the 5th is distant from the brainstem, and cranial 5th and especially 6th, it's very close. So that will be the dangerous place of your petroclival meningiomas. See the anatomy here. Simple, easy tumor approached from supracerebral, infratentorial route. You just resect the tumor by CUSA, by any other means. Then you resect the part of the tentorium, which is the tumor origin. And to save time, I shall go forward. This is the anatomy of the approach. The tumor was exactly where the stitch was. And you know in advance, knowing your anatomy, that you will hit the ambient cistern with the fourth nerve, and then you will hit the crural cistern with the anterior choroidal and with Rosenthal vein. And this is exactly after the surgery. You see, this is the intact ambient cistern, this is the Rosenthal vein, this is the choroidal artery, and here is the fourth. And once you know all this, you are much safer to your patients. Retrosec in my hands is really for the eighth nerve schwannoma, and then exceptions like this Cavanoma of the eighth nerve, the young boy coming in with hearing decrease. This is after the resection of the Cavanoma, and you see the MR postoperatively, and the hearing improved to normal. And then the last approach for the skull base is lateral or far lateral. I call it enough lateral suboccipital and enough teloveral, because moving the tonsil is an inherent part of almost all the procedures, and I'm not a big friend of too much of drilling, because the angle of approach is given by the slope of the muscles. As you dissect the muscles, this is what determines your angle of approach, and not the amount of drilling. And anything you are doing in this region, you can do above and below the condyle. So condyle drilling is not really that much necessary. This is this approach. It's good to have it across the midline. Then you get much better orientation. Again, the same position, and again, either microscope or exoscope. I again find exoscope better, because you get better angle when you are looking from down up, and it's much easier. So these are the aneurysms you can treat. Actually, this is an old case, and I would say that nowadays I wouldn't be brave enough to offer surgery to the patient. We would go for endovascular, but at the time I did it, and that went well. But this really called for some more drilling. tumor, this is plexus papilloma. You need to enter the fourth ventricle. You need to enter the CP angle, foramen magnum. If you have this enough lateral approach, you can go from lateral side to the CP angle, dissecting the tonsil. Then you dissect the tonsil from the medial side. You lift the tonsil. You enter the fourth ventricle, and this is the patient after the surgery, completely without any deficit. Pica aneurysms, ruptured pica aneurysms, in my opinion, are the surgical disease because you can clean all the CC region of the blood and you can clean the fourth ventricle of blood, and the improvement of the patient is much faster and better than in patients which are treated by endovascular means. Here you see the ruptured aneurysms. This is again this enough lateral approach, and this is after surgery. You see the clean fourth ventricle being approached from lateral, and you see the clipped aneurysm. Here's the low-grade tumor, which is in the whole region from C2 up to the meatus. This is the approach. You see that the resection of the condyle is modest. What's important is dissecting the tonsil and lifting the tonsil up. Here we are in the spinal canal, that the tumor, the yellowish tissue, the arachnoid section as the most important part, because then you know where you are. This is the part of the tumor which is in the canal, developing the plane between the brainstem, which is here, the tumor, decreasing the size of the tumor. QSA is an excellent tool for this. And you are going from caudal upwards. There's a nice plane of dissection in the region of medulla, and you can really find the proper plane of dissection, which will disappear at the very end. Here is the vertebral artery. You see that the tumor is nice, rather invasive against the vessels, and you go higher up, going into the CP angle, rather steeply, still resecting the tumor, and then you release the tonsil, lift the tonsil higher up. You reach the fourth ventricle from the lateral side, not from the medial side as it's usual. You see here, the fourth ventricle is up here. This is the pons. Here is the tumor. At this point, I somehow lost my nerves. And this is by the end of the procedure. Here are the remnants of the tumor. Here is the fourth ventricle. And you are looking from the side into the fourth ventricle. Tonsil is lifted up over here, and then again released to fell down. And this is after the surgery. There is the remnant, which is stable. The remnant is now stable for 6 years. Then the girl delivered 2 healthy babies, and she's really symptom-free and doing rather well. I'm afraid that should I have resected the piece in the peduncle, cerebral peduncle, I would cause her much troubles. Exactly the same approach for hemangioblastoma of CC junction. You see the really ugly lesion on the whole lateral side of the brainstem, and this is after surgery. The patient did have after the surgery 9, 10s, and 12s palsy, partial unfortunately, and within half a year he improved to normal status now. So what you really need is a lab to train everything, because someone said it today that you cannot start on the patients, you must start on cadavers. And once you get really good and knowledgeable in the lab, then you can go ahead. See, this is Igor Maldonado in Tours. We are doing some course in Kochi in India, and you see how happy is he? How happy we are here in Spain, just dissecting. You know, you really learn how to enjoy it. So in conclusion, not to be too long today, basically 3 simple approaches cover everything. It's all 3 of them are routine, fast, effective, and then thus they are safe. They all provide enough room, enough flexibility, and good visibility in any angle. There are no extra risks related to the approach, which is in my mind, really big advantage, because these are routine approaches which are easy. Supra-infra, it's 20 minutes craniotomy, some simple pterion, again, 20 minutes craniotomy without any risk, as opposed to various petrosectomies and various extra far lateral approaches, whatever, down to the 12th nerve canal, which is not really necessary. And in my mind, minimal invasivity is not a question of the approach. It doesn't matter whether the wound is 3 or 5 centimeters long. The minimal invasivity, in my mind, is related to the lesion itself. The surgeon should behave minimally invasive in relation to the lesions and not to the approach. And I believe that Professor Yaşargil would fully agree with this, because he practically behaved in this way. So what we need is a triple H. It's humility, honesty, and hard work. Thank you very much for listening to me, and I hope that I was simple and clear enough. Thanks.
Hey, Arthur, I have to unmute.
Muted?
Okay, thank you, Professor Benz, for wonderful talk.
Thank you.
Now, any questions or comments, please?
Can I ask a question?
Sure.
Yes,
Sure.
sir.
Vlad, hi, it's Sanjeev. Vlad, I agree with you fully that drilling the condyle is not necessary. But what's your view on drilling the jugular tubercle in these tumors? Even the case you showed, would that give you more space coming around the front of the brainstem?
Sanjiva, that's a very important question and a very good one. I'm not drilling the condyle, but what I'm drilling is the posterior skull base as much as possible as far as jugular foramen. This is exactly the part of the craniotomy which is most important, and where you need to be flush with the skull base, and whenever needed, then you go on for tubercle. I'm leaving the condyle behind then.
Yeah,
but you are perfectly right. You need this piece of craniotomy to be flush with the skull base.
Thank you.
There
Thank
is
you
a
very much.
little perforator in the middle of the distance between the mastoid and the midline. And once you reach this, then you are in the proper direction.
Okay, thank you. Can I ask Dr. Baines for subcondylar, pericondylar venous plexuses and handling it during your approaches to
That's exactly the point why I do not need to resect that much, and I don't like to resect that much, because these plexuses sometimes are very difficult to control. Barnard George was always talking about periosteal sheet. He always said shit, that's why I remember that. And that's the plane of dissection, but once you get the bleeding from them, then only the packing will help. No coagulation, no nothing, only the packing. But I don't drill that much as to harm them too much.
Thank you. So can we move to the next speaker, Dr. Sanjeeva Jayarathne? He's going to talk about the anterior clinoidectomy and central skill for the skull-based surgeons. Over to you, Dr. Sanjeeva.
Thank you.
Okay, Vlad, you have to leave your, okay, there you go. Okay, we're all set. We're all set. Go ahead, Sanjeeva.
Thank you. I'm just trying to share.
Okay.
That's weird. Why do I not have the option to share?
We don't
share your image, which is not bad.
Have you updated your Zoom lately, Sanjeeva?
Sorry?
Have you updated your Zoom
Sorry,
lately?
it's fine. It's fine. It's fine. No, sorry about the slight delay.
Okay.
Back on track.
Perfect.
Oops. Thank you very much for this opportunity to speak. And I'll be talking about clinoidal meningiomas and how that's to how dealing with the clinoid is a key skill for any neurosurgeon. I'll jump straight into it. I know there's a sort of range of levels, and I'll try and cover something for everyone. The first thing to say really is about positioning, and in any skull-based tumor, that's key. This is the diagram, and obviously you can read the slide, but the main point is that you shouldn't turn the head too much, and getting that malar uppermost is absolutely key, and that's the real key to retractile surgery. I don't think many people are using retractors now for a lot of these cases. Definitely, we wouldn't for any sort of large meningiomas, but the real key here is that malar uppermost and draining CSF, and that allows the frontal and temporal lobes to really fall back. Once you've got the positioning right, I've spoken about this before when I talked about terionals and things. The next thing to understand is that subfascial approach. You can go sub or interfascial, but the key point is that the temporal branch of the facial nerve runs on the superficial temporal fascia. This diagram is slightly wrong, but the point is correct, that it's on the superficial layer of the fascia. And what you want to do is you want to get that layer forward with the skin. The temporalis muscle comes down and back, and that gives you that fantastic view down the sphenoid. That's what this is all about, getting that great view down that sphenoid. The next thing to understand, once you've sort of started to done a craniotomy and you're drilling for these sort of approaches and approaching the clinoid, is about separating the layers of the cavernous sinus. And that's what this is all about how if you can get to the superior orbital fissure right here, and you can peel, and I'll show that in the video, peeling the layers of the cavernous sinus apart is what really exposes this enteroclinoid process.
Ja.
And you'll see that this view again.
Ja sam Peter Daniel.
Sorry, Vlad, I think you're not muted.
I'm sorry, I'll get him.
And what exposing that clinoid gives you this great view onto the carotid and the optic nerve in this sort of coronal section here. Okay, so these are just a few more anatomical dissections showing that. We're clearly on the right-hand side here. This is frontal dura, this is temporal dura. You should always drill to the meningorbital band, coagulate the small vessel there, and then you're going to peel the dura propria off the cavernous sinus. So temporal lobe is going to come off cavernous sinus, exposing this clinoid, shown in this picture here on the right. And so you got periostal dura, temporal dura, and it's a very basic skill to have, I think, for a skull-based surgeon, exposing the clinoid and giving you that great access to the enterofossa and the optic nerve. And as I said, I'll show that in a video. The next bit, of course, is the true sort of clinoidal anatomy. So you can see the clinoid here, and I'll show its relation to the carotid next. But you have to understand it has 3 attachments. So you have roof of optic canal, you've got the lesser wing and the optic strut. And it's very important to disconnect the roof of the optic canal and the lesser wing, and then you're going to thin down to a strut, and where it's safe, you can sort of fracture that out. I don't think it's necessary to really aggressively drill the strut. Okay, so the main points are disconnecting at the optic canal, disconnecting at lesser wing, coring this out towards the strut, and then you can fracture out. And this is what it gives you. It gives you this fantastic, if you're a vascular surgeon, access to carotid cave, very low PCOMs, all of that, you can get proximal control. But for a skull-based surgeon, absolutely key. In clinoidal meningiomas, you immediately devascularize. That's the case I will show. In a lot of lateral compression, in sort of juxtacellular meningiomas, you decompress the optic nerve. Of course, if the compression is medial, you would likely come endoscopically. But this is the point. You get really low control of the carotid and you decompress the optic nerve. That is the main point. The other key point here to understand, of course, is that while you're drilling out the clinoid, you have to understand how the carotid is inferior and medial to you in more than one location. Okay, this is a cadaveric dissection just to illustrate the sort of fantastic anatomy you can expose. So here we've split, the temporal lobe has been taken back. This is carotid. I've left the clinoid intact here. This is third nerve coming under the clinoid. These are branches of the trigeminal nerve. And this is the sort of anatomy that you expose by that lifting of the temporal lobe dura off the cavernous sinus. And as I said, a real essential skill for any skull-based surgeon. I'm going to skip forward in the interest of time. Just a view again on a cadaveric dissection, and Vlad emphasized the real importance of cadaveric dissection, but I'll skip that forward. I've covered this before, so I won't go in detail, but there are 3 types of clinoidal meningiomas. I'm going to talk today about the most difficult type, this type 1, where it starts very proximal on the clinoid and it may not have a good arachnoid layer. Most of the clinoidal meningiomas, most people would see are type 2, very lateral and very large, a lot more straightforward than these type 1 clinoidal meningiomas. And this we've understood for a good, 35 years. The paper was in 1990. Okay. This is the very small clinoids, the type 3s that present at the optic canal. Certainly in a Western population, they present very early with visual deterioration, more straightforward to deal with. I won't show any videos on that one, but I'll skip that. This is the one most of you will see, this type 2. It comes off the lateral part here, has nice arachnoidal planes. You can get just with a standard pterional craniotomy, just like Vlad said earlier, that's all you need. Standard pterional, you can get very good resection, complete resections. Obviously, take the clinoid with a complete resection. I won't talk about that, but I have to emphasize these are straightforward, should be resected fully and safely. No need for things like an OZ and all of that. I think that's really not required at all. Another example, resected fully, patients doing very well. This is another reason to understand clinoidectomies. You may want to decompress the orbital apex, cavernous sinus. I don't think we have time to discuss that, so I'll move on, but another indication and important to understand. Okay, so type 1s, these are the difficult clinoidal meningiomas. Complete resection is not always possible. They originate very low on the clinoid, and because of that, may not have intact arachnoidal layers around them. I say may not, and this is a case in point that I will show. Of course, this is to remember Professor Yasergil, who still has some of the best papers ever on the anatomy of the brain. This is taken from his book. The absolutely beautiful descriptions of the arachnoids everywhere, but here I'm showing relevant to clinoidal meningiomas. I would recommend everyone to read these fantastic papers. And Professor Yasergil, of course, showed beautiful technique in the intradural clinoidectomy, but I will talk about the extradural one today. So this is the key bit of anatomy and why these can be more difficult. This is an endoscopic view of the proximal carotid under the clinoid, and this is the optic nerve. And you can see, unlike everywhere else in the carotid, it has this sort of potential naked area. So it doesn't have that arachnoid that is present everywhere else in the carotid. And that's what makes the type 1 clinoidal meningioma more difficult than the others. And this is a key bit of anatomy that's very important to understand, that not all clinoidal meningiomas are the same. And I'm going to talk about the more difficult type. So here's an example of what we thought was a potential type 1. They're actually very hard to predict. Very lucky to have a high-res photon counting CT in Oxford. I'm trying to see if we can predict preoperatively, but that remains challenging. Right, let's have a look at the scans. So the anatomy, as always, as Professor Yasergil said, is important to understand. So when you first look at it, it looks quite, it looks challenging. There is this temporal component, clearly compression on the optic nerve. We'll confirm it in an angiogram, the carotids within it. PCOM, A1, M1, everything's inside this tumor, okay? And she's a little bit older, vision is deteriorating. Next key bit of anatomy to understand, and the more you understand, the more you sort of see, is these tumors are fed by the infralateral trunk and recurrent ophthalmic branches coming off the ophthalmic artery. That's the blood supply to that area. Again, early 2000s, Rotan described that. And if you're doing meningiomas in the skull base, if you're doing dural fistulas, you have to understand this anatomy. So in keeping with that anatomy, just a few more pictures. This is a high-res CT angiogram. And you will see, just as you would expect, based on that anatomy, that it is the recurrent branches. There you go. Different to the other side. They're much hypertrophied. And infralateral trunk, just as you'd expect. Okay, so the anatomy is, once you understand the anatomy, everything happens just as you would expect. That's what's supplying this tumor. And as we start to come higher up, you'll start to see that the carotid is within this tumor. PCOM is there, PCOM perforators, A1, M1, as we saw on the MRI scan. Okay, so that's carotid there. You saw the PCOM coming off, A1, M1. All right, so everything as we think. So let's get on to the operative video. So the first thing to say is, because you understand the anatomy, you can devascularize this tumor early. So standard pterional approach, we're going to flatten anterior fossa floor. I'm going to skip forward and show some of this interesting bits of anatomy. So splitting the superior orbital fissure. I'm going to take the temporal lobe off the cavernous sinus. Okay, so you can see the two layers of dura being split, quite easy to do once you get the hang of it. So temporal lobe is coming off, cavernous sinus dura stays there. The blood supply is in this layer, and I'm going to devascularize this tumor early. So there's recurrent ophthalmic branches, infralateral trunk branches, all of that. We're going to devascularize extradurally. I'm going to skip forward, but you'll see this bit in this tumor is particularly bloody, but it gets devascularized. Okay, so this is cavernous sinus dura. Temporal lobe is here, and the tumor is being devascularized, and we're exposing the clinoid. I'm going to skip forward in the interest of time. They're exposing the clinoid, standard drilling that I sort of discussed. There we go, flattening anterofossa floor. Then we're going to drill out the clinoid. I'm going to skip all of this in the interest of time and go intradurally. So optic canal's already been decompressed extradurally when we took the clinoid, but you can see this tumor is now a lot less vascular than we expect. And interestingly, the planes are also better than I thought they would be. So unclear this is a true type 1. Given the planes are very good, we're then going to debulk a lot of this tumor, and I'm going to skip forward significantly in this. I'm going to debulk, more showing the planes are quite nice. So really important technique here, you don't fry the arachnoid. Yeah, important not to seal the arachnoid to the tumor. So this peeling is important, and then you debulk, and that gives you the best chance of getting a nice complete resection safely, and the brain remains intact. So I'm going to skip forward. Right, okay. So optic nerve is here. There's tumor on both sides. That's contralateral optic. This is ipsilateral optic. Carotid is going to be there, and actually you can see the planes are nice, aren't they? And it turned out they were quite good, except on the sort of PCOM. So that's A1, M1 coming into view, carotid. So in the interest of time, I'm just going to skip forward massively here. So just finishing off, optic canal, as I said, was opened extradurally. Yeah, this falciform ligament was here. Clinoid is gone. That's carotid. This is ipsilateral optic nerve. All of this tumor medial to it within the optic canal is all going to come out. And you can see most of the tumor is already gone. I'm going to go towards the end. I did leave a small amount on the PCOM perforators just because I felt I couldn't separate it well there. Their final view, optic nerve, falciform opened, optic canal opened, clinoid gone, carotid, A1, opposite side carotid, M1, small residual on the PCOM. I'll show you the immediate post-op CT scan. So this is what was left, this very small residual. As you'd expect, the vision's better. It was a grade 1 meningioma in the 70s. We'll follow that up. So just an example there on why understanding the clinoid is important. Real critical skill, I think, in a lot of these anterofossa, and here I'm showing Cavanoma Meningiomas as an example. But I think for any skull-based surgeon, you have to understand this. Thank you again for the invitation to speak. It's always a real pleasure. Same runs fantastic events, and John, you're obviously working extremely hard on all of these. So thank you for everything you do, and happy to take any questions.
Thank you, Dr. Sanjeeva. Any question or comments?
Yes, please. Sanjeeva, you have that naked portion of the carotid artery in type 1. For me, the routine approach is cranioidectomy, extradural one. But in type 1, I always only release the tip of the clinoid. I'm not resecting it extradural because I'm afraid the tumor may really be so intimate with the carotid that I could tear it. So I finished the cranioidectomy intradurally.
Yeah.
Only the piece of bone.
Yeah. I've said I haven't seen a problem with it. So I do a lot more skull based than I do vascular, and I wonder if that maybe is the slight thing, because I think vascular surgeons definitely do like the intradural, don't they? But I personally think that dura is still intact, but it's the arachnoid that's not there. So I think it's still safe for that. But I see your point on why that might be a concern. But I think it's the arachnoid that's not there rather than the dura. So I think it's quite safe, actually, for an extradural clinoidectomy in these meningiomas.
I shall show you a video where you will get convinced that it may
I don't
be
see that video.
one piece. That's why I'm doing it that way.
Sorry, someone else says, Arun, you have your hand up.
Yeah, am I audible?
Yes.
Yeah.
Yeah, very nice presentation. Actually, back in India, as Vance was saying, it happens in few cases when this clinoid is actually buried into the meningioma. It's actually very difficult to take out completely extradurally. But it's so nice video. But I just wanted to ask you, because I'm doing from last 1.5 decade this extradural clinectomy, dwellings approach, transcavernous approach, learned from Ali Christ. So, what's your take on sphenoparietal sinus or superficial middle cerebral vein? Because when you do this dissection, so I mean, it's in a blunt way, many time you injure these veins. So I started doing from last 3-4 years sharp dissection, only sharp.
Yeah, so I mix. I don't know. I mean, I skipped in the video. I mix between the two, but you're right. I do like the blunt dissection as well, actually. Again, I don't know. I mean, it sounds like you've got a massive experience in this. So, I've not seen any problems with that blunt. So, is your concern that you obstruct the spheno or damage the sphenoparietal sinus during that blunt dissection? Yeah, I haven't seen that, but I wonder whether because the initial bit is sharp and whether I'm taking it off initially, and maybe that's how I'm avoiding it, that the initial bit is sharp. But I think that's a really nice point, actually. But I've not had an issue there with that. But it might be because the initial bit is sharp. But certainly once I get into that plane, I feel it. I don't know. I feel it comes nicely blunt. But yeah, no, I think that's a really good point.
Okay. Thank you, Dr. Sanjeev.
Thank you.
Now we move to next speaker, Professor Avadesh Jaswal from Lucknow.
I'm not sure. Is he
Okay.
here? Is he here?
Okay. In that case, we can move to the next speaker, Dr. Arun Srivastava. If he's
Yeah, I'm here.
okay, please.
So, am I allowed to share my PPT?
Yes, please.
Sure.
Hope my slides are visible.
Perfect.
Thank you. So starting with this case of a female 4th decade, presented with very minimal symptoms of raised intracranial pressure. And we started with working diagnosis of pineal parenchymal tumor as CSF came negative. And then we decided for this endoscopic third ventriculostomy and biopsy. Everything went fine. We irrigated the ventricle for 5-10 minutes, and then things were looking okay. But in night we got this CT scan showing bleeding in the residual tumor and the swelling of the tumor with increasing eye signs. So in night we operated upon this case, and then patient had a very bad course in ICU, and with a lot of difficulty we were able to save this patient. So when I look into my own experience of what I have found, that most of these cases, if we leave this meningioma and epidermoid aside, then most of these tumors are cellular. And this AI is coming in big way. So CSF analysis, radiology can accurately diagnose in the tune of 78 to 80% cases. And then 40 to 60% of these cases can be treated with adjuvant treatment or neoadjuvant treatment. And we know that through literature that even stereotactic biopsy is having a lot of morbidities. So swelling and bleeding in post-biopsy cases is very, very common. In 90% cases, they have been seen. And in our experience, we have converted 12 cases out of 57 cases of biopsy. Within 24 hours, we re-explored with various microneurosurgical techniques. So my take is biopsy, if you are doing, be aware. So that is why I would like to, thank Professor Yaşargil, the mentor of mentors, because I didn't had much, fortunate to interact directly with him, but I been, lucky enough to go through the mentors who've been mentored by Professor Yasergil, and he said that scalpel didn't cut So his scalpel never cut. He actually inculcated, instilled hopes in neurosurgeon like us. So thank you, Professor. What you taught that no area is challenging, whether it's a equidistant, deeply located area like posterior third ventricular, surrounded by the very important and challenging structure like neurovascular structure and major veins. I used to call it as a tentacles of pod, because most of the time the tumor is growing between the pods of this venous structure. And I had experience of operating almost all kind of pathologies back here in India with the approach. What I'm going to describe is the gravity assisted occipital transtentorial approach. So the surgical option is very straightforward. You have to see in which part of the posterior incisorial space the lesion is lying. If the lesion is epicenter in the anterior part of the posterior incisorial space, you can come with the transcallosal or you can come with the posterior interhemispheric approach. But if the lesion is epicenter in the posterior part, we have options like occipital transtentorial or supracerebellar infratentorial approach. Then other factors to be encountered for, like lateral extension of the lesion, superior extension of the lesion, and the inferior extension of the lesion. Then another very important factor is the relation of these lesions with the deep venous system, mainly the internal cerebral vein and the galenic system. And obviously the expertise of the surgical team in which particular procedure they are good with. So I'm going to present my experience with this gravity assisted retractionless occipital transtentorial approach. So as we know that various approaches has been explained in the background of the venous structure and relation of the venous structure with the lesion. If it's below the internal cerebral vein and pushing the galenic system up, the best approach described being the supracerebellar infratentorial approach. If it is going in one direction, then you have the option of going with the any one of the approach, supracerebellar infratentorial or occipital transtentorial. But if it's pushing the vein down, then obviously the occipital transtentorial approach, and for the tectal plate lesion, the occipital transtentorial approach are preferred. So what we are doing at our place? So there are the equivocal indications where when the both supracerebellar infratentorial or occipital transtentorial are having equal indications, then we are looking for this supratentorial extension, the inferior extension. If these are significant, lateral extension are significant, Tarcula is low lying, the tentorial angle is unfavorable, we are going for the this occipital transtentorial approach, where we are following the teaching of Professor Yasergil. Take the natural corridor, try not to retract the brain, not manipulate the normal brain. So we are going with the gravity assisted approach. And the cases where the venous system is pushed down as velum interpositum meningioma, where by default these meningioma are pushing the vein down, in most of the cases, we are preferring this occipital transtentorial approach. And obviously the definitive one where the lesion is arising from the tectal plate like glioma, cavanoma, or sometime tuberculoma arising in that area and some other vascular lesion. So the advantage, what I learned exercising this gravity assisted occipital transtentorial approach in 1.5 decade of experience with this approach, that there is no retraction of the occipital pole. So there is no very minimal chances or no chances of field cut related to the manipulation of or injuring that area. And then once you cut the tentorium, you have a wide exposure of infratentorial as well as supratentorial compartment. Ambient system opening further laxes the brain, and then you can utilize the distorted venous anatomy. The tentacles of pods is widened and spreads with the lesion, and through that corridor you can take out this tumor. So I'll take you through one of example case. So positioning is if you are doing occipital transtentorial in prone, you have to learn the changing anatomy if you are shifting to this very approach. And then a lax brain is sacrosanct. You should start your procedure with lax brain. You should not be relying only on the gravity-assisted retraction. So you have the double dandy point in your view. You can drain the ventricle, but it should be gradual and intermittent. And then you should be cutting the tentorium after opening the ambient cistern, and that can be done in antegrade manner or retrograde manner. I'll show you in my video. So we have a good experience of operating various pathologies through this approach. And to date, almost 39 cases been operated through the gravity-assisted occipital transmitter approach. So this is the case 28-year-old male. He presented with raised intracranial pressure, including diplopia. And CSF and other investigation was within normal limits. So we decided for the definitive surgery. And it's the right-sided approach. So you understand the anterior, posterior, and right occipital lobe is actually retracted with the help of gravity, and the ventricle has been drained. And then this is the retrograde tentorial cutting from H towards the straight sinus and transverse sinus junction. Now this is the opening of the thick arachnoidal band around the galenic system. I'm sorry, it's one of my very old video. And after cutting the thick arachnoidal band around the Rosenthal vein and vein of Galen, now you can see those corridors which we are going to utilize. So subsplenic splenial area. So this will expose the anterior pole of the tumor in this case. So I can see the anterior pole of the tumor through this corridor. And then you see the occipital vein, deep occipital vein, and you see the Rosenthal vein. So you can see the lateral part of the tumor through this. These two tentacles are part. Then the best corridor, we all know, is the interrosenthal corridor. So I'm able to see the big chunk of the tumor and posterior part of the tumor through this corridor. The Rosenthal vein should be mobilized before manipulation of this important vein. Surface vessels were coagulated, tumor was cut, biopsy was taken. And then, as I said, most of these tumors are highly cellular. You have to put suction, even you don't require to put ultrasonic aspiration in most of the cases. And then this tumor will deliver itself. A control suction, the tumor will start revealing, because the CSF pressure, that is why you should not be draining much CSF, will be pushing the tumor. The tumor from the aqueduct is removed. You can have this beautiful anatomy, and rest of the tumor was removed through the interrosenthal corridor. Now the complete tumor removal is done. This is at the end of the surgery. Patient, after almost 11 years of follow-up, is not having any residual tumor, and the biopsy turned out as ependymoma grade 2, and so no adjuvant treatment was required. So coming to the next case of 22-year-old male, right-handed, again raised intracranial pressure. Opening of the ambient cistern. Again, retrograde cutting of the tent. sometime I take help of this Colorado needle for cutting this tent. Thick arachnoid over the galenic system was cut, and this tumor was actually a pilocytic astrocytoma. So all the vein, the rosenthal was lengthened, other vein in that area was separated, and you see the corridor. You get a very nice corridor as occipital lobe is retracted with the help of gravity, and then after cutting the tent, you get a wide area to work around the tumor. And then this tumor was, the solid component was removed. Precerebellar vein was preserved because I don't, sacrifice this precerebellar vein, though literature says that you can cut this precerebellar vein, but I usually avoid cutting any vein in this area. And this is at the end of the surgery. This patient is in the 7-year follow-up. There's no recurrence and no adjuvant therapy was required. This we have operated as young as 18-month-old baby girl with this approach, and you'll see that this is not an issue. Only the pin, we have taken a very, small pin for this kid to hold the skull. And after that, everything was very favorable. This baby was shunted, so no tapping was required. And then tumor was decompressed. And when required, this tentorial cutting, in this case, is what done in antegrade manner, can be increased to perform adequate tumor resection. So this girl did well, and then unfortunately her biopsy was anaplastic ependymoma, and she succumbed to the complication of this malignant tumor in 2 years. So last case is 42-year-old female presented with this meningioma, and this was also operated through a gravity-assisted occipital transtentorial approach. I'll take you fast through this video just to tell you and show you that how elegantly this approach provides control over the lesion on either side of the midline, and then you can perform and complete the tumor removal. So my take-home message for this approach is actually, if you are shifting from prone position to this very elegant position approach, you have to understand this change in 90-degree rotated anatomy, and do not rely only on gravity. The CSF diversion is very important. It's the key. And these venous anatomy, which are actually poses a lot of difficulty, and that inhibit a surgeon to go for this approach. We have to understand with pathology, they are actually expanded, and they provide a lot of space to go ahead with the nice adequate tumor excision. These are my suggested reading. And while waiting for my turn, I draw this to thank Professor Yaşargil again. And I'm grateful to the committee for giving me this opportunity. Thank you so much.
Thank you, Dr. Arun, for reinforcing the message of avoidance of retraction and preservation of veins in microneurosurgery. Is there any question? So in that case, if there is no question, can I ask one? That we all know that the deep venous system has a lot of variations. And are you happy doing the MRV, CTV based preoperative workup versus having a dynamic picture of DSA, telling the reserve and anticipating how the rerouting of venous return is a possibility. So static images cannot give that detail, like the venous drainage on BSA in a trained person reading those images. So what is your take on that? Thank you.
Yeah, very valid point. But to date, I really go ahead with the MR venography study. And as I said that actually the venous anatomy, whatever type of venous anatomy is there, it actually distorted with the tumor. Then we have to understand about three important vein. One is internal cerebral vein, one is Galen, and third is Rosenthal. Actually, these three veins dictate your surgical corridor inside that insusural space, and as well as they dictate the surgical outcome. So I go with the MR venography in all the cases and try to understand how my veins are, distorted with this pathology.
Okay, thank you. So it's challenging to deal with the veins compared to arteries with the thin walls. It's very helpful for all the neurosurgeons getting this reinforced message. Thank you.
I didn't.
You're sharing the screen, Aaron. Could you get off the screen, please? You stop the screen sharing. You're still screen sharing. Okay, there we go.
Okay.
Thank you.
Thank you. So the next speaker, I hope Dr. Jaswal, Avatish Jaswal will make it this time. It's third announcement for him. Yeah, I see his
Yes.
presentation.
Is my slide are visible?
Yeah, perfect.
Okay. Thanks. Thanks everyone. Thanks the society. I'm going to talk about transorbital neuroendoscopic surgery. So before I start this presentation, I request everyone to have this book and read it. It's a wonderful book on biography of Professor Yasergil. So this is a new approach which is gaining popularity very fast. And if you type endoscopic transorbital approach on PubMed, you will get number of articles and in recent years. And that shows that how popular this approach has become nowadays. These are few publications. If somebody is interested, they should go through it, and they are really wonderful, and that opens an idea about all this approach. So this transorbital neuroendoscopic surgery has been described various zones which can be assessed with this approach from orbit to lesser infrared wing, middle fossa, lateral cavernous sinus, infratemporal fossa, Peters apex, and anterior channel fossa. These are the various stages of difficulty from stage 1 to stage 5, from extraconal extradural lesion to MCA aneurysm and insuroglioma, which can be addressed with this approach as somebody get experience in this approach. So basically, what is the rationale of this approach? This TOS offers distinct advantages over the conventional approach, like it provides direct and shortest route to the lesion. It's minimally invasive. There is no or minimal brain retraction. CSF leak is very minimal and excellent cosmetic outcome. So these are the few schematic diagrams showing key surgical steps. You have to make a superior eyelid incision, then expose the lateral orbital rim, then cut the lateral orbital rim till the greater building up sphenoid, expose the temporal dura, and then, depending on the lesion, address the pathology. So to present some cases, this patient presented with was operated right fifth schwannoma 3 years back, presented with recurrence. You can see small recurrence is there in the middle canal fossa, paramedian. This is the video. This superior eyelid incision, exposure of the greater orbital rim, lateral orbital rim, then prefixation of the orbital rim, then lateral orbitotomy.
Hello.
Then cutting the hello.
Hello.
Yes.
Krishna.
Then we do not remove the lateral orbital rim, rather keep it in the place, just detect, and then drilling the greater wing, isthmoid wing. Basically, we are doing under endoscopy vision, but the principles are of microsurgery in this procedure. Then drilling the sagittal crest. Now we have exposed the tumor using microsurgical technique as advised by Professor Yasergil. Under endoscopic vision now, dissecting the capsule of the tumor, piecemeal dissection of the tumor, and then dissecting the capsule. This is the cavity and filled with the some fat, and then the fixation again. So this is the post-op CT. Complete tumor had been removed. You can see in the here the bony defect, and the post-op day 4. Later on in follow-up, patient was doing very well. This is another patient having middle spine with meningioma, presented with headache. This is the short video. Exposed to tumor, temporal dura, dissecting the tumor in the piecemeal. This tumor was small and not having any vessel in the surroundings. So dissecting tumor and bringing out in the operative cavity and taking it out. You can see here this is the temporal lobe. We use an endoscope holder for this procedure. In other procedures, assistant usually hold the scope. The tumor was soft also, so made the procedure easy. So gradually dissecting tumor, taking out in the, bringing the operative field. So taking out the last part of the tumor now. So this is the temporal lobe, hemostasis with putting some fat wrapped in the Surgery cell. So this is a follow-up MRI after 4 months. Biopsy was meningioma. There was no residual. This is picture of post-op day 1, and this is follow-up 4 months. This was our very first case, and it's difficult to say which side the patient was operated. Another girl, lady presented with right side hemifacial pain with right side hemifacial hyposphagia. It was an epidermoid cavernous sinus. This is a short video. Exposure was same, just like shown earlier. Piecemeal dissection of the epidermoid. This is the part of the hole towards the tumor was going in the posterior fossa. And this is view after complete excision. This is excellent cosmetic result and follow MRI showing complete tumor excision. This patient presented with headache and right side orbital pain and proptosis. There was a bony tumor. Removed to same approach, although it was subtotal excision. The biopsy was benign osseous lesion. Patient has excellent cosmetic result. It's large right-sided trigeminal schwannoma. You can see middle fossa component, posterior fossa component. With the same approach. This cavity after excision of tumor, middle fossa gone, posterior tumor removed. This is a brain stem. This is a post-op scan. Complete tumor had been excised. This patient developed a pseudomeningocele, required LP shunt later on. This patient presented with right side, left side proptosis. There was large tumor present in the orbit, lateral side. This superior eyelid incision, same approach. Here we did not remove the lateral orbital rim. The tumor was projecting outside even. Gradually dissecting the capsule of the tumor. The capsule was thin, got ruptured. gradually bring the tumor outside. So the complete tumor was excised. We were thinking that it may be Cavanoma, but came out to be metastasis from the renal cell carcinoma, especially was known case of renal cell carcinoma. This is the operative cavity. This post-op scan, complete tumor removed, follow after 3 weeks, process resolved completely. Patient received radiotherapy. This another patient presented with V1, V2 hypoesthesia, cystic sonoma. This complete tumor excision. This is bony defect. This picture post-op day 1, and then follow after 2 months. Excellent cosmetic result, vascular sonoma. This another patient having spino-orbital cavernous meningioma involving the extraocular muscle also. Subtotal tumor excision was done. This was aim of the relieve the proptosis. We follow after 3 months, good cosmetic result. Patient received radiotherapy. Another similar patient, tumor present on the right side. You can see here there is proptosis and downward shifting of the globe. This is the post-op after follow after 3 months. The biopsy was meningioma. This patient presented with unconscious, has multiple tumor. And you see here in the cardiac nucleus, here in the left temporal lobe, in the right temporal lobe. We went for the same approach. This is the bony defect. Biopsy was lymphoma. Patient received chemotherapy and later on died after 3 months. This patient presented with headache. There is left right side temporal lobe cavernoma. This is post-operative one picture. Follow after 6 weeks. Excellent cosmetic result. Complete tumor was removed. This is a bony defect. This patient has residual right spino-orbital meningioma. You can see here. Same approach. Follow after 2 months. Tumor was removed completely. This patient, another case of operated spino-orbital meningioma 2 years back, present with proptosis, large tumor present with the cavernous sinus, infratemporal fossa. We could remove only the infratemporal fossa part. Cavernous sinus part could not be removed because tumor was very firm. Patient received radiotherapy. So we have experience of 16 cases. Graft total excision was done in 9 cases, near total in 3 cases, subtotal in 4 cases. Complications were very minimal. Lid edema in all the cases. Pseudomeningeal in 1 patient. None of our patients has any visual deterioration or any extraocular movement dysfunction. These are the various histopathologies. Meningioma was the most common, followed by schwannoma. So to conclude, the transorbital neuroendoscopic surgery offers excellent surgical result to a variety of selected skull-based lesions. However, learning curve is a limiting factor. Thank you very much. I acknowledge the help of Dr. Ravi Shankar, my neurology colleague, who has been a part of this procedures. Thank you very much.
Thank you, Dr. Jaswal. The floor is open for questions and comments. Please. Do we have any questions? Okay. So in that case, we move to our next speaker, Dr. Anil Kumar Sharma. Professor Anil Kumar Sharma from AIMS Raipur. Dr. Sharma, floor is yours.
Yeah, my screen is visible.
Yes, just please switch to presentation mode.
Yes, please.
Yes, sir.
Perfect.
Yeah, at the outset, I would like to congratulate Professor Samay, my dear friend, and John for this wonderful initiative. And I'm honored and privileged to be a part of this program in the memory of Master himself, Professor Yaşargil. So I'll talk about revisiting far lateral approach. So as we all know, like foramen magnum lesions, one of the most challenging tumors because of their distinctive location, clinical course, and tumors are large enough. By the time they present, they are large enough due to insidious course, and there is enough space to grow that tumor in the foramen magnum. And they are often large because of slow growing nature, their indolent development, and most of the time they are rare pathology that require microsurgical expertise. So there can be a variety of indications for far lateral approach. There can be schwannoma, primarily lesions which are ventrolateral and ventromedial to the foramen magnum, to the upper cervical roots and cervicomedullary junctions. These are the primary indications for the paralateral approach. That can be schwannoma, that can be aneurysm at the vertebrovascular junction. Primarily, this technique, paralateral approach, was developed for the aneurysm for the vertebrovascular junction aneurysm. There can be foramen magnum meningioma, there can be V4 aneurysm and pica aneurysm, there can be meningiomas, and there can be vascular malformations and hemangioblastomas. So I will not go into the detail of surgical anatomy of foramen magnum, as we all know all these things. These are the contents of the foramen magnum. And this is the classification system of the foramen magnum meningioma in respect to the roots and vertebral artery. So there can be variety of techniques to approach lesions to the foramen magnum. Lesions which are primarily anterior to dentate ligament and ventromedial to the cervicomedullary junctions, lower part of brainstem, lower part of cervical, that are primary indication for paralateral approach. And lesions which are posterior and posterolateral, that can be very well addressed by the standard lateral suboccipital or midline suboccipital approaches. So coming to paralateral approach, there can be incisions like there can be Leji S incision. Coming to incision part, Leji S incision or inverted hockey stick incision. I prefer to take hockey stick incision because variety of reasons. It starts from mastoid and extend by the superior nuchal line and to the midline and then up to C3 or C4, depending upon the amount of additional level of laminectomies that is required to address the extent of the tumor. So it helps in better orientation of the midline. That muscle flap that can be raised as in a single, and we don't have to dissect the individual muscles. And a small amount of cuff that can be left at the superior nuchal line for the better closure. And position is 3/4 quarter cone position, and that head is rotated in lateral flexion around 30 to 45 degree to the opposite side. That helps in better exposure. So coming to the case scenarios, this is a young male presented with quadriparesis. There is a large lesion centered at the foramen magnum, and there is displacement of the brainstem and lower part of cervicomedullary junction that can be very well seen. And the lower image, we can see how vertebral artery is within the matrix of the tumor, how vertebral artery is encased by the tumor. So these things we need to study in detail preoperatively. So these are the preoperative and these are the postoperative images. Tumor was resected completely. These are the preoperative and postoperative images. So most of the time, it's larger the lesion, it's easier to operate. And in respect to the foramen magnum, small lesions, in my opinion, small lesions are difficult to resect, but larger lesions are easier to operate upon because there is enough space to play around the tumor when lesion is large enough and the brainstem is already displaced. So in this case, as preoperative scan, vertebral artery was encased, we identified the preoperative vertebral artery. Dura has been opened, and now tumor comes into view. And we can see how lower cranial nerves are draping around the tumor. But tumor is large enough that there is enough space to play around the tumor, and cutting of dentate ligament gives the enough space to dissect around the tumor and to play around the tumor. The dentate ligament is being cut, and we can appreciate how lower cranial nerve are drapings around the tumor on the posterior surface. The sharp dissection is the key. The tumor matrix is being coagulated. The principles of microsurgery remain same for meningioma, and that decompression is being done so that dissection becomes much easier and safer, and it becomes much easier and safer to play around the tumor and to dissect around the tumor. So tumor is being decompressed with cavitor ultrasonic aspirator, and now that lower part of tumor is being dissected. The tumor further is being decompressed, and we can appreciate the vertebral artery. how tumor is encased by the vertebral artery. Now lower part of tumor is being dissected, and that lower part is tumor is removed in total. Now coming, we can see the most of the time there is fairly enough space and fairly there is plane to arachnoid plane. We can see most of the time between the tumor and the vertebral artery, but in this case, as we can see, there is no plane, and that was expected as we have seen preoperative MRI. So tumor was decompressed, and we can see opposite side of vertebral artery and pica complex, ipsilateral vertebral artery. So tumor is being decompressed here. That attachment is being, we can see opposite side vertebral artery here. And at this juncture, we thought like ICG may help, and we did utilize the intraoperative ICG video angiogram, and we can see there is no plane and tumor is incorporating the vertebral artery. So that part of tumor was resected with the help of cavitral ultrasonic aspirator. And at the end of surgery, we can see ipsilateral and bilateral contralateral vertebral artery. This is the end of surgery. And post-operative, there was no obvious residual tumor, as we can see in the follow-up MRI. Another patient who presented, 41-year-old male who presented with hemiparesis, and I'll not go into detail of this video. This is another interesting case. This patient presented with quadriparesis, and we can see that how bilateral vertebral artery are incorporated within the matrix of the tumor. So thinking that it will require bilateral, midline suboccipital is not feasible in this case, and bilateral far lateral that pose additional challenge of instability. As tumor was large on the right side, we decided to approach by the large side to decompress the tumor, and vertebral artery was incorporated intraoperatively bilaterally. So we removed this part of the tumor on the right side, far lateral approach, as that can be very well appreciated in the postoperative MRI. And some part of the tumor that was attached to the vertebral artery and could not be dissected, that was left behind. And from this side, that opposite side matrix of the tumor was coagulated, and we can see that how tumor has regressed significantly in the postoperative MRI. Patient is in follow-up. This another patient we operated recently, presented with weakness on the right side and radiating pain. So it appears like schwannoma. Tumor is large enough with severe cervicomedullary compression. This is operated by far lateral approach. We can see after the dural incision, and sharp dissection is the key again. We can see how cranial nerves are draping around the tumor, and everywhere you will see a lower cranial nerve. That sharp dissection is being done, and again cutting of dentate ligament that create enough space. And decompression is the key. First tumor has to be decompressed so that we get enough space to dissect all around the tumor. We can see ipsilateral vertebral artery. The tumor is being dissected all around. That lower part of lower pole of the tumor is being dissected. We can see the route of attachment here that is being sharply coagulated and cut. And after that decompression, it becomes easier to dissect all around. Lower part of tumor that is being dissected. And after decompression, that tumor can be removed completely. So patient did reported significant improvement, and this the postoperative, the intraoperative we could see ipsilateral and contralateral vertebral artery. And this is the postoperative CT. It shows complete removal of the tumor. So this is hypoglossal schwannoma, which is rare tumor. Tumor is extending to the hypoglossal canal. These tumors are candidate for the far lateral approach. This we can see how that there is atrophy of the ipsilateral tongue, and that is distributed to the ipsilateral side. Tumor was resected by the far lateral approach. Here we can see postoperative images. So coming to another scenario, giant purely solid hemangioblastoma in the that CP angle and cervicomedullary junction, that is very rare pathology. And in my opinion, these purely solid and large hemangioblastomas that should be treated upon on the line of the AB malformation. Only difference is presence and absence of the true capillary network. That's why these hemangioblastomas do not present with bleed often. And like we treat AB malformation, first we need to free from the feeder, then we need to dissect all around the tumor. We need to dissect all around in the plate. And at the last, like how we do in the AB malformation surgery, in the last, that draining vein that should be tackled upon. So these tumors should be treated in the same line. So these are the post-operative images. Tumor was resected completely. This is the tumor was operated by the far lateral approach. We can see the tumor, red cherry colored tumor in the cervicomedullary junction, and the intraoperative ICG video angiogram can help to identify the draining vein, the pattern of the draining vein, though may not be much helpful in the deeper located locations. The principles remain same like AV malformation. First, that feeder that should be tackled all around, tumor should be dissected, and how beautifully the draining vein is preserved till the last, that we can appreciate here. The tumor is being dissected all around from the medial part of the brainstem. I'll fast forward this video, there's lack of time. So tumor is being dissected again all around, and the draining vein is preserved till the last. Here again we can appreciate, and the tumor was removed in total. Here we see video, ICG video angiogram that can help in identify the pattern. So this we published in the literature without preoperative embolization. So coming to another case scenarios, vertebrovascular junction aneurysm that can be candidate for this far lateral approach. This patient was presented with bedbound, severe ataxia and quadriparesis. There is severe compression we can see, and this large partially thrombosed aneurysm which was operated upon by far lateral approach. So here the intraoperative view we can see called bilateral vertebral artery, vascular artery, and the aneurysm, one lower cranial nerve, and cemented complex. So we can see after dissection, after opening of the dura, again sharp dissection is being done. Vertebral arteries, ipsilateral, contralateral vertebral arteries are identified, and in particularly in the giant aneurysm, we should avoid that temptation to dissect and remove that capsule completely, because there will be a lot of adherent perforators, and that can lead to catastrophe. We try to remove that capsule completely. So it's better to decompress, and like we operate upon tumor. So here that aneurysm is being decompressed with the cavital ultrasonic aspirator, and after that temporary clip and permanent clip is being applied. This patient had difficult postoperative course, as there was severe deficit preoperatively, but we could discharge this patient with the tracheostomy. This is the postoperative CT angiogram showing no residual aneurysm. So coming to another scenario, V4 segment aneurysm that can be another candidate for the far lateral approach. Here this patient presented with bleed, and dentate ligament is being cut, and we can identify the vertebral artery, and now aneurysm is seen, and that is neck is being dissected, and that clip is being applied. So these are another indication for the far lateral approach. So this is another vertebral artery and this pica junction aneurysm that can be another indication. We can see reformatted CT images. So most of the time that condylar dissection, resection that is not required, and a larger the tumor, it's easier to operate. And if required, that posterior medial part that can be resected. So these are challenging tumors due to vicinity of the brainstem and multiple multiple vascular. Am I audible?
Yes, you are audible now.
Yeah. So these are challenging tumors because due to vicinity of the brain stem, vertebral artery, and lower cranial nerve, and these are one of the most difficult and challenging tumors to operate upon. And that we need to identify the specific indications at tumors and lesions which are anterior to dentate ligament and ventromedial that are ideal candidate for these kind of lesion. And tumor which are posterior to dentate ligament and situated posterolaterally, that can be very well tackled with the standard midline suboccipital or lateral suboccipital approaches. And drilling of that for a lateral wall that is required during the approach should be limited, and we should not create the instability. And if required, that posterior medial part can be resected. Particularly, again, I am stressing that point. Particularly when the tumor is small, then drilling may be required. But if tumor is large enough, drilling is often unnecessary and not required. And this is a versatile approach for the tumor situated anterolateral to the lower brainstem and upper cervical roots. And post-operative complications can be dramatic and should be anticipated. Thank you. Thank you very much.
Thank you, Dr. Sharma, for excellent talk. Do we have any questions for Dr. Sharma? Okay, Dr. Ani, my question regarding preoperative embolization at this region in selective situations. You already mentioned that your series is without preoperative embolizations, but do you consider it in any situation?
No, we do consider, we do that paper, that article was specific to him in respect to hemangioblastomas, giant and solid hemangioblastomas. So what we often see that these tumors often share the common vascular supply. Some part is supplying to brain, and that feeders are often small, and it become very difficult to negotiate, particularly in supply anterior, and that posterior fossa is very crowded space, means less accommodative. Suppose if after embolization that small feeder there is some edema or some infarct, that become very difficult to accommodate that. And so most of the time in giant hemangioblastomas, I find often unnecessary to do preoperative embolization because it carries its own risk and variety of region, sharing of common vascular supply, less space, and all these factors that we should take into consideration. But we do preoperative angiogram, and particularly in giant and solid hemangioblastomas. As I mentioned, like these tumors should be treated on the line of the AV malformation.
Okay, while dealing before, especially if pica and anterior spinal artery is not involved, seemingly the endovascular approach is less invasive and putting just a cardiac stent work in those cases. So how you justify the risk by this paralateral approach in those situations, or would you just stick to endovascular option for those cases?
No, we do give option. So like we always for that whenever it's possible, we always give option, but a variety of factors comes into play. Like we need to see patient preference and that financial status also. So all those factors comes into play.
Okay.
But we combinedly we decide all these kind of things.
Thank you. So we are running short of time. Now can I invite Dr. Ranjesh Kachhara, who's going to discuss microsurgical clipping techniques for ophthalmic segment aneurysms. Dr. Kachhara.
Did you see my screen, please?
Yes, but not in, please switch to presentation mode.
Is it okay now?
It's still not in presentation mode. Can you please switch it?
I am seeing it in presentation mode.
Okay, then please close and reopen it again.
Okay.
pros and cons and alternatives of the proposed procedure in the plan of care with the patient significant other below that. We understand to the 50% of the time.
Is it okay?
Not yet.
No. So,
Yes, that's fine.
is it okay now?
Yes, that's fine. You can see it now.
Okay, so at the outset, I must thank Professor Same for arranging such a wonderful meeting in the memory of Professor Yasergil, connecting the neurosurgeon from all over the world and presenting their scientific deliberations. So my talk is on the ophthalmic segment aneurysms and microsurgical clipping techniques. I had an instance to meet Professor Yasergil. This is in 2002 at the ACS meeting. We had some light moments and he was honored guest there. And he's my friend and we had some talk with him. So before I start my talk, I would show this article from the Yasergil, which is published in Surgical Neurology in 1997. And he has presented 30 cases of aneurysm in this region with no motility. So with this article, I will just go and present my series, my talk on this subject. So the ophthalmic segment is a C6 segment, which is between the origin of ophthalmic artery and the origin of precommon artery. And it is such a very important segment with a lot of important, very important structures, segments of the ICA, branches. There are some other nerves, supraorbital fissure. Apart from that, the bony anatomy here, which doesn't permit you freely access in this region. So the aneurysm which arise from this segment, which is the largest subarachnoid segment, are called the ophthalmic segment aneurysm. These aneurysms are very important. They are difficult aneurysms and complex anatomy around. And you need a very dissection skills. And giant aneurysms, multiple aneurysms, and mirror aneurysms are known in this location. So one has to be very critically evaluate the aneurysm angiogram preoperatively. We have to be assessed in detail. And the microsurgical clipping remains a very durable treatment method to treat these lesions and which allows good optic nerve decompression. So this is the anatomy of this region, and you can see this is the distal dural ring, and this is proximal dural ring. So, and this is origin of the ophthalmic artery, and this is in relation to this proximal part, and this is the ophthalmic segment. And as you see here, and these are the various reasons for the formation of aneurysm in this location. Usually origin of the branch, curve, and the flow direction. So major three types of aneurysms are seen in this location are the ophthalmic artery, which arise in relation to the ophthalmic artery and they project dorsally or dorsal-medially. Another in location to the branch, superior hypophyseal branch, and they project medially. And third one is the dorsal variant. But usually we have found that we have broadly divided into dorsal wall aneurysms and the ventral wall. It can be proximal or it can be distal. Distal proximal dorsal wall or distal dorsal wall, or proximal ventral wall, or proximal distal ventral wall. So these are the most common aneurysms which arise in this location. Coming to the treatment and the key steps to tackle these aneurysms, first and foremost is the proximal control of the neck, of the IC in the neck. We always take. And we use microsurgical cranial-based techniques, wide splitting of the cilium fissure. And another important aspect which helps in the visualizing the segment of the IC. Sometimes these aneurysms can remain hidden under the clinoid process. So the most important step is the drilling of the anticlinoid process, optic canal urethane, and the removal of the optic strut, which helps in the exposure of the proximal segment of the IC. Then there are some agents to treat these aneurysms like retrograde suction decompression, or the locally we can trap the segment and then aspirate and decompress the sac, and then we clip this aneurysms. And regarding the clinoid drilling, already we have seen so many talks on that. It can be drilled extradurally or it can be drilled intradurally. And once you drill the clinoid process and cut this optic nerve sheath and retract the little bit of this optic nerve, and you can see the whole segment, you can see the ophthalmic artery, and whether aneurysm projecting dorsally or ventrally, you can access these lesions. So regarding the clipping techniques, all these depends on the size of the aneurysms, its projection, whether it is projecting dorsally or dorsomedially or ventral or ventromedially, and the configuration, whether it's a multi-lobe, thick-walled, post-coiled aneurysms, how much the IC involved in the particularly bigger size aneurysms, and its relation with the optic nerve. But by far, we use the clips in direction or in the parallel with the artery. So these are the various clipping techniques. A simple aneurysm can be clipped with a very small curved clip, or sometimes it can be a tendon clipping when aneurysm projecting on the inferior or ventral wall is usually the fenestrated right angle fenestrated clip, which can take the artery, normal artery, into the fenestration, and you can clip this. You can apply sometimes multiple clips. How this, so coming to some examples, this is presented with the subarachnoid hemorrhage, and you can see the aneurysm arising from the dorsal wall and projecting dorsomedial. A small clip I will show. We use the usual trigonal craniotomy, and the sphenoid wing is aggressively drilled to make the base to the flat and the wide opening of the cilium fissure and the microsurgery resection. As I mentioned, the clinoid can be drilled extradurally or intradurally. So in this case, we have after the dissection, we have drilled the clinoid process intradurally. So that's how we just incise the dura over the clinoid process, including the part of the dura which is covering the optic canal. We cover this whole area with the glove rubber to protect the surrounding brain. And that's how the clinoid process is drilled. And the tip of the clinoid is removed. Once this is removed, you can cut the distal dural ring and you can open the optic nerve sheath. Which gives mobility of the optic nerve, and we can slightest amount we can drill it, we can mobilize it, and that's how we just dissected the neck of the aneurysm and a small fenestrated clip, not the small bayonet-shaped clip is good enough to control the neck, and you can see the sac has become white after the clipping of the head. Coming to the another, this is the lady, 75-year-old lady. She has presented with the 3 times with subarachnoid hemorrhage. And this is the aneurysm which arising from the ventral wall, ventromedial wall projecting medially. And this is a small video clip after the exposure, drilling the clinoid, and this is the optic nerve, carotid artery. We have used this largest clip, curved clip, Yasergil clip, to take the, just went under the ICA and it is just over the tip of the fitting, the bone there. So completely taking the aneurysm neck in the clip. And it is just taking the curve of the ICA also very well. And this is completely excluded from the circulation. And this is the possibility to check DSA, which shows the complete exclusion of the aneurysm from the circulation. And she did very well without any possible deficits. Coming to another, this lady, young lady, she has presented after a month from subarachnoid hemorrhage, and this is the aneurysm which is arising from the again medial wall and projecting the medially and superiorly. And this is on the left side. We have drilled the clinoid extradurally here. And part of the last part of the clinoid was drilled intradurally. And this optic strut, sometimes this is the bone CUSA, and this is very good tool to drill this optic strut, which produces very minimal amount of the vibration. Cutting the distributor ring and optic nerve sheath. You can see this is the distal ring and this is the ICA. The aneurysm is projecting medially and superiorly, being dissected from the optic nerve. The neck is very nicely defined. This is the segment of the ICA and this is the aneurysm neck. Free from all around. Proximally also, we have just passed the sector, and this is a small curved clip which is being applied. Just to be more secure, I have placed another clip just to boost this clip distally. We usually put this gadgets on the side and surgical at the end. Some muscle also. I usually close this clinoid dura at the end. So it prevents, and this is the postoperative CT angiography, shows complete exclusion of the aneurysm from the circulation. There's another aneurysm which is again projecting medially, and this was clipped with the different clipping technique. So here I initially tried, this is ventral wall projecting. Initially I tried a right angle fenestrated clip, but there was some small plaque here which was not allowing clip to close. Then I changed the strategy. I just put multiple straight fenestrated clip, avoiding this plaque which is at the neck of the aneurysm. And this is how this aneurysm is completely occluded and excluded from the circulation. This another joint aneurysm which was clipped earlier, and this is the postoperative check DSA which shows complete exclusion of this aneurysm. This was the only aneurysm in our series had a who presented with the unblared aneurysm, but patient presented with the visual disturbances, and this aneurysm was clipped and optic nerve were decompressed. So in total, we had operated 45 aneurysms, and there were equal number of from the dorsal wall and ventral wall, and mostly aneurysms were small. There were 2 joint aneurysms. We used clipping techniques in 38 patients. These were our share of complication. We had 3 mortalities. After that, 2 was grade 4 and 5 patients. We could publish our series of 40 aneurysms in this journal as an original article. So, in conclusion, the ophthalmic segment aneurysms are challenging aneurysms due to the complex neurovascular anatomy in this location, and the microsurgical treatment of ophthalmic segment aneurysm is still the most definitive and has got a very high efficacy. The key steps for successfully clipping these aneurysms are we have to have a very good proximal control. We usually take in the neck. Optimally, we have to drill the anti-clamp process to expose the proximal neck to the aneurysm, and we have to successfully obliterate the minimal manipulation of the optic nerve to get the best outcome from surgical treatment. Thank you very much. Thanks a lot for the kind attention.
Thank you, Dr. Rajneesh, for an excellent presentation. House is open for questions. Okay, can I ask Dr. Rajneesh?
Sure.
We live in the era of endovascular with very soft balloons. So having a proximal control with a soft balloon in a hybrid theater would save many risky maneuvers. What's your take on this?
Yeah, it can be tried, but we don't have that good facility with us. So we always take proximal control in the neck. And while dissecting the aneurysm, we intermittently occlude this and dissect, and while clipping, we have proper control. So that is a valid thing which can be used with a balloon in the artery.
Thank you.
Yeah.
Thank you so much. So this makes us to our next presentation. We invite Professor Anand Malhotra.
Yeah,
Thank you
hello.
very much.
Yeah. Can I share my screen now?
Sure. Professor Anand Malhotra is going to talk about supraorbital keyhole approaches for anterior skull base lesions. Over to you.
Perfect.
Yeah, thank you.
Okay.
Good evening, everyone. So, as you all know that Professor Yaşargil is teachers of teacher, and his students who later on went on to become teachers themselves, through them, little bit of Professor Yaşargil is living in every neurosurgeon of the current generation. The famous American novelist Thornton Wilder once said that the highest tribute to the dead is not in grief, but in gratitude. And I am sure every person who is participating or is a part of this webinar is expressing his gratitude to the legend in his or her own way. And I shall be doing the same by presenting a small talk on supraorbital keyhole approach. Now, as Turel approach, we all know is a gold standard approach for the anterior skull-based pathologies, but minimally invasive approaches have of late developed as a good alternative. And among them, the most commonly used approach is the supraorbital keyhole approach. Now, the advantages of any minimally invasive surgery are like small incision, small size of the craniotomy, and therefore less brain exposure, less operative time, and perhaps there is a reduced length of stay. Now, various pathologies of the anterior skull base can be dealt by supraorbital keyhole approach, and among them, we shall take them one by one. Let us talk about the aneurysms first. Now, whether aneurysm surgery should be done through the supraorbital keyhole approach is debatable. There are certain concerns, like what about intraoperative rupture, whether we can completely obliterate the aneurysm, whether the outcome is similar to that of the Turel approach or not. And definitely there is a concern that the parental sinus exposure is there, that can lead to meningitis and encephalitis later on. So intraoperative rupture is controversial. However, there are various studies which show that there is no increase in the intraoperative rupture as compared to the conventional Turel approach. And not only that, even if there's an intraoperative rupture, there is no increased difficulty in controlling the intraoperative rupture as far as the SOCA approach is concerned, and there is hardly any conversion of supraorbital keyhole approach due to intraoperative rupture into the open technique. Definitely, it is also important to understand that whether the aneurysm is ruptured or unruptured aneurysm and what is the location of the aneurysm. So the question is that how do you choose that which aneurysm can be tackled through SOCA and which aneurysm should be dealt by the Turel approach or the conventional approach? So the anterior circulation aneurysms are definitely slightly better to be approached to supraorbital keyhole approach as compared to the posterior circulation aneurysm. Even MC aneurysms can also be operated through the SOCA approach, provided the M1 segment is relatively small, it is about less than 15 millimeter or so. Unruptured aneurysms, medium-sized, small to medium-sized aneurysms can be tackled through supraorbital keyhole approach. Complex aneurysms like giant aneurysms, aneurysms with multiple feeders, aneurysms with multiple clipping has to be used, in which bypass has to be planned. It is always preferable to use a proper conventional approach. Apart from that, if the patient has a good Huntington's grade, in our center, we commonly use the Huntington's grade, and only Huntington's grade 1 and 2 we operate through the supraorbital keyhole approach. Higher grade aneurysms, we usually don't prefer through the supraorbital keyhole approach. If the patient has hydrocephalus, you can use an EVD, but it is always prudent to use the conventional approach. If there's a large hematoma or if this frontal sinus is relatively large, then it is prudent to use the conventional approach. I shall just be discussing a few cases. So this is a case of 55-year-old female patient who presented to us with the subarachnoid hemorrhage. You can see the CT scan in which there is blood, and you can see the aneurysm just at the IC bifurcation. So here is the skin incision. You can give the incision either through the brow or just supra-brow. The keyhole burhole is made and the craniotomy is done. The size of the craniotomy is conventionally about 2.5 to 2.5 centimeter. It can vary from 2.5 to 3 centimeters in horizontal and vertical dimensions. So as you can see here, the craniotomy is about 3 into 2 centimeter in size. You open to do that, but perhaps one of the most important steps is proper release of the CSF, so that the brain can become lax and the brain can fall away from the bone, and then you can proceed further. So you should release the CSF. Don't release the complete CSF because you might find it slightly more difficult to open the sylvian fissure. Once a significant amount of CSF has been drained, then you can actually shift your focus to the sylvian fissure. You need not open the entire sylvian fissure from distal most to the proximal most. You can use only the proximal part of the sylvian fissure to be opened, and that is usually more than sufficient. So here we are doing the sylvian fissure opening, and arachnoidal dissection is being done. Now, arachnoidal dissection is very, very important, as was discussed in length by Professor Yaşargil. It actually helps us in two ways. It actually detethers the neurovascular structures and therefore reduces the injury to the neurovascular structures. Secondly, the CSF pockets, they open up when you open up the arachnoid, when you do the arachnoidal dissection, and because of which you can actually have further CSF release, and that can actually make the brain lax, and a further surgery becomes slightly more easier. So here you can see the arachnoid band is tethering the ICA to the frontal and the temporal lobe, so detethering is required. With taking the temporary clip, you can see the ICA, the IC bifurcation, and there's a small perforator which is attaching to the dome of the aneurysm. Every single perforator is extremely important, and it's very important that all these perforators are dissected off the aneurysm so that none of these perforators come into the clip. Otherwise, patient can actually have devastating complications. So here we have defined the aneurysm. You can see the anterior carotid artery also. You can see the anterior carotid artery now. Now we are doing the ICG, and you can appreciate the IC bifurcation and the aneurysm. for the want of time, this clipping is, so you see, we are applying a right angle clip. The important thing, as I had mentioned earlier, is to save the perforator so that the perforator does not come into the prongs of the clip. Otherwise, patient can have serious complications. So here you can see that the perforator is off the clip. Sorry. I'm doing the ICG, in which you can see the non-virtualization of the aneurysm as well as the patency of the perforator. So this is another case of a medium-sized ACOM artery aneurysm. We routinely go to the CT angio suite and we try to make the craniotomy on the dummy craniotomy so that we know where the exact craniotomy has to be made and what should be the dimensions of the aneurysm, sorry, of the craniotomy, so that the aneurysm can be properly visualized. This actually helps us in the intraoperative period. Now, in this case, the craniotomy has been done, the ciliary fissure has been opened, and we are working at the aneurysm. You can see the medium-sized ACOM artery aneurysm out here. This is, we are lifting the ipsilateral A2 and trying to find out the contralateral A2. We're trying to delineate the contralateral A2. Now, the contralateral A2 is visualized here. Both the A1s are on the left side of the screen. When we do the ICG, you can see both the A1s. Now, this is the A2 and trying to find out the contralateral A2. And here we are trying to see the contralateral A2, and now you have visualized the A2. Now we know all the 4 vessels, we know the plane of these vessels, and just we can apply these clip just above the plane of the vessel so that all the 4 vessels are preserved. And we are applying the clip. This is, I think, a 7 mm straight clip is being applied. Release the clip extremely gently. Otherwise, it can always be in an inadvertent rupture. So now we are seeing the tortuosity of the contralateral A2. And you can see both the A1s on the left side. And now we are seeing the ICG. So you can see all the 4 vessels, that both the A1s, the A2, and the contralateral A2. And you can see the non-visualization of the aneurysm out here. So we are now visualizing contralateral A2. So this is the size of the craniotomy. Craniotomy is about 3 into 1.5 centimeter in size. This is a case of an MCA aneurysm. So here you can see that multiple clips can also be applied at MCA aneurysm by using the SOCA technique. This is the image on the left is the immediate post-op, about I think 6 or 7 days after the surgery, and the image on the right side is about 3 weeks after the surgery. Coming to the meningiomas, NTS Culvis meningiomas like the tuberculum cellae, the plenum sphenoidal, and olfactory groove meningiomas can be well tackled by the supraorbital keyhole approach. Whether you want to go endoscopic or use the SOCA is controversial. There are certain centers which prefer endoscopic. There are certain centers which prefer the supraorbital keyhole approach. So here this is a case of tuberculum cellae meningioma. As you can see the coronal contrast, the T2 SAG, and the contrast CT scan. So the craniotomy has been done. It's a short video. So the basic principle of the meningioma surgery and the microsurgery remains the same. You have to devascularize the tumor, you have to debulk, you have to dissect off the tumor. That remains the same. So we are devascularizing the tumor, and now we are cutting the attachment of the tumor. Now, in a tuberculum cellae meningioma, there are 3 structures which have to be preserved: the optic nerve and the chiasma, and the ACA ACOM complex, and the pituitary stalk as well. At many places, the chiasma or the optic nerve might actually be slightly adherent to the tumor, so one has to be very cautious and one has to be very careful while dissecting off the tumor from the optic nerve and the optic chiasma. So it is always prudent to debug the tumor. That actually gives you plane. Sometimes if the tumor is soft, actually the tumor tends to fall into the cavity, and that can further help you in the dissecting of the tumor. But the tumor is firm, it does not fall off, so you have to properly dissect off from the neovascular structures. So here you're seeing we are dissecting the tumor of the optic chiasma. And once you dissect off the tumor from the optic nerve and the optic chiasma, and we're targeting the tumor from the attachment, so that actually that devascularizes the tumor and also helps the mobilization of the tumor. And you can see the pituitary stalk just below it. And here is the pituitary stalk. The pituitary stalk should also be preserved in NTS Culvis meningiomas. Some part of the tumor, as I mentioned earlier, is adhered to the optic chiasma and the optic nerve complex. So that should be, using by both blunt and sharp dissection, should be dissected off the complex. And once you dissect the tumor off from the optic chiasma and the optic nerve complex, then you can visualize the ACA ACOM complex in the tuberculum cellae meningioma. So here you can see the ACOM complex. It is very important that you do very sharp dissection in such cases, because even a small perforator which is avulsed from the ACA can actually lead to significant amount of bleeding and can actually lead to spasm of the ACA at a later date. So this is the postoperative MRI. You can see complete excision of the tumor. This is a moderate size olfactory groove meningioma. You can see the incision that we plan out here and the complete excision of the tumor. And you can see the craniotomy on the CT scan. Craniomeningioma is a less common indication, but can be operated through SOCA. But then these tumors, craniomeningiomas are cystic tumors and have a good subfrontal extension. Then craniomeningioma can be tackled through SOCA approach. Otherwise, chiasm actually offers a roadblock. So preferentially, you should come more laterally to a renal approach. This is a child with a solid cystic craniomeningioma. So you can see the optic nerve and the ICA. We're just trying to open up the capsule of the craniomeningioma and debulk the craniomeningioma. If it is pure cystic craniomeningioma, that actually once you open the wall of the craniomeningioma, that large amount of fluid can be drained out, and the capsule actually tends to fall away from the vascular structures, neurovascular structures. In craniomeningioma, you have to use all the corridors. Initially, you were in the working in the intraoptic space, and now you're working in the carotid-co-optic space. And once you debulk the tumor, then you have to work even later to the IC and the keratoco-oculomotor space, and now you're working in the keratoco-oculomotor space. Once you debulk the tumor, as I mentioned earlier, tends to fall away from the vascular structures and the neural structures. And here you can see once we decompress the tumor can easily be separated from the arachnoid of the third nerve. As you can see, we're just peeling off the arachnoid from the third nerve, and the tumor is being pushed towards the IC away from the third nerve. It is always better to actually bring the tumor towards the largest cisternal space. In this case, it was the entire optic space. So we're just trying to move the tumor from the keratoco-oculomotor and the keratoco-optic cistern into the intraoptic cistern. Sometimes the largest cistern might be the keratoco-optic cistern, in which case you should be using that. Once you move the tumor, then you can actually do a piecemeal dissection of the tumor, cut the capsule, remove a part of it, and then you can actually debulk the tumor and proceed on the same lines. So once you cut the last part of the tumor, even small remnant of the tumor can be left attached to the optic nerve on the ICA. Usually they have a good outcome as far as the long-term outcome is concerned. So this you can see is the complete excision of the tumor and the craniotomy. This is another case of cystic craniomeningioma. You can see the postoperative CT on the right side. Other pathologies like epidermoids, gliomas, and even cavanomas of the frontal pole can be operated through the SOCA approach. No surgery is without complication. SOCA has its own set of complications. They can be CSF collection or rhinorrhea in about 3 to 4% of patients. Patient can have supraorbital hypoesthesia in about 4 to 5% of patients, but permanent hypoesthesia is seen only in about 1 to 1.5% of patients. They can be passive the frontal matter of the facial nerve and seen about in 3% of patients, and in permanent paralysis can occur in about 1% of patients, but it's less common. And then patients can have wound-related complications. So to conclude, SOCA is a good alternative to the renal approach, but the patient selection is extremely important. But I think what is more important that the person should have, the neurosurgeon should have proper experience in conventional approach, then only they should shift on to the minimally invasive approach. This was my humble tribute to the legend, and I would end with a Hebrew proverb which said that they're not in grief that he is no more, but in thankfulness that he was. So I thank Professor Yaşargil for being there and creating so much of literature for the neurosurgeons. Thank you so much.
Thank you, Dr. Mehrota. Any question for Dr. Mehrota? Okay. If that's the case, then we invite Professor Suresh Dugan. Professor Suresh Dugani is one of the famous and most prominent Indian neurosurgeon with extensive experience in microsurgery and endoscopic surgery. So, Professor Suresh Dugani.
Thank you.
Thank you.
Thank you, Professor Atta. Indeed, it's a pleasure and honor. At the outset, I like to thank. Can you see this? Can you see the screen?
Yes, but not in presentation mode yet.
Can you see the screen?
Yes.
Yeah. Now I'll make it presentation mode.
Please.
Can you see it? Yes.
Thank you.
At the outset, I thank Professors, my dear friends Sameh and John Bennett for the excellent opportunity during this excellent scientific platform, sharing and learning from each other, and a tribute to our great master, the father of modern microneurosurgery, Professor Yaşargil. So I'll take you through few of our work and experience in the management of skull-base lesions through ciliary fissure, highway to skull base, and my journey over 35 years treating many cases. I bring greetings from India, South India. Professor Yasergil, for the first time in 1960s, he called the sylvian fissure as a highway to the skull base. And even after about 60 years, we follow the same pathway in treating these many lesions. I'll just take you through how it is done. As you know, the sylvian fissure is a CSF-filled arachnoid space and lateral part of the brain, connects surface of the brain to deep part of the brain and skull base. Opening this space gives wide, safe access to the deeper vital neurovascular structures and pathologies and helps in comprehensive management of anterior, mid, and posterior skull base various pathologies. On the surface, it is located like this. All of us know, every day we see this. It is divided by him into 3 compartments: superficial, opercular compartment, which faces us during the surgery, deep opercular compartment, third cisternal compartment are the 3 parts of this place. I'll not go into the details. Anatomy is always available, but make you aware of the things. It contains very important structures: arteries, middle cerebral artery, lateral lenticulostriates, veins, middle cerebral vein, superficial and deep. One must know the venous anatomy along with the arterial anatomy in the sylvian fissure because it is most important along with the artery, the venous anatomy. Again, I'll not go into the detail before we start treating these lesions. Apart from that, we have arachnoidal strands binding artery to artery, artery to brain, artery to veins, brain to brain, and vein to brain. These are the adhesions each one of us see when we split the sylvian fissure, and we need to cut these and open the sylvian fissure deep and wide. Professor Yaşargil gave 4 types of this space, sylvian fissure. Until today, after 60 years, we follow the one. The first one is wide and straight. Second one, type 2, is wide and angled. Type 3, narrow and angled. And type 4, where the both temporal and frontal horns, they herniate and the track is quite narrow. For us as neurosurgeons, the first and type 1 and type 2 are great help, and we call them as friends of neurosurgeons. Type 3 and type 4, as time goes, we learn and we keep dissecting many sylvian fissures. We keep learning from there and how to open this. The surgical approach, majority of the time, all these skull-base lesions we have heard just now, frontotemporal T-renal craniotomy, again given by Professor Yasergil for the first time, until today it is a workhorse for the anterior, mid, and posterior anterior skull base. Fronto-orbital hermetic craniotomy. We have various craniotomies available to us, mini, micro, small, and larger ones. But my advice to the younger generation is to select the procedure of the craniotomy which you are comfortable with and which is safe for the patient. Just because somebody does a small mini craniotomy and excise the lesion, don't do that unless you master the technique and you're very comfortable and you create justice and no harm to the patient. Opening the sylvian fissure, as Professor Yasergil gave to us, majority of the cases, we open them lateral to medial, except in middle cerebral artery aneurysms, we open medial to lateral. As I mentioned to you earlier, starting from lateral, you see the strands there, arachnoidal strands, open the arachnoidal space, just opening of the arachnoidal space, always done under terms, keratico-optic, suprasellar, medial ones by accessing this route. Next, once you do this, now this is exactly what you see once you open the sylvian fissure. You can go any direction you wish, anterior, posterior, lateral, inferior, superior, and you can have many corridors available to us: intraoptic corridor, keratico-optic corridor, retrocarotid corridor, and through the lamina terminalis, we can access any pathology in the base of the skull. The structures which we access by traveling this pathway is anterior and mid skull base, posterior skull base lesions, neural, frontal, temporal, and parietal lobes on the surface, vascular, anterior circulation of Willis, pituitary gland, cavernous sinus, cranial nerves 1 to 6, hypothalamus, and upper brain stem, that's a midbrain up to the upper bounds, are the various structures we can access. My journey traveling through this highway in last 33 years, we have crossed nearing about 4,000 cases. I'll share with you how it helps us and what we can do. What are the lesions we go through? Vascular, congenital, vascular, neoplastic infection, and traumatic aneurysms, aviums, meningiomas, craniopharyngiomas, schwannomas, optic neurobliomas, pathway gliomas, pituitary adenomas, cavernous sinus meningiomas, cavernous angiomas, midbrain thalamic, hypothalamic gliomas, deep brain gliomas, suprasellar dermoids, epidermoids, temporal lobe epilepsies are the various common pathologies which we can access during traveling this pathway. A giant aneurysm, ICA, which presented with the visual involvement. You can see the circle of Willis taking origin from the aneurysm itself, the dilatation. We planned for first STA-MCA bypass. First STA-MCA bypass and expose the internal carotid artery as a proximal control, and yes, then the Sylvian fissure was opened. Then you can see the exposure of the Sylvian fissure, exposure of the neck. Once that is done, put a clamp in the internal carotid artery, aneurysm reduces in size. Now dissect the ICA, distal ICA originating from the aneurysm complex itself, and proximal to the origin of the PCOM, we need to apply the clip, and completely the aneurysm is taken away from the circulation. You can see the well-maintained distal circulation due to bypass, and in spite of that, he had hemiparesis, but recovered subsequently, and he's doing very well. The preservation of posterior communicating artery in cases of where the aneurysm, the PCOM originate from the neck of the aneurysm is again greatly done with the wide opening of Sylvian fissure. You can see the vessel originating from the neck of the aneurysm. The aneurysm is isolated, proximal and distal clipping. Now the long clip is applied on the neck, and again a small distal clip is applied, and now the proximal clip which we had used to apply that opens up the PCOM, and the whole aneurysm is obliterated. Preservation of the PCOM post-operatively patient with no neurological deficits. This is what we can achieve by opening this. Under large fusiform dilatation or the blister aneurysm of the ICA, a large blister you can see there, and presenting with the visual complaints. Now the whole the ICA is exposed, and the fenestrated ring fenestrated clip is applied. Now you can see so nicely after deep and wide opening, still part of the neck is left there. Take one more fenestrated clip, obliterate it, and proximally again there is a part of the neck which is left there. Again, take one more straight fenestrated clip. So in fact, we are reconstructing the internal carotid artery and excluding the dilatation from the circulation, and that's a patient post-operatively, and you can see complete obliteration or taking away the aneurysm from the circulation. Another large ACOM complex where the aneurysm is dilated, the ACOM is dilated as an aneurysm. We use a clip reconstruction technique for as given by Professor Professor Seno, and the clip is modified according to the need, and the tip is drilled and made small, and the aneurysm is obliterated, and the aneurysm complex is covered with the wrapped with the muscle. This lady had again the middle cerebral artery aneurysm from medial to lateral, open the Sylvian fissure at the same surgery, and the MCA aneurysm, the bifurcation aneurysm, is also obliterated completely at the same sitting. And that is the Sylvian fissure. All the vessels in the Sylvian fissure well preserved. You can see the perforators, lateral lenticulostriates, and this is the postoperative ICG flow 800, well preserved circulation. And that is the patient postoperatively with no neurological deficits. On day 5, she goes paraclinoid hemorrhage, that's temporal hematoma, access through opening of the Sylvian fissure from medial to lateral. Here, always we advise and we prefer to open the Sylvian fissure from medial to lateral in MCA aneurysms to avoid during the dissection. We should not create the pre-clipping rupture. The clip is applied and you can see the hematoma there on the temporal lobe is evacuated. Again, we prefer to evacuate the hematoma after clipping the aneurysm in majority of the cases, and this is what the patient postoperatively with no neurological deficits. Now coming to the arteriovenous malformations, medial temporal AVM, this lady presented with a hematoma and a speech abnormality. And this is the angiogram showing a Spessler-Martin grade 3 AVM malformation, medial part of the temporal lobe, accessed through the Sylvian fissure, opening preservation of the perforator, and that's a patient postoperatively, no neurological deficits. Sylvian fissure, medial temporal large cavernous angioma with the bleed. You can see the navigation guided access to the lesion, the frontotemporal craniotomy, that's the location of the angioma on the surface, opening of the Sylvian fissure, and medial temporal lobe is open, and you can see the clot there, and large the cavity of the angioma with the blood. Gently it is dissected, and always keep the lateral lenticulostriates in mind before we obliterate the angioma. That's a patient postoperatively with no neurological deficits. Now we have deep brain gliomas. We are called upon to treat gangliocapsular glioma in a young girl like this. You can see that she came with a tumor with a bleed situated in the anterior part of the gangliocapsular region, accessed through the Sylvian fissure, and the lesion is gone to the anterior part of the temporal lobe, and you can see the blood clot there due to the hemorrhage in the tumor with the hemiparesis and high magnification. The hematoma is evacuated and glioma is taken out completely. You can see the postoperative scan, complete removal of the lesion, and this is the intraoperative end stage of surgery. That's a patient postoperatively, hemiparesis improved, upper limb power is improved. Now she's going to the college and doing well. It was grade 2 astrocytoma. Sometimes we need to treat midbrain thalamic gliomas by this approach. A young boy, you can see the glioma coming down, the crest of the mid-cerebral peduncle on the left side, and you can see the lesion going up into the thalamus and extending upwards. DTI is of great help in this to locate the corticospinal fibers and the extent of the lesion and the fibers disposition in relation to the lesion. Again, navigation is planned to have the access to this, and you can see through the Sylvian fissure, we can access it very well. That's the best way without going through the left side, the temporal lobe. Sylvian fissure is open as is done here, deep and wide. Go posteriorly, you can see the bulge there coming into part is taken out from the midbrain, and you see the third nerve there medially. That is the boundary where the tumor is medially extending. Once that is done, go superiorly and the medial part of the temporal lobe, and gently the capsule is accessed and the glioma is brought down. You can see the complete anatomy, third nerve and ICA and other branches. We bring the endoscope and see the completeness of the excision. Endoscope is of great help in this. This is the patient postoperative pilocytic astrocytoma grade 1, and he is doing very well. They can see the postoperative scan, complete excision of the lesion. The scan looks as if it's a normal scan. Nothing has been done. Skull-based tumors, giant pituitary adenomas, where we need to access them transcranially. You can see the multi-compartmental pituitary adenoma. Again, through the Transcallosal approach, we have done a dural aneurysm and silus, as I showed you earlier, interoptic corridor, keratico-optic corridor, retrokeratic corridor, and cavernous sinus can be easily accessed. Lesion can be decompressed completely, and you bring in the endoscope and see how much you have excised and see the well-preserved vision. Share a third nerve before surgery, and subsequently it recovered. Craniopharyngiomas, you saw just now, very nicely mentioned. Again, through this approach, Transcallosal, we prefer to do it. Dissection from the circle of Willis, perforator preservation, and pituitary stalk preservation, we can try in many cases. Larger lesion here, multiple corridors. First is interoptic corridor, keratico-optic corridor, debulk the lesion, bring it down superior part, and you can take out the lesion completely. And you see the in between the carotid artery and the optic nerve opposite side, and the whole lesion is excised completely. And that's a post-operative scan showing the well-preserved pituitary stalk in this. In almost about 30 to 40% of the craniopharyngiomas, the microsurgical dissection, preservation of circle of Willis, where the tumor is big and engulfs or encases the circle of Willis. Again, by opening the Sylvian fissure, Transcallosal, you can comfortably preserve the branches of the circle of Willis and excise the lesion. This was the third surgery for earlier. Twice it was done at a different place, and we could do it completely. Subsequently subjected for radiation, and she is doing very well. Again, sometimes we need to treat these lesions prefixed chiasm, the keratico-optic corridor, retrokeratic corridor or space, decompress the lesion. Superior part of the lesion, sometimes we need to go through the perforators. You can see the separation through the perforators, and separate the perforators under high illumination and magnification. Lesion can be excised completely. That's a scan. Post-operatively, you can see the complete removal of the lesion. Skull-based meningiomas are again very common lesions we call upon to treat. Tuberculum cellae, planum, suprasellar, and cavernous sinus meningiomas. This is a large suprasellar meningioma, tuberculum cellae meningioma, opening the Sylvian fissure deep and wide. And as you do that from the origin, next step is debulk the lesion maximally inside the tumor capsule, gently deliver the tumor capsule from the basal frontal region, and cut the capsule and debulk the lesion. Once you do that, immediately always keep a watch on anterior cerebral arteries on both sides, optic nerves and chiasm, and the opposite vessels. This is the picture what you get at the end of complete removal, and pituitary stalk is preserved in many of the cases because it will be pushed posteriorly and inferiorly, and that's a patient post-operatively well-preserved vision, and that's a scan post-operatively. Sometimes many times we need to achieve Simpson's type 1 excision. In these cases, again, the opening of the Sylvian fissure, Transcallosal, it helps us greatly to achieve this. And sometimes we need to do the optic nerve decompression and excise the lesion inside the optic canal and optic foramen. At the end, you bring in the endoscope and see how much tumor is left behind. So you need to decompress or dissect the circle of Willis from the surface of the tumor, and this is done. You can, I think it is. This video is not playing. I think we'll skip that. Something wrong. Yeah, that's fine. Cavernous sinus meningiomas again are very common lesions. You can see here that the video is not playing. Hello?
No, video is not playing.
Okay, some technical problem, I think.
Okay.
Okay, leave it off. I think I'll not waste time. Again, the same approach, the fronto-orbital zygomatic-temporal craniotomy and trans-sylvian approach. You can see the complete, the tumor there. And this is a post-operative complete excision of the tumor. Sylvian fissure epidermoid, I think I'll skip this again because what of time, maybe some problem, the thing is not playing. So take home message, Sylvian fissure is, I think, some problem.
Did you fall off the Zoom?
Sorry?
Did you fall off the Zoom?
No.
Okay, you're all done?
Last slide. Yeah, okay. I'll show the last
Okay, we'll
one.
continue. Yeah.
Yeah. So Sylvian fissure is a natural, convenient, comfortable, safe access to the skull base vital neurovascular structures. Detailed anatomical and physiological knowledge is a must for neurosurgeons. Dissection, opening the space is mandatory for all of us when you call ourselves the microsurgeons or skull-based surgeons. If you don't know how to open the Sylvian fissure and get the access, you cannot call yourself as a skull-based surgeon. Greatly helps in comprehensive management of critical neurosurgical pathologies and vastly reduces morbidities and mortalities to the patient, and who can give a good outcome. For this, our heartfelt thanks and tributes to the great master who gave us this pathway almost 60 years back until today, and even in future, in the eternity. As microneurosurgeons, we keep following this pathway to help our needy patients and make their lives comfortable and safe. We thank the master for his giving. Thank you very much for this opportunity to share and learn from each other. Thank you.
Thank you, Professor Suresh Dugani. Excellent talk and thorough journey, Sylvian fissure, and excellent cases you shared with us. Is there any question for Professor Dugani? Okay. It was very thorough. So thank you again, Professor Suresh.
Thank you.
Thank you.
Thank you very much.
Can we move to
Indeed, it's a
our
pleasure and honor. Thank you.
Can we move to our next speaker, Dr. Ravi Shankar from Uttar Pradesh, India, and he's going to share about Professor Yaşargil's life and lessons we learned from him.
Thank you,
Over to
Professor.
you.
Thank you, Professor Atta, for the invite. I think when we started, I was talking to Professor Samme, and I thank again Professor Samme for this invite also. So when I was talking to Professor Samme, we were discussing about some other thing to have a presentation on, but he told that we are organizing a memorial conference in respect of Professor Yasergil. So would you be able to speak something about that topic? So once I started preparing for this talk, words fell short. I really didn't had words to describe Professor Yasergil. Was there? If you start writing about him, you will fall short of words. So what I thought that I'll paint a picture of him. I'll start painting a picture for what he did for all neurosurgeons across the globe. And this is a very special picture that I loaned from Mr. Peter Lawrence. So this was a picture that he intended to give to him once he turned 100 at the Yasergil 100 conference. So again, in the same respect, I want to paint a picture. So how do we remember Yasergil for the coming generations? So how do we remember him for our coming generation, and how do we know about him? I'll try to paint a picture for him. So the whole story started in Turkey, in a small village in Lish when he was born. And this was very aptly described in the CNS memorial lecture that he was going to give in 1986, where he described that the village of Lish is famous for two things: That is the birthplace of Mahmud Gazi Yasergil, and that too, it is the site of great earthquake. We do not have evidence as to what was the cause and what was the effect, but I really don't think that was an earthquake that happened when Yaşargil took birth, but rather a volcano was formed at that time, which erupted later many years when he showed up how the neurosurgery can be taken up from there. And then the whole knowledge exploded from Yasergil, which we are still imbibing upon to learn the art and practice the art of neurosurgery. So again, for he was an very guy who had a dream. So from Turkey, he went to Switzerland, Basel, where he learned this residency. He did his neurosurgical residency under Professor Kranbull. And this is a slide that I have taken from Professor Spechler, that rather than being a diligent master in his later life, he was a diligent student to start off from. So you see, Professor Spechler in his talk was saying that I want a resident like him, standing diligently behind his mentor, learning the trade crafts from him. So the diligency started right from the time he was a student to later on when he became a master. So what we do remember Professor Yasergil for? We do remember him for whether he was a great neurosurgeon who advised the use of microneurosurgery, operating floating microscopes, operating principles, the operating charisma, the operating discipline that he had in ORs. Do we remember him for him that only, or for the simple instruments like tumor forceps, the bipolar that he took a cue from Professor Mallis and then started liking for him and then brought it into his practice, or the ubiquitous Leila retractors? So do we remember him for these instruments that he has described, or do we remember him for the simple approaches, or not so simple at that time, the Turel approach that he gave us, that has kind of become the workhorse for all the surgeries that we are doing in anterior, middle, and even posterior cranial fossas? So do we remember him for this only? Or do we remember, as Professor Dugani was telling about the Yasergil highway that he has given, the Sylvian fissure opening and unlocking whole of the brain, the anterior and middle cranial fossa, and then we can tackle upon all the pathologies that are there in the areas. For example, if you want to operate upon an MCA aneurysm, you have to open up the Sylvian fissure or the Yasergil highway and then have to kind of clip upon the aneurysm. If you don't open up that Sylvian fissure atraumatically, then you will not be able to anyhow reach upon these lesions. Or for the fact that the very clips that we are using in treating these aneurysms was again devised by him, which have kind of progressed over the period of time to now small clips, mini clips, very endoscopic clips, again like that. So do we remember him for that? The list goes on and on, on and on. Again, for the work that he has done on the subarachnoid spaces, the arachnoidal opening upon, and then reaching the various pathologies, or the arachnoidal pathway that we take to open up the various vasculatures, the anterior circulation, the posterior circulation, or for the fact that he was the first guy who did the STA-MCA bypass in year 1967, and which has kind of unraveled or unlocked the pathway for bypass surgeries in the brain. Or for the fact that he was a visionary to start off from, and then he gave that idea of not only doing an anterior temporal lobectomy and then going to hippocampus to remove it, rather than being very selective about it and then going through a trans-Sylvian route to have a trans-Sylvian selective amygdala hippocampectomy. So, or do we remember him for the fact that he was a brain surgeon? No, he was not a brain surgeon. The very standard microscopic lumbar discectomy that we do day in, day out was given by him. He was the first proponent to advise to do a lumbar PIVD through a microscopic route, or for the fact that he was the first one to operate upon a spinal angioma and take out completely, or for the fact that he did a telescoping surgery for thoracic pathologies. So he was not only a brain surgeon, he was an apt master spinal surgeon too. Or do we remember him for the fact that he conceived all his ideas in and book, and then give us this 6 volumes of microneurosurgery that we are still kind of I really, for the fact that I have not been able to imbibe all that knowledge that has been there in this 6 volumes. So you read it first time, you'll not be able to understand it. You go second time, third time, the knowledge will keep on powering upon you. So this was the contribution that he gives to us. And for all this work that he did, he became the man of the century, or the neurosurgeon of the century, which was given him from the Neurosurgery Journal, and from various accolades and all the things that were showered upon him from his home country, Turkey, or across the globe. Whenever he went, he was an kind of an hero for neurosurgeons, and everybody had a fanboy movement of him. We saw through many a masters, they were very kind of that was their moment of life when they took a picture of him. So he had those fanboys movement whenever he went across the globe. Many documentaries and books have been written upon him, and this has been kind of going in and out for him. So he was always and kind of a star wherever he went in the neurosurgery community, and he was followed upon, chased upon, to be taken a picture upon, to be taken an advice upon. But he also gave us various kind of philosophies, the secrets to practice the art of neurosurgery. So he said, the more I know, the more I see, the more I see, the more I know. So he was taking a cue from that. He devised the art of operative microneurosurgery under a microscope. And he used to tell that I don't only see through my eyes, those 10 fingers are my eyes. Whenever I am operating upon, these 10 fingers become my eye, and then I can really see upon the patients to do the best for them. Or he was a visionary to start off from, in this age of social media and everything, where we have kind of time which has become a constraint upon us. So he used to say, if you are practicing the art of neurosurgery, you have to just do neurosurgery. You have to give your whole life to it. Because he used to say, I save my memory. I don't learn anything useless. I am learning professional terms. I keep them in my mind. No junk food. He advocated the art of staying healthy, to have no tremors in hand. You have to stay healthy if you want to practice the art of neurosurgery, or keep the brain away from unnecessary information in order to keep it healthy. And for that, the underlying philosophy for the same was that medicine is art of saving and healing lives. The patients were the first and foremost thing that he always talked or was thinking about. And I am a middle grade neurosurgeon. I have juniors looking upon me, and I have seniors whom I look upon to. So I am a kind of a third tier neurosurgeons, and I have learned the trade craft from masters who have learned the trade craft in some or other way from Professor Yasergil only. So this presentation, I will also like to kind of bow my head in front of my teachers, who will always say that they learned the tradecraft from the master himself. And these are two kind of adages that I have taken upon. One is from my virtual master, Professor Lawton, who tells that you have to have your head, heart, hours, and hand in the right place if you want to learn the tradecraft and become a master of it. Or the 10,000 rule, which was many a times told us by Professor Hannes Nemi, that if you want to really become a master of anything that you want to do in life, you have to give 20,000 hours to it. You have to learn that tradecraft in 10,000 hours, then only you can become a master of it. Because for the fact that this is a slide which is very old, but again, this holds so apt, so true at this moment of time, that if I have seen further, it is by standing on the shoulder of giants. We as the neurosurgeons are very lucky that we have two generations of wisdom upon us. So I have the master Yaşargil, who taught the art to my teachers, who have given this art to me. So I have been very lucky. And this is a slide which was often kind of presented by Hannes Nemi. So this is very apt for me, for the fact that I have learned the tradecraft standing 2 steps behind Professor Yasergil. Professor Hannes Nemi learned the tradecraft from him, and I learned the tradecraft from Professor Hannes Nemi. So I have the wisdom of 2 generations on my shoulders to take this art from here on. This is also an kind of an obituary for the what I can always call the Zurich gang. who kind of developed the neurosurgery for us, Professor Yasergil, his favorite pupil, Vinko Dolenk, and one of his no, I can't say favorite pupil, but a pupil that he must have been proud of, Professor Harnes Nemi. So they kind of literally opened up the art of neurosurgery for us from their work, and we again kind of pay all our obituaries and condolences for they are not with us right now. But as Professor Anand told in his talk was that fact that we should be grateful, we should not be ungrateful for the fact that they are not with us. We should be grateful for the fact that they were sometimes with us. In the words of Professor Yasergil, what he condensed in about his kind of experience over the time was published in the journal Neurosurgery, and he published it with a memoirs, lessons, and axiom. And what was the main, I think, what I can say, what was the gift of Yasergil was unlocking this art of neurosurgery and making it from an not so beautiful larva to this beautiful butterfly. He transformed this whole art of neurosurgery from a larva to a butterfly, which we kind of realized day in, day out from seeing how it has grown from there to this beautiful thing. The beautiful subject of neurosurgery, the beautiful art of neurosurgery, the beautiful operative principles that we have. And if as a middle grade neurosurgeon in the middle, what advice do I imbibe from him and tell my younger neurosurgeons? It was published in the memoirs only when he tell that to younger generation, I wish courage and hard work to pass to higher levels. So he always wanted his pupils to do better than himself, achieve new heights and do better in the professional life that he kind of achieved from and that he has reached to. So Professor Mishra in his earlier talks was telling on a lighter note that any lecture of Professor Yasergil, if it was to be stated for 1 hour, used to go to 2-3 hours. So taking a cue from that, I will not have the last words and I'll leave
to say again, it is a teamwork. It is like in other surgery also. In the operating theater, we are maybe 6 to 10 people. But around the operating room, 20 to 30, with around, at least 50, 60 people are involved in every operating cases. The microsurgery is a small cavity surgery. We have to be accustomed to work in 2-3 millimeter space, like a dentist, also ENT people, ophthalmologists, and also brain surgery and spine surgery needs work in small cavities. I hope the young generation will learn one last word. For the preparation of the teamwork is essential that the scrub nurses, they should come on the operating theater, also in the laboratory, and train at least few weeks to learn themselves to dissect under microscope, to understand what is the problem of the surgeons. We are a big team. Team is very essential for neuroanesthesists. They're responsible to control all neurophysiological problems. Again, I hope you could listen and understand me what I'm talking. Thank you very much. Thank you.
Thank you, Master. Thank you for all that you have done for all the neurosurgeons. Thank you.
Thank you, Professor Ravi Shankar. Excellent talk. And any question, any comments? Please. Dr. Vinod, yes?
Okay. Okay, I thought we're gonna have to delay here. I have to change. I have to stop the YouTube and start another YouTube. So a 5-minute break. 5-minute break. Okay, just you stay here. We're not changing the Zoom. We're changing the YouTube. Just hang on 5 minutes.
Okay.
Okay.